Szanowni Państwo, wszystkich tych, którzy jeszcze są na korytarzu.
Ladies and gentlemen, if you are still out in the corridors, please take your seats in the lecturing room.
Message to all those who are still in the lobby. Why don't you please join us in the lecturing hall so that we can start the conference. Jeszcze raz przypominam, że
Once again, let me remind you that simultaneous interpretation is available to you. On channel 1 you will find Polish, channel 2 is for English, and channel 3 is French.
is available. Channel 1 is Polish, channel 2 is English, and channel 3 is French. Szanowni Państwo, już za chwilę rozpoczynamy konferencję. W większości przypadków
Ladies and gentlemen, this conference will be conducted mostly in English. Some of the messages will be read out or delivered in Polish, but like I said, simultaneous interpretation is available for you.
about to start the conference, it'll be held in English mostly. Some of the messages will be in Polish, but as I said, simultaneous interpretation is provided. Channel 1, Polish, Channel 2, English, and Channel 3, French. So, this time officially, I may say, good morning, ladies and gentlemen. It's my pleasure and honor to welcome you to the conference towards an EU action plan on rare diseases, national plans, and European cooperation. We are located in the main lecturing hall of the Medical University of Warsaw. I extend the warm words of welcome on behalf of the organizers of today's conference, the Ministry of Health of the Republic of Poland, and European Economic and Social Committee. The hosting institution is the Medical University of Warsaw, the second oldest university in Poland, ranked number 10 among Polish universities and ranked number 1 among Polish medical universities. We have a clinical center that comprises of numerous hospitals that are scattered around the city. We have a long record in treating rare diseases, but it's an honor for us to host Europe's most distinguished specialists in treatment of rare diseases. Ladies and gentlemen, please welcome and please give a warm hand to Minister Urszula Demkow, Undersecretary of State, Ministry of Health, Poland. Bajba Miltowicza, President of the Section for Transport, Energy, Infrastructure and Information Society, European Economic and Social Committee. Online is joining us Mr. Adam Jarubas, Chair of the European Parliament Committee on Public Health. He will have a message for us. And last but not least, Professor Rafał Krenke, His Magnificence Rector of the Medical University of Warsaw. And Your Magnificence, please do not sit down because the floor is yours.
Madam Minister, Madam President, Mr. Commissioner, Chair, dear participants and guests, it's both an honor and a privilege to welcome you all to this International Conference on Rare Diseases, which is organized by the Polish Ministry of Health and the European Economic and Social Committee within the framework of the Polish presidency of the Council of the European Union. I would like to convey my heartfelt gratitude to the Ministry of Health for choosing our Warsaw Medical University campus as a venue for this important event. We are thrilled to host this conference at our institution, and on behalf of our faculty, students, and staff, I am delighted to greet all the guests, speakers, and participants. And I also want to express our sincere appreciation for you for your involvement in this remarkable and very much needed initiative. Security in its various dimensions have been designated as a priority of the current Polish European Union presidency. Health security, with a particular focus on a patient's perspective, is one of these dimensions. In this context, it should be noted that rare diseases that affect millions or even hundreds of millions of people worldwide remain one of the most under-recognized and challenging areas in both medical research and patients' care. On the other hand, it must be admitted that important steps aimed at improving this situation have already been taken at both international and national levels. In 2020, a resolution of the European Parliament called for the development of an EU action plan for rare diseases. A year later, at the initiative of Parliament, a report was published recommending the integration of the European and national action plans in the field of rare diseases. Absolutely key actions at the operational level included the launch of the 24 European reference networks, ERNs, networks connecting healthcare professionals across Europe with expertise in rare disease, enabling to collaborate on research and make optimal decisions regarding patients' care. I mean, diagnostic and therapeutic approaches, even at the level of the individual patients. The networks cover the main clusters of rare, complex, and low prevalence disease, and importantly, the meeting of the coordinators of all 24 ERNs was held yesterday at our university. The conference that is just beginning will summarize the actions taken by the previous presidencies for the European Union plan in the field of rare diseases and will propose further steps before passing the baton to the next Danish and Cypriot presidencies. I'm confident that the discussions and collaboration that will take place over the next 2 days will lead to the meaningful progress in the field and add significantly to the previous achievements. Once again, I welcome you, and I wish you a fruitful and inspiring conference. Thank you.
Professor Rafał Kremke, Rector of the Medical University of Warsaw. And now a message from the Minister of Health, Mrs. Izabela Leszczyna. A letter will be read by Vice Minister, Mrs. Ursula Demkow, and the Secretary of State in the Ministry.
Ladies and gentlemen, dear colleagues, and dear patients, even the smallest one. On behalf of Madam Minister Izabela Leszczyna and myself, of course, I would like to welcome all participants of the Conference on Rare Diseases under the Polish presidency in EU Council. We aim to continue unified European effort undertaken in 2004 to foster the development of European strategy for rare diseases, especially to improve patient management, to strengthen cooperation between member states, to complement further legislation, and to stimulate investments. Let me now read the letter from Madam Minister Izabela Leszczyna addressed to all participants of the conference. Szanowni Państwo,
Ladies and gentlemen, thank you very much for the participation in the conference on rare diseases. In particular, I would like to convey my words of welcome to our foreign guests. Unfortunately, due to urgent professional duties, I cannot be here in person. Thank you very much for organizing this event as an element of actions to raise awareness in the area of rare diseases.
This still causes diagnostic problems and therapeutic difficulties, which is why this area requires constant involvement of professionals from different medical areas and decision makers. Regular meetings like this one are exceptional. We need to share knowledge, experience, and develop international collaboration. At the Ministry of Health, we continue activities to implement the plans for rare diseases for 2024 and 2025 aimed at introducing comprehensive solutions and facilitating the system of healthcare for patients with rare diseases. I want to thank all the experts and the patients, their families as well, for being involved in the execution of this rare diseases plan. I wish all of you much health and successes in your private and professional lives.
And I'm looking forward to have a fruitful and stimulating debate. Thank you very much.
Urszula Demkow, Under Secretary of State, Ministry of Health, and the message from the Minister Izabela Leszczyna. And now I give the floor to Bajba Miltowicza, President of the Section for Transport, Energy, Infrastructure, and the Information Society, European Economic and Social Committee.
Good morning. Madam Minister, Under Secretary of State, dear Rector, distinguished guests, and dear participants. I must admit that I feel moved because it's just 6 months since we met last time in Budapest in a Hungarian presidency event dedicated to rare diseases, and we talked about action plan and common efforts that we need to join to move forward this very important issue and help the patient organizations and help patients themselves. Now our committee, in collaboration with Polish Ministry of Health and Warsaw Medical University, welcomes you to continue our joint efforts to shape effective and comprehensive European strategy on rare disease. Let me also wish to the Minister well recovery, and please send the best wishes, because we are also thinking about your ministry recovery. Let me also mention that last week in the European Parliament hemicycle in Strasbourg, the collective voices of civil society, especially patient organizations, echoed very strong message through the members of the European Parliament, and we called for a European action plan for rare diseases. We are happy to see that our efforts are being fruitful and our voices are being heard more and more, and this time in European Parliament. I extend my gratitude to members of the European Parliament and member states and the European Commission for their dedicated efforts to work towards a unified European response to rare diseases. The conference will ensure that the momentum and political commitment built since 2004, with crucial contribution for EU member states, EU institutions, and civil society organizations, will translate into very concrete actions fostering the development of the comprehensive action plan for rare disease. Let me mention the main points, what we really need and how we address our main conclusions. We need common and measurable objectives that directly address unmet needs. We need to ensure equal opportunities for rare disease patients across all member states. We need additional measures to support health authorities at the national, regional, and local levels, as well as civil society organizations in their efforts to provide high quality and affordable care for rare disease patients. We need to introduce an effective horizontal coordination model for Commission services dealing with rare disease, cross-border healthcare. We need to encourage agreements with member states on the content, updating applications, and monitoring of national plans for rare disease. We also talk about collection and dissemination of best practices across the European Union. We need also guarantee financing and feasibility, ensuring the planning of EU health programs, namely like Horizon Europe, and other financial instruments, ensuring significant budgetary resources for the health in the upcoming 2028-2035 multi-annual financial framework. We need to give guidance and earmark funding for initiatives aimed at providing better access to diagnosis, care, and support for the patients and their families. We need to include targeted incentives mechanisms to promote research and innovation, particularly in the areas of disadvantaged, and also think about more advanced diagnostics and also medicine and gene therapy. The conference will be a crucial step in strengthening Europe's collective response to rare diseases by addressing gaps and challenges and highlighting the best practices and innovative solutions. And I look forward to today's discussion and conclusions, and I'm really looking forward from the stakeholders here in Poland, and I believe that together, and only together, all EU institutions and stakeholders, including civil society organizations, we will move forward EU-wide action plan, and we will be heard at the European Parliament and also Council level. Thank you so much, and wishing you a very good and fruitful day. And I'm happy to see many of stakeholders here today, since it was some time since we met last time. Thank you so much, and see you very soon.
Thank you very much, Bajba Miltovića, European Economic and Social Committee. And now it is time for a video message from Oliver Varhelyi, European Commissioner for Health and Animal Welfare.
Dear Minister, colleagues, ladies and gentlemen, many thanks to the Polish Minister of Health, our Polish hosts, and the European Economic and Social Committee, as well as the Medical University of Warsaw, for inviting me to speak. I'm very happy to see that Polish presidency is continuing the commitment to people living with a rare disease, following the events organized in Spain and Hungary. Up to 36 million people in Europe live with a rare disease. That's the population of Greece, Sweden, and Portugal together. To translate this, while rare diseases are rare, patients living with them are not rare at all. This 36 million people in the EU that may have to wait a long time for a diagnosis, that have difficulties accessing treatment if one is available at all. 79% of rare diseases still lack treatment. People should be able to access the best and most innovative treatments, no matter where in the EU they live. One of the most important actions here is the ongoing reform of the EU's pharmaceutical legislation and the Critical Medicines Act. Together, they will improve access to medicines, including for patients with rare diseases. The pharmaceutical reform promotes the development of treatments for rare diseases through regulatory incentives and free scientific advice from the European Medicines Agency. It addresses areas where there are no treatment options for patients. It also aims to facilitate faster patient access to innovative medicines and better affordability. This comes on top of the tremendous groundwork being done by the 24 European reference networks for rare, low prevalence and complex diseases. The European reference networks are unique because they allow the expertise to travel rather than the patients. The Commission has been continuously providing significant funding to these networks since 2017. This also includes Clinical Patient Management System, which is an IT platform that facilitates the cross-border discussion of rare clinical cases. We have now strengthened their work with the EU for Health funding worth 77.4 million euro, which will run until 2027. It is now high time for the implementation of these networks. Currently, the biggest challenge we are facing is that the potential of ERNs are not sufficiently deployed due to their low level of integration in the national healthcare systems. We have therefore launched the joint action, Jardin, for integrating these networks into national health systems. Another major area of action is research. Recently, we launched a 7-year European research partnership, ERDERA. It brings together 177 partners to advance research and innovation in rare diseases. The European health data space will be a catalyst for innovation in the next years. With the European health data space, we are creating a secure and interoperable environment to share health data. Researchers, industry leaders, and healthcare professionals will be able to work together in ways that are unprecedented. Accessing data securely to develop life-saving treatments and personalized medicine. For Europe, this means driving scientific breakthroughs, building a unified market for digital health, and delivering better diagnosis and treatments that improve people's lives. The European health data space can set up a new era of innovation that make ends meet for rare diseases. To make it a reality, we need to implement it now, together with the Member States. These actions and achievements are in line with our existing framework for rare diseases, the Commission communication on rare diseases, the respective Council recommendation, and the Cross-Border Healthcare Directive. While we may take further action in the future, we are focused on what we are doing now, making specific, targeted steps to help the lives of patients and families affected by rare diseases. I am committed to delivering a European Health Union that helps improve the health of our citizens, no matter where they live, no matter their disease or complex condition. With this, I want to thank the Polish presidency once again and wish you a successful event.
Oliver Varhelyi, European Commissioner for Health and Animal Welfare, a video message to the participants of the conference. And now online, Mr. Adam Jarubas, Chair of the European Parliament Committee on Public Health.
Dzień dobry.
Good morning. I want to welcome everyone very cordially. I hope that you can hear me well. Yes, we can hear you very well indeed. Thank you very much. I would like to thank very much the team of the Polish Presidency, the Ministry of Health, the European Economic and Social Committee, and the hosts of the venue, Warsaw University of Medicine, for the organization of this important debate. And I'm very glad that as the chair of the first standing legislative committee in the European Parliament, the SANTE committee, I can speak to you today. The efforts for rare diseases taken up by you are also seen from Brussels. A moment ago, we heard the words of Commissioner Olivier Varhelyi. 2 weeks ago, we also had an opportunity in the European Parliament in Strasbourg to organize quite a hot parliamentary debate that was devoted to the subject of rare diseases. It doesn't really happen very frequently in the European Parliament that it was bipartisan and all the political groups stressed the significance of the need to build common European approach to the subject. In the European Parliament during the debate, we also remember that the communication of the Commission on rare diseases, as well as the recommendations of the Commission to this extent, as well as the European legal frameworks of the trans-border healthcare. Commissioner Varhelyi stressed the significance of 24 European reference networks that bring together service providers, researchers, patients' organizations from all over Europe that take advantage of the state-of-the-art knowledge in the area of patients' care. The Commissioner was right to note that the European reference networks constitute an exceptional example of the European solidarity and innovation, and an example of a common action that creates results and creates an opportunity for the life-saving knowledge to follow the patient and not patient to chase knowledge. We know that the health-related competencies in the European Union are vested on member states, but according to the treaty, the European Union complement them as well as coordinate them. That is why it is so very important to note the national actions plan that are also coordinated by the European Union. The Union wants to follow those plans and support them. Commissioner Varhelyi noted also the significance of a very dynamic pharmaceutical biotechnology sector, as well as medical devices in the European Union to fight against rare diseases. And he also announced that next year there will be a special biotechnological act presented, and it will help scientists to transfer the medical therapeutic solutions from the laboratory to the manufacturing sector, as well as to the market. This legal act is to help us to create a very dynamic biotechnological sector in the European Union that will bring about the development of new personalized medicine. We have to know that for the last 25 years, the European Union supported the research on rare diseases with the amount of over 5.2 billion euros. And recently, the next 7-year-long European Rare Diseases Research Alliance was inaugurated. When I participated in the plenary debate last week devoted to the need of having European action plan, I stressed several aspects. First of all, the fact that patients should be in the center of our attention. We know that rare diseases hit many citizens of the European Union, and only 6% of them have any therapeutic options, and there are differences between different member states. These diseases are different, especially when we compare it with other diseases, but it's about the tragedies of patients and their families, and long-term diagnosis process, on average 7 years long, sometimes no therapies or vain therapies. Rare diseases is also the area where free market does not act successfully, because there are very few cases, little data, and low scale does not really allow for the return on investment, which makes the therapies very expensive. That is why a response to them can be Europe and our common approach. The pandemic showed that when we cooperate, we are more effective than when we compete with each other, fighting for limited resources, raising prices. The pandemic created a bottom-up grassroots support for the European involvement in healthcare, and we cannot really waste social expectations and hopes. Together in the European Union, we can also research a greater number of cases, allowing for more effective development of new therapies. We definitely have to count on the European health data space. And I would like to refer now to the Polish presidency, because the work on this document was completed during the Polish presidency. The greater unified pool of data may allow for the better use of AI for the therapies research, as well as the optimization of the healthcare resources. We have to coordinate it better, and we have to strengthen reference networks in the European Union for medical doctors and researchers to be able to share knowledge about diseases cases, which we hope will facilitate and speed up diagnostics, as well as the selection of the right therapies. The key thing is the adoption of the European standards of screening tests, also of neonates. European standards, education of medical professionals, coordination and cooperation of medical doctors and researchers under European reference networks may bring the current geographical random selection actually to an end. Because sometimes it's actually a pure chance whether you're able to find a doctor who can treat you successfully. We have to facilitate, improve trans-border healthcare in the European Union by integrating it with the European reference networks using the European health data space. It will be absolutely crucial to provide for the right financing under multi-annual financial frameworks. That is why we are really making efforts to make sure that there is the greatest amount of money in the EU for health or in the missions of the Horizon program, but perhaps also in the funds of the cohesion policy or digitization. Sometimes skyrocketing cost of treatments, the reality of public collections for the treatment of patients, including children, may be decreased by the use of the European order of magnitude orders, purchases in the European Union, which we have proposed in the Act on Critical Drugs by the European Union. There are also works underway on pharmaceutical package, and here there are also solutions that are to stimulate the development and availability of drugs for rare diseases. We are now waiting for the completion of works in the Council as well as the beginning of the trialogue. As the Parliament, we are prepared for this debate, and it has been the case already since April when we adopted the parliamentary approach. And under the Health Committee that has been in place since January, I have to say that rare diseases is one of the crucial, the most frequently raised questions. On the 31st of March, we finished public consultations which were initiated together with the Rare Diseases Day of 2025, and they targeted in particular patients, caregivers of patients with rare diseases, scientists and medical professionals. Over 4,000 participants of this study represented all the European member states, including 65% of individual patients. The next 10% of the participants are patient organizations. 22% of responses were provided by healthcare professionals in the area of rare diseases. We hope that the results will be presented very soon during the meeting of the Santa Committee meeting, and they will constitute the basis for further work in the committee as well as in the Commission and the Council. And we hope that we will be able to help to prepare good programs in the area of rare diseases. Europe can give a significant added value by supporting member states. Thank you very much, and I would like to send to you my very warm greetings.
Bardzo serdecznie dziękujemy, panie przewodniczący. Adam Jarubas, Chair of the European Parliament's Committee on Public Health. I czas na pierwszy panel, szanowni państwo. Pierwszy panel, pierwsza sesja towards an EU action plan on rare diseases, national plans and European cooperation, state of play and future actions. This session will be moderated by Mr. Enrique Terol, Health Councillor, Permanent Representation of Spain.
And despite many efforts, and many of you here have been doing that for many years, still we are having problem with the access to timely diagnosis, treatment, and coordinated care. And that remains far from equitable, and still very significantly between countries and within countries. And that's something that national plans have been addressing since that started in, I would say, 2006, 2007. But we need to make something more. The European Commission had a very important role during, from 2004, I would say, until 2017, working on rare diseases and creating a real environment that facilitated the development of national plans. Also, of course, the European Reference Networks launched in 2017, that was a huge step forward. But now we need again to rebuild this institutional cooperation. Because, as we all know, national efforts alone are not enough. And today we will reflect on how these national plans, in some cases, have evolved in different EU countries, and we will learn about their achievements, their challenges, and also the lessons they have learned and the gaps they are finding when they are evaluating the strategies. So, and more importantly, we will explore how we can scale up cooperation at European level. It seems that it's the time to ripe for an EU-wide action plan on rare diseases, an action plan that has been insistently requested by patients, by families, by health professionals, and the Council, the presidencies of the Council, the European Parliament that has been presented, and the European Social and Economic Committee have institutionally made the same request. What will it look like, a European EU plan, action plan for rare diseases? We need to discuss that. We need to learn from this presentation, what do you think on which should be the elements that should include and how that will be integrated in the national plans. We are very fortunate today because we have 4 distinguished speakers from Poland, from France, from Czech Republic, and from the European Commission who will share their insights and proposals. Please, I will invite the first speaker, which is Minister Ursula Demkov. Minister Ursula Demkov, she has an important background in this area, not only as institutionally representative, but also at professional levels since many years ago. She supervised in the Ministry of Health several departments, including healthcare policy on rare diseases. And she has been a professor of medical science with a specialization in internal medicine, immunology, allergology, and diagnostics. And she heads currently the Department of Laboratory Diagnostics and Clinical Immunology at the Medical University of Warsaw. She is a recognized expert with the European Commission experience in evaluating research projects, and she has been involved in many scientific societies and was past editor of the Central European Journal of Immunology, area very much related with rare diseases, as you all very well know. And she will present us the main elements of the Poland's national strategy on rare diseases. So, Ursula, please, you have the floor.
Thank you very much, and can I have my slides? Yes, thank you. I don't know how to do. Maybe I can borrow your mic. Thank you very much, because otherwise I don't see. Raz, dwa. Okay. It works. I should stand like this because otherwise I don't see my slides. I did it. Okay. Okay. I did it, so I know what there is, but still I would prefer to look at them. Let me present our successes and our failure and gaps related to National Plan for Rare Diseases of Poland, 2024-2025. Next slide, please. First of all, we are all aware about the challenges related to rare diseases and what we would like to assure for our patients is to fast, innovative and reliable diagnostics, the best possible medical care and holistic support for every patient regardless of the rarity of their disease. A comprehensive integrative approach to rare diseases, including, apart from just medical care, should include education, research, prevention, diagnosis and care, treatment, social support, and also inclusion. National Plan for Rare Diseases is composed from 6 tasks. The first task is to establish, we should establish new rare disease centers of expertise to cover main clusters of rare and complex diseases. Also, we would like to improve access to diagnostic tests, increase availability of medicine and foods for particular use. We also to 3 digital tools, Polish Rare Disease Registry, Rare Disease Patient Card, and information platform developing and disseminating the knowledge about rare diseases. And let me shortly present every task. New rare disease research centers of expertise. Currently, we have 44 research centers of expertise in 23 hospitals. All belongs to ERNs. We plan first to establish further further centers of expertise. First, outside of European network, to provide patients with a specific care for a disease or group of diseases, with access to diagnostics and highly specialized and coordinated care. And among those, if possible, is still the process of new ERNs inclusion in European network. Some of them will apply and undergo the process to become ERNs in the future. Currently, the Rare Disease Council is working on elaborating both substantive and formal criteria to qualify the medical centers as a center of expertise. And then this integrated care assures that the patient will obtain coordinated care, and it avoid the situation where the care is fragmented. What is the crucial part of the plan is to implement the new financing solution to assure sustainability of new expert centers, and we have already implemented new financial mechanism aimed at covering the high cost of rare disease patient management, especially expensive and sophisticated diagnostic tests, as well as the cost of the patient's stay in the hospital or getting help in outpatient manner. And the cost of analysis was carried out in the cooperation of with the Agency for Health Technology Assessment and National Health Fund. And those 2 organizations, they are first pricing, and they are reimbursing those procedures. Then the next task of the plan is to improve diagnostic to improve diagnostics, and then we plan establish and finance new certified laboratories, providing a patient with complicated, innovative, sophisticated diagnostic tests, including gene panels, microarrays, exome sequencing, also transcriptomics, metabolomics, proteomics, sometimes supplemented with functional study to support the causality of a putative variant and to understand molecular mechanism of rare disease. As you see on the slide, you know the metabolism of a cell is very complicated. You see how many metabolic and signaling pathways we have in the cell inside. And then sometimes the diagnostic is like looking for the needle in the haystack, and then you can imagine, for those who are not expert, how difficult and how hard the process is. The next task is to improve access to drugs, medical devices, and foodstuff for rare diseases. And then we are still work on registration of innovative medicine, but also we want to improve the access of our patient of the drugs being in the clinical trials before marketing authorization and before obtaining reimbursement for public funds. Moreover, we work together with the whole Europe to introduce legislative changes which will enable the implementation of newly registered drugs and technology into the European and Polish reimbursement system. Well, sorry, I don't know what it was. Okay, we continue. And then 3 important digital tools. First of all, we work on implementation of Polish Registry of Rare Diseases. First of all, we want to implement and assure widespread coding with ORFA code, what is very crucial for rare diseases. We want to prepare the complete identification of patients with rare disease, properly define the sources of information about patient, and refine logistics of obtaining data to assure completeness of the data. Also, we also have expert teams which are very active and they can develop, interpret, and support the use of the data. Of course, we have to introduce appropriate authorization in the provision of law, assure stable financing, and make the data searchable, findable, and easy to use. And also what I would like to underline that we want to establish the Polish Rare Disease Registry with the accordance with fair principles, and the registry should be interoperable with other EU databases and registries within the European health data space, what I consider as very important. Every patient will get the patient card, which will be kept in electronic form and integrated with the individual patient account, which is EHR, like in Poland we call it IKP. Then the card will store personal data, ORFA code or ACD-10 code, and possibly OMIM if it's fundable. A recommendation and the indication for the patient, contraindication for the patient, and emergency access. And the last is what is already working. This is a rare disease information platform for patients with rare disease, their families, patient organization, doctors, and other healthcare workers who need such advanced knowledge. For medical students, teachers, especially in special education, teachers who deal with children with special needs, and also as outreach for general public. Thank you very much.
Thank you, Minister. I think that you have explained an impressive description of your national plan. Now let me ask you a short question. Under all the development you are foreseeing and organizing, which are for you the main achievements so far? And how do you think the role of European cooperation will help in addressing the remaining challenges?
Okay, thank you very much. Thank you for this question. It is very important questions, and I think that the highest value of our plan is its complexity. Because usually, and in Poland as well, the care of patient since the first symptoms and signs occur till the diagnosis is made and the treatment is introduced, this pathway of patient and this travel through the healthcare system is very fragmented, and patient undergo so-called diagnostic odyssey, and then they are lost in the system, especially if they have problem with multi-organ diseases. And therefore, I think that such a complex approach, combining all the basic, at least, elements which are necessary to coordinate the patient care in all possible aspects, of course, maybe not all, but all basic, we are still ready to learn and to implement the second and third and the next version of the plan. So I think that we have the good basis to start to look at the patient in a holistic way, not only from the specific point of view, but we should look at the patient also at every patient by himself or herself, but also from top down, from the resources of the whole system. And I think that my highest achievement is to get the good financing of the plan, because the money assures that the plan will survive, and then the plan sustains. So I think this is important. And I'm also ready to listen the experience of experts from other countries who are more advanced in the management of patients with rare diseases. We will learn from you. We will learn from your successes, but also from your failure. And we want to fulfill the gaps which we have in patient care in Poland. Thank you very much.
Thank you very much, Madam Minister. I think, as you said, money always helps, and we should also ensure that money is in the, as it was mentioned by Barbia from the Social Economic Committee, that it's also in the multi-annual financial framework that will be crucial for the maintenance of the European Action Plan, for the networks, etc. So thank you very much. And now I have the privilege to introduce my dear colleague, where is she? Anne-Sophie Lapointe. Anne-Sophie has been personally touched by rare diseases through her own family and has transformed her personal experience in policy changes, policy activities, and she has been involved in many different areas related with rare diseases patients. In 2018, I think, you joined the Ministry of Health, and now she is responsible and coordinating the national strategy on rare diseases, which is, I would say, the new one. It's the third one or the fourth one. So France is one of the countries with more experience on rare diseases, and I think that it's important to learn from what they have learned in this evaluation of the last strategy, and also to see how that can be included. And for that, Anne-Sophie has also a very important role in the different actions that are now running at European level. There are the European reference networks, the Joint Action Jardin, etc. So you have the floor, Anne-Sophie. You can talk from here.
Thank you. Thank you for the invitation, and Ursula, thank you for your very nice talk. You have the very good foundation to have a rare disease policy, very useful, and thank you for this. I just wanted to try to explain why we had a fourth national plan and why it's important to have still a process with several plans. It's important to have assessments, and for our plan, we need we work at healthcare system, but also with the research system. So it's something that we want to evolve continually with a virtuous circle. For the first national plan, it was 20 years ago. It was important to have strong visibility where the experts for the rare disease are. It was important for the doctors, but very important for the patient. It was very important also to have after an assessment of the first plan and to have after to design for each plan a very coherent plan. And it was for the second plan, the importance to the given to the coordination. We have the expert centers, but we needed to have a national coordination. And it was the launch of the National Hub for Rare Disease. We have 23 National Hub for Rare Disease, and it was very, very important. And in the third national plan, we have a very important level around the data and the question of the dissemination of the data and the dissemination of the visibility and all the things around training. So for the first national point, it was this recognition of and the management of rare disease. For this, it's really important to have strong labelization with criteria. I work about this subject with Luca in Italy, and we have strong criteria with for the amount of the patients seen by the expert centers, but also the research part. It's important to have involvement in research at high level and at national level. It's also, for us, it's a strong criteria, and usually it's the most difficult to have. So this was very important to have strong labelization. So it's the first plan. The second plan, it's also the beginning with the work in the 2011 with the cross-border healthcare and all the reflection with the future launch with the ERNs. So it was also the beginning with strong cooperation, and for us in France, it was the beginning of our national registry for rare disease. It was 10 years ago, and it was really important for the foundation for the rare disease policy. So the second plan, national hub and strong national rare disease for registries. In the third national plan, it was also all around the data and the spread of the reuse of the data. It was very important to structure our national rare disease platform for the data, and it was very important also to have our 23 national hubs. They help a lot to achieve all the action of the third national plan. For us, at the ministry, we are very close with these physicians and doctors involved in the rare disease field, and I think it's our success because we are a multidisciplinary team with the patient in center and with the ministry. It's a strong also support from the ministry and for the different ministries. And the fourth national plan, it's now, we have to be close with the European part. It's really important. We were already involved for more than 20 years. Figures like Yann Lecam with URDIS, Ségolène Aimé with Orphanet. It was long time ago. They were the precursor of our work. But now with our fourth national plan, because we have a strong national policy, we can work with the European part more easily. It's really important to have the good foundations. So my message today is that we need to have national plan if we want to have a European plan. We need to have clear foundation, and I already said thank you for the Polish work, because it's very, very well structured, very well organized, and I think it will be the good foundation for the work at the European level and together, and at the policy level and with the reference center. It's very, very important. So I work a lot with the Jordan project and with the data management, and I think it's really important because we will have expert centers, because we have national strategy for the data, so after we can share our data at the European level and to have area registries. And I talk about healthcare, but we have also to work closely with RDA, and I think it's very important. We have mirror group with RDA and Jardin in France, and I think it's already important to have mirror group in all the 27 European countries, because it's to organize the health and the research between national country and the European country.
Thank you very much, Anne-Sophie. I think that probably all your experience on your national plans will be very useful for the rest of the European Union member states. So you have named some of the main conclusion, the main recommendation to be included in an EU action plan. But if you should select the most important one, what should be the foundation of the EU action plan on rare diseases?
Alors, the foundation, one national plan. I think it's really important that the 27 national plan have good, the European country have national plan, because it's the foundation for European plan for rare disease. It's not in the contrary. I think it's the foundation, so it's my first message. The second message is to be close with RDA project, because it's health and research, and they are lucky because with RDA, I think they have a research, European research plan for rare disease. That's why we want to have the same for the health, because for us it's really important to be aligned and in mirror. And the key message is also you have to organize the reuse of the data. So you have the data will be key in next years. It will be key in the future, and the reuse of the data, for me, it's more important. And for this, for a European action plan, I think it's really important because we can increase ethical questions. It will increase autonomy for the patient, good informed consent, etc., etc. It will increase also the link with all the EU legislation. We need a European action plan because we need to work very closely with all the EU legislation. For example, data and pharmaceutical medical devices legislation, or the European health data space. And it's why we need the European plan, not for the money, but more for the policy aspect, because we need, after 2028, to have still strong policy at the European level.
Thank you very much, Anne-Sophie. If I can take a message from your presentation, so what we need is to put together what we know, the different actions in a meaningful way, with goals, with clear analysis of and evaluation of the national and European action plan. So thank you very much, Anne-Sophie, again. And now we have Martina Brzrockova, who will join us online. Here we have Martina. Martina, good morning. You can hear us?
Good morning, Enrique. Can you hear me well?
Okay, excellent. Martina works at the Czech Ministry of Health, and she is now responsible in the Ministry of Health for the development and evaluation of the rare diseases activities developed by Czech Republic, in concrete the national plan, and also for the substance of human origin. She has been working, she's a colleague actually, it's my colleague. She has been working in the Council as representative of the Czech Republic in the European Council as health attaché for many years. And now with this experience, and I think that's fundamental, she's coming back at national level and is organizing this national plan, but also with the view of the European Union impact. So Martina will present us the work they are developing towards a second Czech national strategy on rare diseases. You have the floor, Martina.
Thank you very much. And I will now try to share my presentation. Can you see it well?
No, not so far. So we will try. Now it's starting.
Okay. So first, ladies and gentlemen, let me thank the organizers for inviting the Czech Republic and to have the possibility to share the experience of our past. It's an honor to speak with you today and to share the situation regarding the rare diseases in the Czech Republic. I would like to briefly introduce our journey towards the development of the second national strategy on rare diseases, which is currently in progress. So to understand the full context, we must return to the first Czech presidency of the Council of the European Union, which took place in 2009. Sorry, can you hear me well? Because I have here now the message that something went wrong.
No, we can see your presentation. So the presentation is on the TRIO program, so then no problem.
Okay, so during our first Czech presidency of the Council of the European Union in 2009, as a part of TRIO presidency together with France and Sweden, our joint program included work on the forthcoming proposal for a directive on cross-border healthcare, which actually set the possibility for the European reference networks. And the topic of rare diseases was also explicitly mentioned as a key focus area. One of the key outcomes of our first presidency was the adoption of the Council recommendation on an action in the field of rare diseases, which continues to serve as a valuable framework to this day. In 2010, the Czech government adopted its first national strategy for rare diseases, spanning the following decade. Its objectives were to improve diagnosis and treatment, raise awareness, and strengthen international cooperation. In terms of care, several healthcare facilities joined the European reference networks and actually became highly specialized centers that have been established. Today we host 22 out of 24 ERNs. Also, as part of the first Czech strategy, we organized many workshops for medical students to raise awareness, but somehow the integration into formal curricula remained limited. What was important, that the patient organizations played a crucial role in enhancing the communication between patients and healthcare providers, Also, scientific collaboration and data collection were enforced, including the implementation of ORFA codes for more precise disease classification. After the strategy was ended, we made an assessment, and despite notable progress, we must have admitted that challenges remained, such as lengthy drug reimbursement procedures, the need for more comprehensive systemic support for patients. But nevertheless, this strategy demonstrated that centralized care, European cooperation, and the active involvement of patient organizations are fundamental. And now we come to our second presidency of the Council of the EU in 2022, which unfortunately was still marked by the aftermath of the pandemic. So the topic of rare diseases was not included in the trio presidency program, but nevertheless, it remained national priority for Czech Republic. So that's why in October 2022, we hosted an expert conference on rare diseases in Prague with the goal of promoting more structured European coordination. The conference culminated in a call to action highlighting 5 key recommendations that now serve as a foundation for potential European action plan on rare diseases. And now, ladies and gentlemen, we come to the present. Since January this year, we initiated preparations for the second national strategy for rare diseases, covering the period 2026 to 2035. This initiative is being led by the Ministry of Health in very close collaboration with healthcare professionals and patient organizations. And here I would like to present 4 intended pillars of the strategy that we are currently discussing. The first should focus on patient-centered care.
Sorry,
which,
Martina, sorry for interrupting you. You have to pass the next slide.
Active involvement of patients and their families in decision-making and the provision of care, ensuring access to clear information and support for both patients and their families, and provided...
Do you hear us?
Provided...
Presentation stopped. You need to stop sharing presentation, remember the slide, and start the presentation again.
Now.
Because something broke.
Okay. I will try it. Yes. Now I hope you can see again.
Yes, okay. Perfect. Now we can see it.
Still things to make it better, right? So, first pillar on patient-centered care. So, active involvement of patients and their families in decision-making and provision of care, ensuring access to clear information and support for both patients and their families, and providing integrated barrier-free care across the entire system. The second pillar, effective and high-quality healthcare, involves centralizing care to promote specialization and operational efficiency, introducing modern procedures and technologies, and enhancing data collection, management, and accessibility to support evidence-based care. The third pillar covers education and competence development, which means to strengthen the knowledge and skills of healthcare professionals, foster international collaboration and scientific research, and expand educational and training opportunities across all levels of the healthcare system. And the last pillar on strengthening coordination focuses on increasing the efficiency of healthcare system through improved coordination and strategic planning. And here we are discussing to introduce new position into the system, coordinator of care, which we currently lack. And also part of this pillar could be strengthening the connection between healthcare and social services to ensure more holistic patient support. So as a disclaimer, all 4 areas are tentative and under discussion, but these are the directions that we would like to go and currently discuss to set the measurable criteria to be able to assess it along the way and after it will finish. What I would like to stress that the European dimension is integral to the strategy and intersects with all 4 pillars. We are following closely the progress made under the Joint Action Jargon, in which the Czech Republic is active participant. And what is also clear to us that it's essential that the national strategy be legitimate, realistic, and supported by a long-term expert consensus. So for this reason, as a Ministry of Health, fully supports this initiative and strongly encourages the participation of professionals, patient organizations, and all relevant stakeholders in both the development and implementation of the strategy. We are fully aware that not all challenges we can resolve immediately, but the idea is to establish sustainable processes that we believe we can make steady progress and ultimately achieve our shared goals. So thank you for your attention. It's all from my side.
So thank you very much, Martina, and thank you for your insight on how you are addressing the next strategy, because I think there are solid pillars for that. May I ask you, how do you think EU-wide action plan provide the greatest benefit to the Czech Republic and to their strategy? Martina?
Yes, the greatest benefit to the Czech Republic and to the strategy. As a reflection of the debate we are currently having, we think the key aspects is to provide the expert guidance and the expert framework and also financial resources, because the changes to the healthcare system are always long-term projects and they require strong political backup, sustained focus regardless of the current circumstances, and the progress must be made step by step, not to shatter the system in different parts. So it also might be different in different member states according to national context. But the common framework would unify the efforts and help to avoid duplicities, and maybe from the point of view of the political backup that I mentioned, that to have it on the EU level maybe would be a little bit more neutral, not so involved on the national level changes. So I think it's perceived also by other member states in a similar way, because the call to have the EU action plan from different member states have been a recurring topic in recent presidencies, and also what was mentioned here today and what we saw last week at the plenary of the European Parliament, that there are also more voices.
Thank you very much, Martina. I think that from your presentation, I think that we can get a main message, is that doing things together and learning from each other is fundamental, and for that EU action plan will be a core element also to align goals and to align also the lesson learned. No? So thank you very much again, and a big applause for you. So So, and now, finally, we have our last speaker, which is, who is Donata Meroni. Donata Meroni, my dear friend, she has been working in relation with the rare diseases and the European reference network since many years ago. She now is head of unit at DG Santé in the European Commission, and she is leading the work on health monitoring and networks, including rare diseases and cross-border healthcare. She has an extensive experience across public health and EU funding instruments. Actually, she was before in the previous agency, as now is HADEA. It was CHAFEA before, and she was responsible also on working with the European reference networks and giving them the support for their work. So we are having a lot of hopes on the European Commission. We know that all the eyes are looking at you, so don't be nervous. And go ahead. You have the floor.
Dzień dobry to, Dzień dobry to everyone. So I would like, first of all, to thank the Polish presidency and the European Economic Social Committee for hosting, organizing this important conference, and the University of Medicine, which allow us to be in a beautiful room. Dear hosts, esteemed guests, experts, and colleagues, I'm pleased to address you today on such an important topics. One with which the EU has long recognized the importance of. In the EU, as it was repeated several times, we estimate that there are around 36 million people living with a rare disease. So, while rare diseases are rare, patients living with rare diseases are not. That's why the Commission has been active in addressing rare diseases for many years now, for over 3 decades. A strong European health union helps to improve the health of our citizens. This was the message passed by our Commissioner. No matter where the citizens live, no matter their disease or complex condition. Our work on rare diseases is underpinned by a strong EU framework based on the Commission communication rare diseases, based on the Council recommendation on action in the field of rare diseases, based on the cross-border healthcare directive and all the legislation concerning ERNs. Yeah, I think that is better to change. Sorry, this is, okay, yes, the beauty of the director. Yeah. On this strong foundation, the Commission is supporting Member States through targeting on concrete actions that can make a real difference for rare disease patients. You can see on this slide the broad, multi-phased panorama of the EU action in the field of rare diseases. It covers research activities, the EU platform for rare disease registries, the European reference networks on rare diseases, supporting the orphanet, and legislation on pharmaceutical, medical devices, and European health data space. Most of these actions will be discussed in depth in other panels of this conference. I would like to focus on the 24 European reference networks, because they are a truly European success story. They bring together knowledge of healthcare professionals, researchers, patient organizations from across Europe to leverage the collective expertise for patients' care. The European reference networks are unique in that they are a prime example of European solidarity and innovation, allowing the expertise to travel rather than patients. We have now, from the Commission, strengthened their work with EU for Health funding, with direct grant worth in 77.4 million euros, which we run until 2027. Now, I would like briefly to highlight what the ERNs do, just to explain their activities. They do virtual discussion, and to date, more than 4,000 patients' cases have been examined using the new IT platform, the telemedicine, specifically created to support the work of these networks. We call Clinical Patient Management System, CPMS, this is an acronym, which has been recently revamped. Another important part of the work is the patient registries. Currently, there are more than 90,000 patients registered in the registries of the ERNs. This is important for the secondary use of their data. This is fundamental for research and development of new treatments. Again, a lot of important part of the activity is training and education activities. A plethora of activities on training have been initiated by the ERNs to share and generate knowledge, to create a new generation of health professionals specialized in rare diseases. Again, we have a clinical practice guideline development. More than 400 guidelines have been published by the ERNs, which will guide health professionals in diagnosis and treatment of rare diseases. And then we mention coordination. This is the main work, of coordination. The networks continue with a network size ranging from 40 to 105 members. And I would like also to mention the support to Ukraine in rare diseases to develop a network also in Ukraine. And I'm pleased to announce that recently we have started consultation between the ERNs and the Ukrainian hub on rare diseases on CPMS. So this is a very good achievement. Sorry for my voice. Today, the primary challenge is that the potential, as mentioned by our commissioner, the potential of European reference network is not fully realized because they are not yet well integrated into national healthcare systems. We realize that still too many health professionals don't know about the existence of the ERNs, and many patients cannot go up to them through the national networks. So we have therefore launched a joint action, so an action jointly between the Commission and the Member States, and it's called Jardin, to integrate these networks into national healthcare system with an additional 18 million euros until 2027. This action is exceptional because it sees the participation of all 27 member states, plus Norway, plus Ukraine. So this is also a good sign of interest. Joint action promotes the development of national plans for rare diseases. We were discussing about patients' pathways from how the patient can reach the ERNs from the GP. And it brings together all stakeholders in rare diseases and will be pivotal in shaping union policies and supporting member states. What's next now? So, as you can see, EU action is unstoppable, as we say. We will go on this year, but also in the years to come. So, rare diseases will stay a priority for the European Commission. I have already mentioned the ongoing work of the Joint Action Jardin. the result of this joint action will help to shape future actions for rare diseases. Again, another action is widening the use of the IT tool, CPMS 2.0, which was launched at the end of 2024. Now all ERNs, in a couple of months, they have already migrated and they are actively using this tool and working also with Ukraine, as I said. In the future, this important telemedicine study funded by the EU can be used by other health networks, not only for rare diseases, but it will be available also for other diseases at national level, and it is planned to be distributed under an open source license. Again, we work actively on the pharma reform to promote orphan medicine, and especially this is a very important activity. It will be illustrated later on during this conference. And we are working on the implementation of the European Health Data Space. You know that the new regulation has just been adopted was adopted on 21st of January, and now this is the momentum for its implementation. And we associate for rare diseases the work on registries, which is of paramount importance. We are also working to improve access to all ERNs from all member states and disease to increase the coverage, the coverage by the ERNs, to allow all patients to have access to ERNs, and also to broaden the rare diseases covered and dealt by the ERNs. And again, we are working also to simplify, to streamline the work of the ERNs, for instance, to simplify the procedure for the evaluation, and most importantly also to create, as I mentioned before and mentioned also by other speakers, on education, to create a new generation of health professionals specialized in rare diseases through, for instance, the Erasmus Plus program, and develop ad hoc curriculum at EU level in order to provide medical students with opportunities to acquire specialist knowledge in rare diseases. And finally, it is not last but not least, I mentioned Erdera. I think tomorrow we will have the possibility to to understand better this huge action on research on rare diseases. So we have been hearing the call for a EU action plan for a while, but we are convinced that we need to communicate more and better on the already ongoing actions that exist in Europe for rare diseases. And that's why we have produced, for instance, recently, in occasion of Rare Disease Day 2025, a booklet on the success stories of ERNs, what the ERNs have achieved so far. I invite you to read online on the website of the Commission, and I brought a few copies. They are outside in English, but this booklet will be translated in all European languages, because this is really a success of for all EU patients. And we have also produced the fact sheet, 4 pages or 3 pages, just to explain the ongoing action, what has been achieved in 2024 for rare diseases, and how we work at EU level. Yes, I think that this is also going local, and we have organized more than 10 workshops in the EU countries, one also in Warsaw, in Poland, to explain to the patient's right under the cross-border directive, and also for European Reference Network for Rare Diseases. So we are here together, and the EU is committed to delivering European Health Union that helps improving the health of our citizens, no matter where they live, no matter their diseases, complex condition. today's discussion shows that we are stronger. We share strong commitment to improving the quality of life of people with rare diseases. And let's continue together this important work.
Thank you very much, Donata. I mean, it's impressive how many things has been done and are already ongoing. So taking the words of Anne-Sophie, I will say that probably, I mean, of course, having more money is always very nice, and we can develop more. But I will say that now it's not exactly an issue of having funding, but an issue of sharing common goals and having a shared analysis on where we should go on rare diseases along with the national plans and having a common evaluation. So related with this, with the call to have an action plan, not to develop new actions, but to structure the action, do you think that the European Commission will address this issue from this perspective?
Thank you, Enrique, for this question. So, as I have already presented, from the Commission point of view, we have already in place a strong framework to work on rare diseases. And we are, instead of creating papers, we are focusing on a variety of implementing concrete activities that have a real impact on patients' life and families living with rare diseases. I mentioned a pivotal piece of work, which is this joint action. And that the joint action regroups a lot of stakeholders, the key stakeholders. And they are working together, members, not only member states, but all the stakeholders important for rare diseases. And they are working how to integrate adherence, as I said, but also in the national healthcare system. So touching upon all the elements that have been mentioned by Anne-Sophie, and by Martina and Ursula. So, however, for me, it's not a question of member states alone. All of us as an integral stakeholders, and this includes a member state, commission, patients, organization, families, the ERNs, healthcare professionals, hospital managers. We have just started a group of hospital managers, patients organization, as I said, and researchers. This is so. And the EU institutions will do their part for sure, starting from the European Parliament, but also the Council, Commission, and I see that also European Social Committee, Economic and Social Committee takes an active part. I think that we have to work all together. Yes, and I think that it's important to leave this joint action work, not to preempt the result of this joint action, and not to impose or to suggest, a bottom down. We prefer a bottom-up approach than top-down approach. So. Anne-Sophie is already there, working in a working group, work package 8 on registries, and she can speak about the huge work that is ongoing. So let's wait until 2027, and we'll see how this will result.
So thank you very much, Donata, and big applause for her.
Yeah.
So then, just now, I would like to ask some questions from the audience. We don't have too much time, as usual in these cases. I will ask you to be very concrete, focusing on a concrete question and also identifying the speaker you want to ask. Now we have there, Birute, here. If you can introduce your name, please.
Birute Tumiene, EN Board of Member States co-chair and Jardin Work Package 4 and Work Package 6 co-leader. I actually have more remark than a question, but it should be, if a question, it is addressed to Anne-Sophie and Ursula. We are working together very hardly in Jardin. Actually, one of the main problems behind the development of national plans and national strategies is lack of evidence-based data for evidence-based governance of rare disease care. And currently we are, as it was mentioned before, for the first time, actually, it was never ever done before, deeply analyzing all national plans and the national strategies, and hopefully will be able to provide, if not evidence-based, at least deep analysis-based data for further targeted recommendations for further national plan and national strategy development. So I hope very much that in the next presidency conference, we will already be able to give some results to you for really common discussion among member states.
So thank you very much, Birute, for your statement. Do we have more questions? We have there. Gentlemen.
Yes. No, my name is László Helma. I'm coming from Hungary, and I'm also involved in Jardin as a policy contact point. First of all, I would like to thank all the speakers for their very highly informative presentations. And my question would go towards Ursula. I was very happy to hear that in your national plan of rare diseases, you have taken some efforts to involve health technology assessments. And I would just like to know how many of such assessments could have been processed and what percentage of the outcome was positive.
Thank you very much for this question. Other things that we involve innovative technologies as diagnostic tools for patients, and then those tools were directly reimbursed for patients. So therefore it made more accessible and more less tough in terms of financial problems of hospitals. So therefore we try to include in the let's say basket of diagnostic technologies offered to patients as many as possible, including all currently used genomic tools like gene panels based on NGS, like microarrays and whole exome sequencing, but also we went deeply into metabolomic testing because many of the rare diseases are related to some disturbance in the biochemistry of the cell, and therefore we need we think that we need very sophisticated tools to look into metabolome of the patient, and those all technologies are now in the basket offered to patient to be diagnosed. Moreover, we also consider some immunological tests, because apart from typically genetically based diseases, we also have immunologically based diseases. So I did not mention in my presentation because Enrique gave me only 7 minutes. He was very tough. And then I could not, of course, talk about this technology, although I'm very keen on that, because for many years I ran a lab dealing with rare diseases, and we offer diagnostics to those patients who were who had ultra rare or undiagnosed disease. So we had had to put all the hands on the table to support those patients. And of course, in certain moment, we should go just behind those technologies, because even we used whole genome sequencing, we can provide diagnosis only for a bit less than 40% of genetically based disorders. So therefore, in the future, we have to consider new technology like long reads, like deep insight into transcriptomic, like metallomic, etc. I was not developing this because this is not routine yet. But we are very much in favor, and we hope for ERDERA programs and other research-based research programs to give us enough evidence that those tests can be implemented in clinical practice.
Thank you very much, Minister. Thank you very much, Ursula. I was not tough controlling the time, actually, as you can see. So, unfortunately, we are not having time for more questions. So, but before closing, I would like to invite each of you to give us your final message, your golden minute. Yes. What do you wish? What is your call, or what is your main thinking on what we are talking about? So, Ursula, we will start with you.
I should start some golden message, right?
Yeah.
Should I provide a golden message? So I think that I will stand. It is so important. I think that we all should go together. This is the most important. The European policymakers, the doctors, the patients, and the other specialists and people around, we should go together. Europe should be stronger and stronger, especially in this geopolitical situation as we have now. Then it is still more important that we get closer, and this cross-boarding and exchange of all the resources, not only finances, but also some human resources and knowledge, and the research results, as well as the information gathered from the data we collect in every country. So therefore, I think that my golden message will be just stay together.
Thank you very much. Thank you very much, Ursula. Anne-Sophie, please.
Alors, I wanted to go with the motto of the ERNs, share, care, cure. And my message is more for a political level. And we need to have very strong action for the ministries of the different, the 27 EU members of the EU member states. And it's really, really important. And not just the Ministry of Health. My message is that we have to work at the interministerial level, at the national level, and at the EU level, with the health, with the research, and we talk a little bit, but in our fourth national plan, we have now the industry. We talk at the beginning about advancements, bioproduction, biotech, and it's really important to have the industry also. So it's to be more pushy for with the European Commission, perhaps, to have a European plan for rare disease, but with a very strategic work with an interministerial work.
Thank you very much, Anne-Sophie. And Martina, I don't know if she's... Martina, can you hear us?
I can hear you. I'm still here.
Perfect.
Hope you can also hear me. So my minute would go along what was already said. So I think we need continuous political support at national and EU level to ensure the lasting progress, to have active participation from all stakeholders, and as Ms. Lafontaine just mentioned, also industry is very important recently to be included in the probably strategic documents on national level. And the third, to keep transparent communication, I think, with professional and the public to build trust and ensure clarity. And if you allow me, I hope not to be too pathetic, because Polish motto of the Polish presidency is Security Europe, which is very powerful statement to keep security at the heart of Europe's agenda, reflecting recent development. But if I adapt it to security patients, to ensure that care and attention to those who are vulnerable, like patients with rare diseases, must remain as one of the fundamental matters of our shared future, European future. Thank you very much.
Thank you very much, Martina. And last but not least, as I said, we have Donata. Please, what's your golden minute message?
So thank you to all of you. I think that, can you hear? Okay. Thank you. Yeah. So I think it's fantastic to see so many countries working together in the EU. This is the good part of having the European Union. And I think that there is a momentum for rare diseases, and this is now, this momentum. We are working, as Martina said, for real people. So we change their lives and the lives of their families. So we firmly believe, as said by Ursula, that by working together, we have to stay together, but working together as well, we can make the difference and bring the best possible solution to patients with rare diseases. It is for this reason that we ask for your support to all the action activities that I've presented to allow this action to bear fruit for the future. Please support us. Everyone must do their part. We are building together a European health union to improve the health of people with rare diseases and their families. Thank you again.
Thank you very much. Thank you very much, Donata. Yeah. Thank you very much. A big applause for the 4 speakers. It was very easy, really, to moderate with your really deep thoughts and knowledge. And now we close the session. Please, moderator.
That was the first session. Enrique Terol, Health Councillor, Permanent Representation of Spain to the European Union. Thank you very much. And thank you. I would like to thank the panelists. And we are slightly out of schedule, but just a few minutes. So I will just say that we don't break for coffee now. We'll break for coffee after the next panel, which is going to be Organization and Management of Healthcare Systems for Patients with Rare Diseases. And we are going to start with a keynote speech by Krystyna Szymańska, professor at the Medical University of Warsaw. The title of the keynote speech is Showcase of Rare Disease Patient. Professor, the floor is yours. Zapraszam na mównicę. I'm sorry, we break for coffee now. That was my mistake. And we meet here at 11:15. Ladies and gentlemen, we are starting the next session. Szanowni Państwo, zaczynamy kolejną.
We are beginning our next session, and we will start with a keynote speech speech. The session is entitled
And management of healthcare systems for patients with rare diseases. A keynote speech by Krystyna Szymańska, professor at the Medical University of Warsaw. The title of the keynote speech, Showcase of Rare Disease Patients. Professor, the floor is yours.
Nie ma slajdów. Aha, bo ja tu nie widzę. Thank you very much for the invitation. I represent 3 patients with rare diseases. Currently, there are over 7,000 rare diseases identified. 50% of patients are children. One of the most important challenges for us is the diagnosis of a rare disease. The process of acquiring diagnosis often takes many years, which not only delays treatment, but also affects the quality of life of the patients and their families. A rapid diagnosis means that parents and doctors become aware of what we are dealing with, and in many cases allows for the application of appropriate therapy. My patients, there are 3 children with different rare disorders each. They exemplify distinct destinies. The first patient, the problem is timely diagnosis does not always change the prognosis, but it sets the pathway for further family decisions. The second child, a rapid diagnosis allows for the treatment to be appropriately tailored. A third child, a precise diagnosis enables further improvement of a patient's functioning and in some cases full normal life activity. These 3 cases show the complexity of rare disease problems and different fates of patients and their families. The first patient is with Krabbe disease. The girl was the second child of young, healthy parents. The first child developed normally. Her mother was a healthcare worker, a pediatric nurse. The pregnancy and delivery went without complication. From the beginning, the baby's movements and behavior seemed disturbing to the mother. The mom went to doctors after doctors until she heard that she had postpartum depression and should treat herself. And yet she was right. The girl was sick with a severe, incurable, rare disease, Krabbe leukodystrophy. We can see body and eye abnormal movements. Sometimes parents see more than doctors. The family calmed down, stopped looking for a problem, focused on the child's comfort and everyday life. She would be at 18 now. The girl died at the age of 1. After the difficult road we traveled together, her parents are still in touch with me. Her sister is now studying medicine. Next patient is an example of how important it is to make a quick diagnosis. This boy had numerous long epileptic seizures from the first days after birth, even up to several dozen days. A day. The treatment used for neonatal seizure was completely ineffective. A decision was quickly made to perform a rapid whole exome sequencing test. It is an essential test in the diagnosis of rare disorders. Weston turned out that the boy had a mutation of gene encoding a sodium channel. These channels play a fundamental role in brain function. The treatment in such a case is different than the one adopted in the treatment of seizures in newborns. The treatment was changed rapid. The boy is currently having single seizures a day or no seizures. Next patient is the third child or healthy unrelated parents. The pregnancy was uncomplicated. She was a full-term newborn. From the beginning, the girl's parents noticed frequent head tremor, and from the age of 4 months, paroxysmal tremors of the arms, legs, and head. The patient was first admitted at the age of 7 months due to tremor, hypertonia, and delayed psychomotor development. We can see that she wanted to catch a toy, but she couldn't because of stiffness and tremor, stiffness on arms and tremor. The neurological examination revealed increased muscle tone, especially in reaction to unexpected stimuli, for example, a sudden change in body position or noise. Start reaction manifests as rapid blinking of the eyelids and intense tension and tremor of the limbs and head, which would gradually subside. MRI and EEG were normal. A cerebrospinal fluid test was performed and revealed decreased cerebrospinal fluid concentration of homovinylic acid in combination with normal 5-hydroxyindoloacetic acid. It strongly suggested tyrosine hydroxylase deficiency. Tyrosine hydroxylase deficiency is a rare autosomal recessive disorder. Its clinical expression varies and falls into DOPA-responsive dystonia, DOPA-responsive infantile Parkinsonism, DOPA-responsive spastic paraplegia, progressive infantile encephalopathy, or DOPA-responsive dystonia. Genetic testing confirmed the clinical and metabolic diagnosis of tyrosine hydroxylase deficiency. Following treatment with L-DOPA and the carboxylase inhibitor carbidopa, she showed a rapid and spectacular clinical improvement, supporting the clinically significant enzyme deficiency. And we can see that she is an intelligent girl. And she's 2.5 years old. Oh. Very intelligent girl. Currently, the girl dances in a modern dance group. We can see that hypotonia helps her dance. Her movements are fluent. Free patience, free faith. The hope never dies. Thank you very much for your attention.
Thank you very much, Professor Krystyna Szymańska from the Medical University of Warsaw. Well, that was a breathtaking experience, especially the last film. And now I would like to welcome to the stage the moderator of the session 2, Mr. Josep Figueras, Director Emeritus of the European Observatory, Health Systems and Policies Ambassador for the Health Union Fellowships. Professor, the floor is yours.
Hello. Good morning. We are competing with a coffee break, I'm afraid. The queue in the coffee on the coffee machine is more important than the session, I see. As they say, accessing to coffee, Italians, Spanish say that, is a real human right. So here you are. People are exercising their human right to have access to coffee. My name is Josep Figueras. I'm Director Emeritus of the European Observatory. And I'd like to introduce very briefly this session. I'll try to be very strict with my own time and everybody's time, because I want to give you lots of space to contribute later on, and I will do so at all costs, okay? So, what we doing here in this session? We heard already in the national plans a number of initiatives, a number of strategies, a number of levers. Now in this session, we're going to zoom in into some particular strategies. We're going to zoom in some particular financing, regulatory mechanisms, national pathways, and so on and so forth. So we want to hear good practices. My worry is always that we have these national plans which sound more like wish lists, that they look like Father Christmas letters. I believe in them. We have to put them in place. But we need to be aware as well that our ministers, our decision makers, have many, many priorities. They have a number of limited Easter eggs. We're in Easter now. In which basket are we going to put these limited eggs? Where are we going to prioritize? So I wanted to start. I will not ask you to vote, don't worry, although I wanted to do that, but the organizers have convinced me that we cannot vote. Although this looks like a Greek forum, you know, like where democracy started all around you. But I will not get you to vote formally, but I'd like you to think through, where do you think are the priorities in your country? These are all effective strategies. We'll hear more about them with our panelists. And I'd like you to think, where would you put your limited eggs, where you put your limited resources to ensure what is the focus of this session? A better organization and management of the health systems to ensure better access, timely access, and quality access. This is access to effective interventions. We heard already in the first presentations the challenges of rare patients, rare disease patients, to access to all those services. So, which three strategies should be the highest priority in your country to improve access to effective care for rare disease, including better integration of European reference networks, of course? So part of the objective is not only access and quality and your health systems, but how do we integrate these European reference networks into your healthcare system? So, is it all about national governance mechanisms? A rare disease action plan, we heard a bit about those. And a coordination hub, is that the way? Is that your first vote? Is that where you put your resources? National care pathways, patient journeys, and referral systems to ERNs? Is that perhaps the way to go? Would that be your second priority? Create national reference networks with designation and accreditation centers. We have very good ERNs in many countries, very good hospital centers, but often, as we heard, and that's the objective of this session today, they are not that well linked to the other centers of expertise in the country, right? So how do we have these reference networks to reach the ERNs? Engage patients and stakeholders. We always talk about that. Is that working? For the co-production and co-designing of strategies? Isn't that a key priority to ensure that effective access and timely access? Sustainable funding and institutional support, we heard about that a lot earlier. Digital tools, the interoperability, aligning the information systems for rare diseases with a national digital system. Very much also aligning now with the European Health Data Space initiatives, and investing in training and capacity building. We were talking about particularly actually in primary health care, where often is one of the bottlenecks for these patients to be diagnosed, to be detected. So what we're going to do now is, following a bit these kinds of strategies, we're going to hear particular examples. We're going to hear particular examples of making the organization and the management of the health system much more effective, much more access, much more quality. We always have to start with the patient. And not just as a symbolic sort of politically correct way to go about, but because we are here because those patients with rare diseases have enormous problems to be diagnosed, to have access to services, I said ad nauseum, and we heard already the statistics of the average 5 years before they reach the right services. So it's a pleasure to introduce Laurie Rena Linton. She's a patient advocate in the ERN for rare neurological diseases and represents also the community of patients with hereditary spastic paraplegia. So we'll hear from Laurie what are the kinds of obstacles and a particular, very specific strategy to improve that patient journey, that patient pathway. Laurie.
Actually, thank you for the introduction.
You need a microphone.
Oh, sorry. Thought my voice was loud enough. It's not. Okay. Yeah, together with Adam Lawrence, I co-created the patient journey for hereditary spastic paraplegia. So today I'm going to be sharing insights from the patient journey experience. And to begin, I'd like to show a short video showing that explains what a patient journey is, so we can start with a shared understanding. Then after that, I'll tell you a personal anecdote from before the patient journey was created, followed by a brief reflection on how things have changed since it has been created. And finally, I'll close with 2 short video messages from patient advocates within our ERN network, because their voices are super important. So actually, can you put up the, thanks. Okay. It's a PDF. I think, yeah, next slide. Okay, so here, we're gonna show the video. You should be able to click on it.
Patient journeys, different needs at different times. Getting diagnosed with a rare disease is overwhelming. Suddenly, many questions pop in your head. How will this disease change my life? Will I be able to keep my job in the future? Will I need a wheelchair at some point? Or even help at home? What can help and provide orientation in such a difficult situation? The European Reference Network for Rare Neurological Diseases works together with expert centers and patient organizations in many European countries. Together we've developed patient journeys for rare neurological diseases that are covered by the network. Patient journeys are visual overviews of patients' needs in the care of their rare disease. In order to best address those needs, the patient journeys are designed from the patient's perspective. They cover the patient's care needs throughout the whole journey, from first symptoms, over diagnosis and treatment up to the yearly monitoring. They describe the disease and its specifics as well as clinical care and counseling. Thereby they address challenges and goals, like finding a cure and maintaining the walking ability as long as possible. Patient journeys are helpful in many ways, to help patients plan for their future life, to educate health professionals, to help explaining the outcome of the disease to family, friends, carers, but also to employers or in case of children to their teachers. The patient journeys are now available on our website in many European and other languages. Scan the QR code to download the patient journeys and get more information.
So this actually represents, this slide represents the pre-patient journey, my pre-patient journey experience. And what is important to understand is that third picture, where you see the where you see the 2 women kickboxing. It's sort of it's expected that kickboxers wear sweatpants with the white stripe down the side. So. This is based on a hospital stay I had in 2017. At the time, I was not using a wheelchair yet. I was wearing black sweatpants with the white stripes down the side, and a nurse, excuse me, a nurse asked me if I was a kickboxer. No, not a kickboxer. Truthfully, I could probably have only kicked a pebble at that time, like something this small. If the patient journey had existed then and had been available to him, he wouldn't have needed to ask that. He would have known about my condition. Now in the post-patient journey world, I've shared this document with at least 6 different healthcare providers. It brings a sense of security, especially living in Austria, where my German isn't very strong. Having that document, this document, right here, having that allows me to walk into an appointment and hand the doctor a tool that speaks for me. I think next slide. Oh, no. Yes. So, sorry. Finally, I'm going to end with
Hello.
two
I am
short
a mother
videos.
of a 14-year-old girl who was diagnosed with HSP when she was 8. At the beginning, we didn't know much about HSP and the challenges, but the patient journey showed a constant worsening of the symptoms, especially on the ability to walk. Our daughter attends a normal Austrian school. Unfortunately, this school is not entirely accessible. First, this was no problem, but now, 4 years later, she needs walking sticks, and the changes from classroom to classroom get more and more exhausting to her. That's why we decided that she changes school, and the new school is more accessible and better connected to the public transport. Having a patient journey that shows the progress of the disease and the challenges that come up could help other families to prepare better for the future.
And then the next one. Not the next slide, but yeah, this one.
A few years after being diagnosed with Huntington's disease, my mother was admitted into a psychiatric ward. She had tried to set fire on the house of my father, and the police admitted her and asked for 3 weeks of observation and evaluation of her health. Many people think about Huntington's disease as a movement disorder, but it's not. It's more about psychiatric, cognitive, emotional, and personality changes and disturbances. After the 3 weeks of observation, the psychiatrist summoned us and she told us, "Your mother is perfectly fine." Not even the expert had managed to capture the underlying elements of my mother's bad health. Now, I know this is a long time ago, but still I hear stories from patients and family members having to teach their healthcare providers about the disease. That's why we need a patient journey. If we could have shown a copy of that to the psychiatrist back then when my mother was admitted, I think her evaluation and advice would have been very different.
I don't know, the next one, I don't know if you wanted to ask.
Thank you very much. Can you bring your hands together? Thanks, Laurie. I think you were excellent reflecting those realities. I think the example of the gym pants and the lack of understanding, to the lack of understanding of the psychiatrists, to lack of understanding of the schools, all those services around patients with rare diseases. I find these patient journeys absolutely engaging and attractive, and a way to, in a very simple and yet informative way, to demonstrate, to explain those around your disease, that support your disease, addressing your disease rather. But we always talk about patients co-designing and co-producing. I hope there are many patients organizations in the room. Laurie, are you happy? Are you happy about how much patient organizations are involved in the process of designing their own care, coming up with solutions? There's been a lot, there's an European award actually, for those patients that come up with technical solutions to their own problems, or sometimes with devices, because they suffer it every day. So do we have mechanisms, enough mechanisms to enable you to be in that? And in rare diseases more than ever, because they are rare, people don't know about them, and the patients do know about them. They are often patient experts, you know, the Lorenzo's oil story, the famous film. Can you reflect a bit on that? And then later, on the times of the contributions, I'd like to hear from more patient organizations, please.
Yeah, I mean, yeah, this works.
Yes, it works.
I think we have come a long way. I think you need to advocate for yourself, and I think that I mean the patient voice is essential to have in anything that is developed in terms of rare diseases. I'm trying to think if I'm happy. Sometimes not.
What can we do to make you happier? What kinds of things you think have worked well? It's not an easy question, I know. We all want to be happy.
It's not an easy question.
But I'm trying to say, is it about more information to these patients? Is giving them resources, showing them best practices, more training to them? What is it? Because we don't have enough patients involved in this process.
I think all of those things, actually. Yeah, I think all of those things.
Is it about individuals as well? Is it about?
I'm sorry?
Is it about individuals, patient champions sometimes, like yourself?
I think so. I mean, I'm not sure if I'm not sure if this fits in here, but what I was telling you about the father. I just had communication with a father in Romania whose 1-year-old daughter has an ultra rare form of HSP, and there's no expert center in Austria. So he reached out to me to ask if I could do anything. And I wasn't really sure that I could do anything, but I did ask another patient advocate in the ERN to help me. And we made communication with a doctor in Barcelona, and possibly he'll get some answers. But the doctors in Romania did not refer him, did not say, this is what you can do. He was kind of left on his own. So, yeah.
Perfect example, actually, that when the health system failed, not ideal, but at least the patient organizations can offer the kind of information and support that kind of referral.
Yeah, it's not expected that there will be an expert center in every single country, but we talk about cross-border healthcare, and it's like no one referred him. No one told him what to do, how he could go about it, and that is not good.
Not good at all.
No.
Thank you very much. Thank you very much, Lori. That was really, really useful. Let me move now to Luca San Giorgi. He is the coordinator of BOND, and I believe now is your semester, of coordinator of the ERNs group. You're going to talk to us about the impact of ERNs, linking very much with the prior session, and in particularly how we integrate centers within the country. Please, from the rostrum. You want me to pass for you, or you want to pass?
Okay, thank you. This one is working. I think that Laurie's introduction. No, it's working. It's working. Laurie's introduction is perfect from what I'm just going to present, since this is the classic story of a patient that has this kind of problem, meaning not finding the right place where to be cured. And ERN are the kind of response for this situation. I think that the ERN in which you are an EPAG, it's a great example of that, but all the ERN are providing exactly the right opportunity and the right possibility for that. I won't go through all the success stories of the ERN. I would like to also thank DG Santé for publishing this booklet that is really informative and important and gives you the real success story of what ERN has done in order to concretely change the possibility and the situation of the patient in all the different countries. There are great examples of diagnosis. There are examples of ERN that have contributed also at the public health level, for instance, to set up a newborn screening in those countries that in where newborn screening were not present. So concrete action that have brought specific responses to the patient needs. And I think that this is the reason why we are there. As Anne-Sophie was mentioning, we are there for taking care of the patient. Share, care, cure. And this is what we are trying to do in our daily life. So, kind invitation to have a look to the booklet, and please, I won't go through all the success story. It was not able in 7 minutes to do that, but please have a look to this booklet because it's really informative. There is another aspect that is relevant, that is done. We need to measure concretely what kind of impact ERN have brought to the community. And starting from this year, there is this annual monitoring exercise that will publish a report. This is a concrete way of showing what numbers ERN have produced. This is a relevant message for patient, but also for policymaker and decision maker that are in the audience at the national level, showing what kind of impact ERN have brought to the rare disease community. The first edition is going to be published in May. Please have a look to that so that you will kindly realize what kind of real contribution ERN have brought to the patient. Not only at the national level, but also about the possibility of reporting or exchanging patient, the CPMS use, the possibility to provide diagnosis to those patients that do not have a diagnosis. And at the same time, using the CPMS, also the possibility of training specialists, like the Romanian case, that do not have the sufficient and necessary expertise to run the right diagnosis or to run the right treatment. Exchange of situation. For instance, in our ERN, we had a patient from another country coming for a very specific surgery, but also the surgeon from that country was coming as well. So not only giving them the fish, but also giving them the tools in order to fish themselves. I think we'll talk later about pathways, just to briefly mention the exchange of patients that have been taking place. And these are just 3 examples of ERN that have been really efficient in cross-border pathways. Finally, it has been mentioned many times, Jardin, in this audience. I think that it's really a great opportunity that we cannot miss. We were just discussing with the Polish Vice Minister about the possibility of setting up national, let's say, pilot studies in order to evaluate the different models. Even if we are speaking about a common plan, we are operating in very different national systems. And we need to have models that could adapt to the different situations, so much so our proposal could be really efficient and applicable. This is one of the work that we are currently running in Jardin, and it's really interesting that at the first pilot study already with Poland is going to be 9 countries have applied, belonging to different healthcare systems. So at the end of Jardin, we will have the opportunity and the possibility to present different models and different opportunities to be adapted at the different contexts. This is just an example of the pilot study that are currently running. Thank you very much for your attention.
You can stay. Thank you very much, Luca. Thank you very much for being on time and being so informative. It is indeed a great report that the Commission has put together on these success stories. I thoroughly recommend to read it. It gives a good sense of what member states are doing. It gives a good sense already of best practices. It's truly inspiring, and I very much look forward, we all very much look forward to this first evaluation of ERNs. What we see in there, Luca, is huge differences between member states still, in the amount of, the numbers of associated centers. Of course, it depends on population as well, but still, with countries with similar population levels, many more associated centers in some countries than in others, the extent to which are clinical pathways, the extent to which this has these national accreditation systems and networks. Again, it's a difficult question, I know. I'm tempted to ask you whether you're happy about what's happening and why some countries are doing so much better than others. What are the keys? I mean, my obsession today is not just lists, but why some people are managing to implement much better than others? What is the secret?
I'm not sure that there's a secret.
Must be a secret.
There are different cultures, I would say.
Okay.
And in many ways, I was just mentioning about the fact that we have very different national healthcare system in Europe and very different way to adapt the same message to the different situation. One of the activities that we are currently running in Jordan is to find out indicators that are clearly describing what is a national referral center and what is a healthcare provider of an ERN. And this is one of the reasons why we are having 9 countries, because one of the clear messages that we are getting from the first year of Jordan activity is that there is no homogeneity in the way in which we are defining a referral center, both at the national level and also member states are defining a referral center to become an healthcare provider. So setting up a common indicator and common strategies that could respond in a way to a common vision of what is a referral center and what is let's say, an healthcare provider of an ERN.
So your first recommendation is good indicators, clarity of definitions. This is one of the main obstacles in member states.
And good monitoring of the activity of each center, both at the national level and also at the healthcare provider level, so that you can have centers that are always updated and able to respond to the patient needs.
Excellent. Any other factors apart from standardizing indicators, better evidence, clarification of what are national reference centers? Any other elements that explain, for instance, that some countries are using much more clinical pathways than others?
I was mentioning culture. We have countries in which, like France, at the 4th national plan. Other countries are at the 2nd, maybe 3rd national plan. Some countries do not still have.
What is your advice for these countries that do not have yet a national plan?
Or to immediately start working on setting up this national plan, because we are speaking about a national European plan, but then if you don't have a national plan, you won't be able to put in practice the European national plan at the level of the national one.
So in my list of priorities, you would put the national plan as the first priority to start that.
That's definitely programming. I mean, you can get the criteria, you can get the number, but after that, if you not go for programming, that is not going to give you any concrete answer.
Perfect. Thank you very much. We'll come back to you, Luca, and to everybody else when the colleagues in the room are going to contribute and ask you questions. Aileen Tracy now, Clinical Professor of Medicine of Rare Disorders, Trinity College, Dublin, Ireland, of course. You are taking from Jordan as well. We are so excited about Jordan. I would like to see the results of Jordan already, rather than describing Jordan. We all know about Jordan, but we like to hear the results of it. And you're going to depart from there as well and tell us about one very specific strategy, one of the very enabling strategies, which is to have the pathways and referral systems, right? And from Ireland. Thank you.
Okay. Good morning, everybody, and thank you for the kind introduction and to the organisers for the invitation to speak today. And so basically, to set the scene that you know already, the EESC's revised opinion on an action plan for rare diseases actually calls for supports and sustainable funding for the integration of the ERNs into member state health systems, for national networks, for the development of member state and cross-border pathways for highly specialised care, which should adopt the ERN guidelines. But also of importance and of note is the need for enhanced training for healthcare workers and social care providers. So I'm sure you know these studies already. The RARE 2030 Foresight study survey identified 3 key priorities for people living with a rare disease. That is, helping patients get a final diagnosis faster, the coordination of care, and the need for improved access to specialist care, treatment, and drugs. But what might be surprising is that even up to now, even up to last year, from the RARE Barometer European study of over 6,000 individuals across Europe, it still is on average nearly up to 5 years for a patient with a rare disease to obtain a diagnosis, the first step in the care pathway. And there also are very significant delays to referral to a centre of expertise. And it's notable, the conclusion and the paper is that the authors state that improving knowledge of rare diseases among healthcare professionals, especially primary care, should improve the identification of rare diseases and provide information on centres of expertise and networks at national and European level. So the need to improve this education in primary care is well referenced in these recent publications that you'll see here. So the ERNs at hospital specialist level are undoubtedly considered to be highly successful, as we've heard. However, ready access to the required expertise at the commonest and the nearest point of care for patients and families with rare diseases may be problematic in many member states due to lack of knowledge at this level. And the EU cross-border directive open public consultation noted that better ERN integration into national healthcare systems is one of the challenges of the ERN system. And as you've heard earlier, the relevant EC-funded joint action started in January of last year, coordinated by Professor Till Voigtländer. And you can find references here to the relevant links for further information. So what I will briefly discuss here, time is short, is the Jardine Work Package 6, the National Care Pathways and ERN Referral Systems. So the first task, 6.1, is tasked at developing a rare diseases IT signposting tool in collaboration with Orphanet for use at local level for member states to hopefully easily and readily demonstrate the location of national expertise and referral points into the ERNs. The second task relevant to today's topic is the development of model care pathways and the proposal to pilot these pathways, which will include the ERN's experience and what we've heard from Laurie, in particular, the patient's care trajectories in collaboration with EURDIS. These are these patient journeys that have been very nicely presented. And the following on packages in Work Package 6 will include further recommendations on care coordination. So, you know, there are many definitions and considerations of what a care pathway is, but I have to take a few seconds to describe this. So, according to this action, we have used the European Pathway Association definition as the methodology for the mutual decision-making and organisation of care for a well-defined group of patients during a well-defined period to structure a multidisciplinary plan of care and translate guidelines or evidence into local structures, thus standardising care for a specific population. So EURDIS, and specifically, specifically EURDIS, Matt Johnson, has performed a systematic review of the existing care pathway methodologies, which you can see on this slide. And this review was then further refined by a multi-stakeholder Jardine group, which was centred around the lived experience of individuals with rare diseases, the patient journey, and with a number of interactive workshops that were facilitated by EURDIS. So I won't go through this, but the model process has 5 phases. But what I want you to refer to is the toolkit, which has now been finished and is accessible on the Jardin website. And this has got very nice templates and working examples that are modifiable for healthcare professionals and patient representatives. And you'll see on this also the actual toolkits to develop the patient journey that we've heard about. And so to date now in Jardin, there is work in progress to develop an overall generic care pathway, which will include the core aspects of diagnosis and care. And also 13 ERNs have expressed their intent to develop model care pathways for either thematic or single conditions, which will hopefully standardize multidisciplinary integrated care and education for families and specialists and primary care. So then finally, what we've heard in the discussion already today is that a number of member states have reported very robust national commissioning models for highly specialized care. But if you look at national enablers and system levers using the blocks integrated care appraisal methodology, our own experience in Ireland in developing rare disease care pathways, where we have developed 30, has highlighted the needs for a supportive national political environment for patient advocacy, workforce, staffing and training, with a particular emphasis on primary care. Obviously, the need for IT supports, and of paramount importance, the need for financing of the ERN sites and equitable financing for the multidisciplinary staff needed for implementation of the highly specialized care pathways, including in particular for psychosocial care, regardless of rarity. So thank you for your time.
Thank you. Hello? Yeah, it works. Thank you very much, Eileen. That was beautiful. Let's just stay in this slide for a minute. In some ways, care pathways is a no-brainer. We've been trying for years. I remember part of my own personal history in the health system, trying to put in place patient care pathways. In integrated care, for instance, chronic care is fundamental, and in every single disease. But it's getting very difficult to implement those. And I love this list of some of the possible levers that you can put in place. Again, with the limited text, where will you think are the most important levers to get these clinical pathways going on? You and I were talking the other day, you were mentioning very much training in primary health care. It's one of the obstacles sometimes, isn't it? Could you elaborate a bit more in this theme of prioritizing and implementation?
Yes, well, what we've heard already, obviously, every country needs their own national plan. And what I was saying is that obviously there has to be great support, and there is support at European level for the European reference networks. But the member states, however, still retain full responsibility for providing safe and equitable care to the rare disease patients that are appropriate to their needs. So there's 2 things. One, what can be done in a simple fashion?
Can you hear well?
Yeah, so the 2 points I want to make is what can be done in a simple fashion and what is more challenging. And so there are simple things like education and signposting, and so education of the GPs, because I mean, in our helpline in Ireland, we know that this diagnostic odyssey is because it's at the primary care level. So education, and what we heard from actually the commissioners when we started Jardin was try and develop a simple blueprint, a simple way for the GP to click a button. They don't have 25 minutes to find out where is that expert centre, where is the point of referral in your country that you can actually facilitate and get into the ERN. And then, so that's a kind of simple educational tools. The bigger picture then is funding. And the bigger picture, I mean, we heard the discussion earlier about why do some member states do better. Well, if you had 84 million in your member state and 5 million with rare diseases, that's the size of other smaller member states. So obviously with bigger numbers, there's going to be highly specialized care commissioning. But it's in the smaller member states and medium member states where there should be a systematic method of commissioning. And that needs funding, and it needs the actual political support And it also
How do you
has
get politicians involved? Do you
Yeah.
go to the press, you communicate?
Well, I'm just going to finish that sentence, but just to say that, like, but there are particular needs, you see, for rare diseases, that so it's not equal. There's equity issues because they need the psychosocial care. So how do you get the political support? Well, basically, I think, I mean, we hear all the time, and I can tell you for a fact, I mean, patient advocacy is paramount. The patients motivate the ministers, to the media, to the government, but at the end of the day, the commissioners are at the government. So I think, you know, clinicians have a voice,
Perfect.
but it's the patient voice that has started the ERNs and that will motivate the politicians.
That's
I
very
think-
helpful.
I
Thank you
think.
very much. I'm
Okay.
sure we'll come back to that on the debate. Laurie, again, patient advocates going into the press, showing your plea for support, your obstacles. And last but not least, undoubtedly not, Juan Fernando Muñoz, Secretary General of Digital Health and Innovation, Ministry of Health of Spain, presenting indeed a very innovative approach to the network of coordinated care for support of children with rare diseases, UNICAS.
UNICAS. Thank you very much, Joseph, and good morning, ladies and gentlemen. It is truly a pleasure to be here today to share with us, with all of you, an experience that deeply inspired us is the UNICAS project. It's a coordinated care network combining expert knowledge and digital tools to support children with rare diseases and their families, and importantly and differently, the professional closest to them in the daily care. These diseases may be rare, but the patient who suffer from them must not be invisible. Spain actively participates in the 24 European Reference Network and coordinates 2 of them, the ERN for pediatric transplantation and the ERN EpiCare for rare epilepsies. This experience has shown us the value of collaboration and working in networks. And with the same vision, UNICAS was created for the national context, a network that connects the top experts in rare diseases with the professional closest to the patients, including in the nearest hospitals and even in primary care. UNICAS complements the national network of Center of Expertise for Rare Diseases, the CESUR in Spain, being many of them members of an ERN. The reality faced by children with rare diseases is complex. Late diagnosis, limited treatments, and evident inequalities in access to specialists depending on geographic location. Families endure daily carrying significant emotional and logistical burdens. UNICAS offers a different, more humane, effective, and integrated solution that brings expert professionals closer to those working directly with patients through advanced digital tools. The mission of UNICAS is to ensure that children, no matter where they live, have access to both the healthcare professionals who know their disease best and those who know the child and their family best. This way, families don't feel alone and can reduce their burden with the help of all professionals and the digital support. UNICAS is part of the digital health strategy of the Spanish national health system, supported with over 1 billion euros and developed in collaboration with all the regions. UNICAS is the flagship project of new personalized digital care model funded by the European Union Recovery Plan and strongly connected with the SIGENES that aims to create a national genomic information system. UNICAS is built on a federated digital structure. There is a central node managed by the Ministry of Health and at least one node in every region, bringing care close to patients and families. Clinical data is not centralized, it stays under the control of those who create and manage it, whatever it is shared securely in a structured and semantically interoperable way in full compliance with GDPR. So what kind of information is shared? In short, all the information relevant to healthcare professionals, both experts and those who are closest to the patients. diagnosis, symptom, treatment, data about similar patients from other centers, and so on. And in addition, information that is essential for patients and families, appointment calendars, and unified view of their medical history, access to the care team, and with consent connection with other patients with similar condition and their families. Of course, all this requires clear governance with definite roles, permission, access rules, traceability, and safe work. Nothing is improvised, because if we want to build trust, we must provide solid guarantees. UNICA's go beyond technology. Its goal is to make collaboration easier among healthcare professionals. It connects the most specialized centers across the country with the frontline healthcare professionals in the primary care, so that knowledge can move quickly and without barriers. And it's not always the patient and families who have to travel. With UNICAS, a primary care doctor can consult a national reference network expert to safely treat a disease they are unfamiliar with. And a pediatrician can get a second opinion without moving the child. A family doesn't have to travel hundreds of kilometers for expert advice. They can receive it locally, always supervised by a closer healthcare professional and supported by the top specialists. We have come a long way. We have defined the technical architecture, agreed on governance rules, standardized clinical reports. For the first time in Spain, one region, Catalonia in this case, is developing the software for the rest of the hospitals and the rest of the regions in the country. We are now entering the pilot phase, and yes, there is still much to do, but there is a lot to be proud of. Ladies and gentlemen, with UNICAS, we are not only implementing advanced technology, we are truly changing our healthcare model. We are proving that it is possible to combine high specialization with personalized care, proximity with clinical excellence, and equity with innovation. This is our pathway to a true network healthcare focused on people, respectful on their rights, and committed to real health outcomes, because every patient deserves the best possible care, and every family deserves to know they are not alone. Thank you very much for your time.
Thank you, thank you. Thank you very much, Juan Fernando. Yes, it works, no? Many thanks. They're a bit interesting, these microphones. Well, Juan Fernando, thank you very much for your presentation. I think what one message is not just digital to enable models of care, but shaping models of care. I think that's very, very important, improving the care. One of the challenges there is the alignment, isn't it? Is how you don't create a new system of information and digital for rare diseases, but the integration of the main initiative. Can you give us a couple of short reflections on that?
Well, it was something that we came up after the pandemic, because we started to work in this way during the pandemic time. And that was the first key. The second key was the money of the recovery plan, because you need the money, you need the resources. And the third one is you had to listen, because it wasn't our idea. It wasn't an idea from the ministry in our tower. It was we had to listen to the professional care at hospitals, and we had to listen to the patients through the association. That was the combination, that was the key enabled for this project.
So the involvement of professionals and patients was very important in implementing
Absolutely.
And designing and implementing it.
Absolutely.
And then buying in. One of the issues we have always with digital is that some doctors sometimes are very mistrustful of digital. And in this case, it's the other way around. Doctors wanted and health professionals wanted the system, right?
We have more than 600 projects in our digital strategy, but this one, only in this one, 150 healthcare professionals are working together to get this pathway, this reports, to standardize the information. Is the one where more professionals are working.
Central question, central recommendation. Thank you very much, Juan Fernando. Can I ask you now contributions to, more than questions, if that's okay with you, I'll ask you to give contributions of no more than 45 seconds. I'll time you, okay? So you all can provide contributions about any of these areas we heard about. Pathways in your country, why are they working well, what's the key, training programs, digital. What are the kinds of strategies you put in place in your country that actually work well? 45 seconds, and I want to have as many as possible, and then I'll ask the panelists to react to those. Please.
It is a contribution and a question at a time. Yeah, no, short. I am one of those that believe that the ERNs are networks composed by members, which are in fact medical teams that are already integrated in their national healthcare systems, which is the title of Jardin, integration of. Now, on the other hand, I strongly believe that the structural role of the national systems, everybody said it, I had the chance to work for years in France, it is excellent. Now I'm in Spain, it is at least as excellent. So the national networks, I am convinced they play an important role, but I am also convinced that if we miss the EU-level membership of the European reference networks, we will increase the differences between countries rather than decreasing them.
I think we agree on that.
Yeah, so if we agree, that's perfect. So my question then to Eileen, Luca, or it could be for Anne-Sophie or for anyone else, tomorrow, with all this work we are doing, what will be the differential point between a very good national reference center versus the same very good national reference center that will have an ERN membership? What will be the differentiating point?
So what we wanted then is no differentiation, I suppose. So one of you, please, only one. Maybe Luca, prepare an answer on this one, please. More points within the 45 seconds, please.
We always have long discussions.
No, later. I want to accumulate several questions.
You gave me the courage to say today and to stand in front of all of you, thank you. I am a mother of a child who is having a rare disease. And Laurie, thank you so much for showing me the totally different story, because I'm coming from the big corporate world, and I thought that I know quite a lot about customer experience. Today, you showed me a small spark that I forgot. I never thought about the small things that every parent should know, in the meaning, what is ahead of you? What will happen with your career? Yeah. What will happen with the siblings, with the brothers, aunts, etc., etc. And today, I think I'm very lucky, because I'm working in a place where my child is being treated. I'm working at Paley European Institute, which is serving, because this is the right word, kids from 56 countries from all around the world with a rare disease. And today I'm standing, and you gave me an amazing idea, because I'm working on the application that will be guiding doctors, clinics, and parents where to go and where to look for the information. In the situation, we have a super fragmented system where this is so difficult for us to find the right doctor. And I think I will use this moment. If you feel that you would like to join and you would like to create this app for not only neurological and orthopedical rare diseases, please contact me. I have a founders, and I think that this is not only about neurological and orthopedical. There is huge things to be done. So thank you,
so much to be
Laurie.
done. Thank you very much for sharing that experience. It's very inspirational. More points, please. Come on, I built so much time for you to contribute. You're not going to fail me now. Any other experiences you want to share, please, about what you're doing in your member states, in the pathways, referral systems, national plans, digital systems. Nothing else is going on in Europe? I don't believe that. I can be silent for a long time. It's going to be very embarrassing. Eh? Any more points? No? Okay, so I'll go back to our panelists. We only have one question to address. Maybe you want to react as well to the point about this app to improve the referrals, to improve the navigations as well. And then I'll give you in a minute. So we do one first round, please. And then I'll give you the golden minute and we'll finish on time, I believe. Luca, you want to start there?
Going back with the long discussion that we always have with Alexis on this point. As you clearly mentioned, if you are an ERN center, you are part of the national healthcare system. At the same level, there are situations or centers that are not at the same level, meaning they do not fulfill all the requirements to be an ERN center. Obviously, ERN center will have to talk with these other centers and to network with them. ERN are slightly different. And therefore, one of the nice things of the work that is coming out from Work Package 5 of Chardin is that if you want to be an ERN center, one indicator that comes out with 0.0001 significance is to be a research center. Meaning that if you want to provide the best care for the patient, you need to also to do a good research. And therefore, I think that the connection also with all the other activities, tomorrow there will be the Erdera seminar. I think that everything can merge together, but in reality, there are national networks. For instance, if you have a look in the Italian situation, there are a certain number of national networks, of national centers, and few ERN centers that are, and it would be really important and nice to set up networks that are efficient and working together, especially for the aspect of referring patient. Not only at the national level, but maybe sometime also using cross-border healthcare.
Thank you. But short, please.
Just to add to your reasoning, I think, because this is to please Donata, I read the directives. The directives say that membership to ERNs is on a voluntary basis, which means that we should keep this. The good national reference centers, that they are ready to give of their time for the European Union level health, could be another criterion beyond research of being labeled a member of the ERN. Because this is what we are doing, this is what the centers are doing. They give time to other countries, to other colleagues, to other patients, and so on. And I think that voluntary basis is a very good differentiating factor, if I can say.
Donata, may I ask you, put you on the spot? There's a lot of debate. I remember a year-end meeting also organized with Enrique Terol about hospitals and hospital managers, chief executives sometimes not being very much aware of the ERN status, not giving the support, enabling those doctors who put, thanks for the point, very much their voluntary time on that. What can we do about that? How do we convince, how do we demonstrate to these chief executives that actually to be an ERN is a good prestigious thing, it attracts patients, it attracts money? Can we do that?
For sure, we are here to make your dreams true.
I like that.
Yeah, no, I would like to give you a good news as well, because indeed there were already some meetings of hospital managers and CEO of hospitals in the past, but recently we have given them a role of advisory board of this joint action, and we created it as a commission, an expert group. So they are officially an expert group of the commission for the ERNs, after the ERNs. We met in Brussels last month, and we started with them. You know, there is one represented all the hospital, so we have 27 plus 1, Norway and Ukraine, they were not there, unfortunately. But yes, starting working with them. So most of them all are very happy to be there. They are aware of what does it mean, because on one hand we say your hospital will not get money from the Commission, and also for the centers. On the contrary, they will complain about the burden of the administration, monitoring, as it was mentioned, but they understand. They are very clever men, and they say that we have to measure the impact of what we do. So what is the benefit for them to be part of this club, as we say, the European Reference Network, is because they are at the EU level, as Alexis said. So they can reach other hospitals. They are at the heart also for the research. And so they are engaged and they support us. And at least then we have to also to make a survey, I would say, to the centers, because indeed, they have to give time, resources to the center to perform as a center of the European Reference Network, not to do them on their free time, spare time, but to be part, essential part. And for this, we need also the member state to have dedicated budget for ERN's activities that go up to the centers, up to the hospital. Yeah, this is, I don't know if, this is our, it's already true in some member states, in the others we are starting, but I think we are in the right direction.
Congrats again for what they're doing. No money, but lots of goodies that are also very important for these chief executives in terms of prestige, training, research, and so on. Luca, your report will be very important to demonstrate to these hospitals the impact and the evaluation of ERNs. Now you got your 1 minute, golden minute, to summarize your main points here today. Shall we start with you?
Are you?
Take mine.
Okay. Are you going to time us?
Maybe.
Okay. Yeah, of all my work as a patient advocate in the ERN, and I've been there since 2017, so almost from the beginning. The patient journey is something I am most proud of. It's right here. It's a tangible tool that provides immediate benefits for the patient. It allows them to measure, you can get better, you can get more personalized care, better personalized care, and it makes it easier to talk with doctors. Also, the patient journey gives people a sense of control in a situation that is pretty much confusing, that is often confusing. What else? Yeah, the other thing, the most important thing is that it allows you to not, or it makes it so that you do not have to repeat your medical history over and over again, which is quite annoying. And the last thing is, I hope you all see that patient journeys are something super, super important.
They are indeed. They are indeed. They are indeed. Control, control, control to the patient. Aileen.
Thank you. I think I've already mentioned my golden minute to your question. But basically, I think when the ERNs were initially started, it was the aspiration of the patient advocacy groups, EURDAS, that every patient would find a home in the ERNs. And I think that with national plans and with the European support, I think that the ERNs will thrive at European level, and they actually will continue in their excellence. But really what I want to point out is that it's the member state responsibility, and I think to maintain adequate care for patients with rare diseases. And one of the things I mentioned was really simple things like signposting, the most appropriate care and referral pathways into the ERNs, even if there aren't full coverage, as Alexis was mentioning, in a country, that actually every patient can access the excellence and education at general practitioner level that they know in very, very simple terms. And then lastly, that the ERN sites would be funded properly in the national member states, and that the care pathways, like for groups, would be funded in particular for all the components of the care pathway, including, for example, genetic counselling, psychosocial care, which is needed. We found in our pathways is needed for all these pathways. Thank you very much.
Thank you. You mentioned a lot signposting, and signposting, Eileen, is not expensive. Yeah. It's straightforward. It's just doing it and having it integrated, isn't it? Juan Fernando?
Well, to me, UNICAS is a clinical and digital initiative, more clinical than digital, that aims to bring the national reference expertise directly to primary care. It supports healthcare frontline professionals by enabling collaboration and information sharing with the best specialists available. UNICAS can lead to early diagnosis and better treatment, helping primary care professionals to identify and connect symptoms. And at the same time, UNICAS also provide digital practical tools to help families manage care and stay in touch with their care teams, with the care team and with other patients and families with similar conditions. And the last, but the most important thing, is to listen the professional, to listen the patients. And one has been mentioned for the audience now is when we are starting right now to implement a telephone number at the first time and then an app just to help the patient to navigate in a very complex healthcare system.
Signposting, listening. Thank you. Luca.
I really do not want to sound trivial, but since ERN has proved to be a success story, and everybody is saying that it's a success story, ERN will need some more money to survive.
And where does the money come from?
Well, I mean, Eileen was mentioning the member state, and obviously we need also the strong support of the member state, and I think that the monitoring is going to show clearly what is the current impact, not only at the EU level, but also at the national level. But it's pretty obvious that ERN needs to be clearly mentioned in the next financial plan of EU, and to have at least as many money as we have right now, but hopefully, since we are producing, I mean, I was mentioning, if you have a look to the success story, you will see incredible result also in education and training, incredible results. Patient journey is part of the success story. There are many success stories that are based on the patient journey. If you need to further develop this initiative and to bring them to a more mature step, sorry guys, but we need some more support also at the EU level.
Challenge put to you, Donata. So from me, thank you very much. Just to say, if there are two factors that hit me continuously here, is the involvement of the patients beyond the rhetoric, and the involvement of the product, of the champions, of the clinicians, of healthcare professionals. These are real engines. Sometimes it's not about money for them. It's about enabling them, supporting, listening to them. I thought your example was perfect, Juan Fernando, and all of you. So perhaps there are these two factors that are cheap, and their value for money, and maybe can help to put in place this recipe that we saw of different strategies that work, that are effective, but that's perhaps the engine to get that going. Please bring your hands together to thank these enormous, great panelists, and I'm sorry I couldn't get you more excited for more contributions. Thank you.
Thank you very much. Josep Figueras was the moderator of the panel. We don't break for coffee now, because, yeah, I'm telling the truth now. So we don't break for coffee now. We have another panel, which will last for an hour, and at 1:30 we'll break for lunch. But now I would like to give the floor to Alexis Artimanoglu, Professor, Coordinator of the European Reference Network for Rare and Complex Epilepsies. So, Professor, the floor is yours.
It works. Okay, thank you very much. First of all, just to present myself, I am above all and forever a child neurologist. specialized in epilepsy care on top of it, and I have the honor to coordinate the European Reference Network for Rare and Complex Epilepsies. And as it was said some minutes ago, I work for the Barcelona Children's Hospital after having worked for years in France at the Lyon Children's Hospital. This is a glimpse for Anne-Sophie. So it is a pleasure for me to chair this session with excellent speakers. I have to thank the co-organizers for inviting me. I don't know why they choose a doctor to chair the regulators about access to treatments, but I understand the point. So I would not like to occupy more than this, the floor. I would like to invite the speakers. The topic is crucial, of course. Access to treatment has many aspects of accessibility in terms of regulatory agencies, in terms of security of the treatments we are using, being drug treatments or surgical treatment or devices, price, costing of those, reimbursement of the patients, cross-border reimbursement of the patients, situations in crisis like the Ukraine situation, for example, where you need to bring the treatment to patients that may not have it or may lost it. So it is a huge topic. And the first speaker that will introduce this is a person that I had the chance to meet some minutes ago, Kasia Kantorska, who is a policy officer here for DG Santé. And the topic is on regulatory options and pull and push incentives. So Kasia, please.
Dzień dobry, szanowni państwo.
I'll just say hello in Polish because I am Polish, and I would like to first of all thank the organizers for having me. I feel honored being here, being able to present to you our work at the European Commission. And now I will switch to English.
Hello, everyone. I'm really pleased to be here, and thanks a lot for inviting us, the Commission, to speak about this important topic in important times. And before starting, you know, I'm really touched. I think it's a topic which is very touching for all of us. We are doing this, you know, for people. Patients are in the center of this, and patients and people and communication and network and importance of collaboration together was mentioned many times today in previous panels and by previous speakers. And patients are in the really center cornerstone of all of this. And the rare diseases are rare, but as many people said today, rare disease patients are not rare. And I can see it myself as my son is. We are living outside Brussels in a small village, and my son is he just started the kindergarten, and in his group of 10 kids, 2 kids are suffering from rare diseases. So it can be our neighbor, it can be our family. We are all need to do everything to help the patient. So although this topic seems very regulatory, it is regulatory, and we will speak about the legislation. I really want to assure you that patients are the cornerstone of this pharmaceutical legislation and the reform of the legislation, which was decades long, and it was high time for this change. And although here you can see that 2020 as this timeline, the milestone, the first milestone of when we adopted the pharmaceutical strategy, which also coincided with the COVID pandemics, it started a bit earlier. Because you know that the legislation for the medicines for rare diseases, so orphan medicines, it started in 2000. And it was really a moment where we saw this boost in the creation of SMEs and work on rare diseases, research on rare diseases in the EU. There were many products under development. There are still many products under development. And it really created this ecosystem for rare diseases. But after 17, 18 years, we decided to have a look and see how actually it works Did it really deliver what it was supposed to deliver? Do we really have treatments for rare diseases that we need? So we looked into it, we evaluated how the legislation worked, and it was also mentioned many times today that we all see that we still have this high unmet need, because we really lack treatments for rare diseases. 95% are without treatment options. We have as well, those treatments which are there are often not available to all patients. They are not available to all member states, and some patients have to really wait for a long time. So this was really a trigger for this pharmaceutical strategy, and this revision of the rules for medicines for rare diseases was one of the pillars, one of the building blocks of the strategy, which is really this long-term agenda in this field of pharmaceutical policy, to create a system which is a future-proof system that will support industry in promoting research and technologies that reach patients, and these technologies which are really innovative and novel. So the reform was adopted in April 2023, and this reform includes the revision of the orphan regulation, which is now part of the main regulation on all medicinal products, as we know that all the other rules that govern and that apply to all medicines, these rules apply, of course, also to orphan medicines. So the objectives of this change were for improve access, improve availability, boost research in rare diseases, and as well create a system which would be future-proof, so would be really agile, that we can really accommodate the most novel treatments for our patients in the EU. So the situation that we have now is unfortunately the one which we see on the left. So this is really the big problem that we are facing, that we tried with this reform of the pharma legislation to help to address, as the European Commission does not have all the powers, and not some aspects are still laid down at the national level. So there are some pricing and reimbursement discussions which are the competence of member states, but what we can do, we can try to, and we tried to find ways within the pharmaceutical reform to help improve access and to help that patients, that we are more in the situation on the right, that member states and patients in all countries, EU countries, can get the medicine that they need at a correct time, and that really they are at the cornerstone, and we really decrease this high unmet medical need. And so when we looked a bit how the system works today and what we offer to companies, we saw that really we offer one-size-fits-all incentive. So independently, if it's a product, if it's a medicine, which was already for a long time on the market, and the company just made some small studies or really just used the literature to submit an application and have a really high incentives like the 10-year market exclusivity, vis-a-vis really companies who invest years in research and development and really prepare for patients innovative products which are really disease-modifying products. So in this reform, you can see that we really now differentiate, and it's really a modulation of the various incentives, where the 5 year of market exclusivity is given to these well-established products that are well-known, while the 9 years is given to all orphans, but there are additional years which are given if it's a product addressing areas where we don't see treatment options, where we have as well a launch of this product in member states where there are patients. So this is also this additional incentives to improve the access in the EU, and also they can get additional years of market exclusivity if they develop this product for different rare conditions. So now we can offer in this maximum 13 years of market exclusivity, which is really worldwide the highest incentives. What is also important in the field of medicines for rare diseases is their affordability, because you can see that often these products are really very, very expensive. And as well, this is something that we try to tackle in the pharma reform, that now we can see that there were some products which were authorized for various conditions. So their length of the market exclusivity was really doubling, tripling, and it was very, very, very long. What we could also see is that really this tenure of market exclusivity meant that generics and biosimilars could only apply for an authorization when these 10 years of market exclusivity finished. And now, with the change, we introduce a global market exclusivity concept, which means that all products from the one company for different orphan conditions, they all fall within the same market exclusivity, and any prolongation, which can go up to 13 years, will be on the whole portfolio, which will also give predictability to other companies developing in this area. And also, we have introduced this day one entry of generics, which could help in access and also affordability, which means that before the end of the 2 years of the market exclusivity, generics can already file an application to the European Medicines Agency for assessment and then for authorization, and they will enter the market at the day one when the market exclusivity expires. So this really saves also a lot of time. And this is actually, for me, the most important pieces of puzzle of different elements of this reform, which complement this modulated incentive system and which really would result in a regulatory excellence and the simplification of system, and as well creating a system which is agile and future-proof, because we offer various tools and provisions for the simplifications. We decrease the time for the assessment of those medicines. We decrease the amount of the committees in the European Medicines Agency who deal often with the same medicines at the same time in parallel. So all these simplifications and better use of resources will help those medicines get faster to patients. And most importantly as well, medicines which are, let's say, identified at the early stage, which would really address unmet needs, because they would really bring therapeutic advancements in areas where there are no treatment options, or they would really be breakthrough disease-modifying treatments. They would be they would access the PRIME system, which is now encoded in the legislation. So it means that they would receive this early help from the European Medicines Agency on their trials, clinical trials, on the data that they need to have really a complete application. And at this stage also, it would be an early point where HTA bodies would be involved, so that such application would be really a complete application of a level, and all the data needed would be there. So then this product would go really smoothly through the authorization system. What we also offer in the reform of the legislation is the possibility for the regulatory sandboxes, and this is really worldwide. We are the first in the EU in such a regulated area as the area of medicinal products, to offer this possibility. So if you can think of a really novel solution, novel product, which does not fit in the current legislative system and the legislation, we will not block these products, because this product will be there will be a special system called a regulatory sandbox, which will be created together with the European Medicines Agency, under which this product would be assessed, this product would be authorized, it would be all under control environment, and it could result in an adapted framework. So it could lead then to some adaptations of the legislation to allow these products in the EU. So all these small things, these small pieces of puzzle together, let's hope that they will really create a competitive system, and that we deliver the best worldwide solutions to our patients. And let's hope that it will go now smoothly in this legislative process. And with that, I would as well like to thank the Polish presidency, who is now leading these discussions in the council. And they are doing a really great job. And it's a really hard work and dynamic work. And let's hope it will soon go to the next level. Thank you.
Can I have the mic? Thank you very much. This is really interesting. One or two questions for you, particularly with this geopolitical situation we are living now. We all know, for example, that in Europe we are struggling for clinical trials because the companies do everything in the US and they come to us 10 years later or 6 or 7 years later. What is your view, or what are the possible policies to facilitate, I would say, public-private partnerships for the development on this? For me, it's a unique moment in Europe, but it needs incentives to bring these things in Europe to simplify the system, because otherwise I understand why they don't come. So this concept of public-private partnership, which sometimes is feared by many, not that much by the patients, it's more by the policymakers, although the rules already exist. I mean, university hospitals for clinical trials have already very strict rules how they collaborate on public-private practice. There are examples. Together for rare diseases, the Consortium for Epilepsy Trials we created at the initiative. So what is your view about this point of partnership?
Thank you very much for this question. I think it is extremely important, and it's also of utmost importance that we all work together from the different strands around the topic of rare diseases. And I would not say that we are afraid of the public-private partnerships. I can even guarantee you that in the preparation of all this work, during the evaluation of the orphan regulation, during the preparation of the pharma strategy, and then the reform of the pharmaceutical legislation, we worked as well hand in hand with colleagues from the research department of the European Commission, who are responsible for this public-private partnerships, who work closely with the Innovative Health Initiative, IHI, who has, I think, some already ongoing, I'm looking at Ellen, ongoing public-private partnerships, for example, on the clinical trials for ultra-rare diseases. So all this, we need to work together. So that's why we are trying to create this momentum for unmet needs, for addressing unmet needs through the legislation, but also we need those projects ongoing, because we need to, with this legislation, we are trying to create, an environment to bring companies, to bring research into the EU, and to bring those products into the EU, and to have them developed, to have them, to have the clinical trials in the EU. But we need the help, of course, from the researchers. We need the help of these public-private partnerships. I know that there are as well some already multinational projects as well on rare diseases, launched in 23, 24. So I think this work is ongoing, and it needs to be even more, and we are, of course, for it.
Good. Okay. No, for the sake of the time, that we can discuss it at the end, I think that we can stop the discussion here. Thank you very much again. This is really helpful. Now it comes nearer to my field. Where is Daria? There. So it's a pleasure to introduce to you the scientific coordinator of the ERDERA project. The topic is the example of the European partnership ERDERA to boost clinical research and innovation. And please, Daria, explain us everything about ERDERA, I hope.
Thank you very much, Alexi. And I will not be here an exception, więc zacznę po polsku, ponieważ
Let me start Polish because I'm Polish, and this year I spent half of my life in Poland and the other half of the year in France, and I would like to thank very much for the invitation, and I also would like to thank for the invite issued to ERDERA to cooperate with the organization of this conference. Thank you for giving us an opportunity to introduce to you what ERDERA is, and to give you also more information tomorrow as to what how as to how ERDERA gets involved in different scientific studies.
Now, and I was just saying that, well, thank you so much for inviting me here, and as a Polish citizen, but also French one, I'm very honored also to be here today. So actually, because to make sure that I'm going to be on time, I decided to prepare my what I'm going to say when I will be showing you the slides, because summarizing ERDERA in 5 minutes, it's a real challenge. So let me start. So ERDERA actually stands for the European Rare Disease Research Alliance. And its ambition and mission is to contribute to improve health and well-being of people living with rare diseases, but also to support the Europe as a world leader in rare diseases research. So the mission of ERDERA is structured around 3 main goals: the acceleration of diagnosis, but also the acceleration of the development of therapies, especially for the conditions with no approved options, and also better understanding of the impact of rare diseases on patient families and society, with the objective of collecting the socio-economical proofs to be able to influence the policies and making changes. So ERDERA is a 7-year program. It's, of course, Europe-wide. It's co-financed by the European Commission, and we have an investment of about 380 million euros, of which 150 come from the European Commission. And as you can imagine, to build a comprehensive ecosystem for rare diseases, it is necessary really to gather all types of stakeholders. So we have nearly 180 organizations from 37 different countries, and that includes funding bodies, ministries, but also research organizations, research institutions, hospitals, patient organizations, European research infrastructures, and also, very importantly, the small and medium enterprises and industry. So all of them are united by our mission. So here, this is the one when I will be speaking a little bit more. So ERDERA is really here to create a collaborative ecosystem across Europe to drive research and improve diagnosis and treatment and empower individuals with rare diseases. So I like to use this metaphor of ERDERA being built like a house that is built on a very strong foundations. And that means that each part is representing a key element of our work. Its foundations rest on national and international commitment and focus on mirror groups. We will be speaking also about this tomorrow, strengthening underrepresented countries and fostering global collaboration to enhance national capacities and drive long-term engagement in rare diseases strategy. High quality and reproducible research forms the walls of the house, with each project contributing to coordinated effort in diagnosis, treatment, and prevention. And ERDERA is going to finance, or actually we already started this, multinational research, but also clinical studies and networking to support underrepresented countries and rare diseases. Collaborating with the European reference networks and research infrastructures, ERDERA will advance data use and innovation to accelerate solutions for rare diseases. However, this support, this success depends on the solid infrastructures. So we provide not only support, direct support for funding of research, but also through the data hub, advanced therapy platforms, expert mentoring, and education programs for all stakeholders. We are supporting the development of the research. And finally, the roof of the house is a strong governance and agile coordination that is led by participating countries, and that includes also patient and public engagement group that ensures that all activities of ERDERA are aligned with the needs of those living with rare diseases. We also have a help desk that serves as a point of access for guidance and support within the rare diseases community. So since we are speaking about the innovation today and actually about the access to drugs, as you can imagine, the goal or the role of ERDERA is to contribute to the acceleration of the innovation. And so I just wanted to show you how those different elements of the house are actually connected into a single, let's say, innovation support cycle. So all the elements of the house together are connected in a way so that no excellence research is left behind. We finance research projects, but also support their quality and innovation by providing, for example, targeted mentoring that goes beyond scientific hypotheses and brings expertise in regulatory, ethics, biostatistics, or methodology. Our evaluation criteria are adapted to the nature and the topics of the calls for projects that allows us on the selection of the best proposals. Each project becomes a part of ERDERA and benefits from tools and services that are offered to enhance its outputs, and it may be also linked with the in-house research efforts that are delivered in ERDERA through the Clinical Research Network. And finally, promising projects benefit from the support and exploratory due diligence and whenever relevant, also possible further public-private collaboration that is offered through our accelerator. So in that way, we build and cover the whole research pipeline and accelerate the results for the benefit of rare diseases patients. And with that, I would like to thank you.
You kept really your time. Great. Thank you very much. No, because she's right. The project is huge. One question. You also have the experience of the previous European Joint Program for Rare Diseases. To what extent? Because one of the issues we usually face in Europe, despite the funding, is the continuity between the projects. So can you just briefly say one or two important lessons that you used when you developed the ERDERA project with all of us, but you had the experience of the coordinating the previous one? So.
Well, I think that one of the, the European Joint Programme on Rare Diseases, which was financed between 2019 and 2024, was the basis of the creation of this ecosystem. So actually, first of all, it allowed us to learn on many things that are now in this kind of innovation pipeline were pre-tested in EJPRD, which means that actually we know that they function well and that they were supportive for the community, and that's why we decided to integrate. But we also realized that accelerating innovation and accelerating research does not only mean, let's say, having those different pieces in one place, but that there needs to be further enhancement of the activities and also integration of the elements that were not present before. One of them is the regulatory compliance of the different research activities, making sure actually that we have the necessary expertise and that we start the dialogue with the European Medicines Agency, but also national agencies to make sure that actually the projects that we are financing are going in the right direction. And the other one, extremely important, is public-private collaboration. And this is something that, again, we started a little bit in the EJPRD, but also thanks to the different discussions and the initiatives that were developed in the meantime, like, for example, Together for Rare Diseases, where we have this collaboration between ERNs and the industry, but also Rare Diseases Moonshot. We were able to have not only the dialogue, but actually the inclusion of the industry in the ERDERA project. So we believe that now we have all the elements put together, and that means that our accelerator can also benefit from this public-private collaboration, and also the ecosystem is now complete.
Okay, thank you very much. That was my second question, but you already answered about the private-public, because it is important indeed. Thank you very much, Daria. And it's true that it takes this dimension for other projects, because, for example, a newer funded project, the Realized project, also included this, including this time participation of the MEA itself, the European Medical Agency. So I think that this is an important point.
Shall I speak in Spanish? I know where you are. So now my pleasure to invite Eulalia Olesti from the Regulatory Affairs Lead of Hospital Clinic in Barcelona, which is the brother hospital of the one I am working, on a very sensitive issue of the academic CIRT clinical development. They have a very good example, a very good model that we would like to hear about. Please.
Okay, everyone, thank you for the kind invitation. And yes, I come from a hospital clinic in Barcelona. And today we wanted to share with you the experience of the development of new academic CAR T cells, which are novel therapies that I will detail just right now what they are, to enhance access of these kind of treatments. Okay. Yes, so CAR T cells are a new advanced therapies that are currently being developed in many different indications for rare diseases, for cancer and oncological diseases, and it mainly consists on different modifications of cells with gene therapy to make cells more capable of doing a product that will target the tumor very specifically. And this is something that has been done with the pharma industry, but also can be performed in the academia, in the hospitals, by using very closed systems that are very controlled. So these CAR T cells have shown many, many favorable, impressive efficacy and safety results in many indications, but there are some problems in access these kind of therapies into patients. This problem of access can be because there is a high demand, because there are difficulties in distribution, because they are living cells, but also because there are difficulties in accessing them because of the price. So only a small fraction of patients that would really receive this kind of treatments finally receive it at the end. And that's why academia can play an important role. Here we put reimbursement hurdles of this kind of therapies. See, in Europe we have, you can see in the slide, we have about 6 products that are already approved by the European Agency of Medicines, but that finally reach patients, not all of them, and not in all countries. As you can see, there are many countries in the European Union that do not have access to these products that are already authorized. And this is a problem, because that means that these patients cannot be treated. It is calculated that about 6% of the, only 6% of the eligible patients would finally receive treatment. And as you can see, we have a lot of inconsistencies between the different member states of the European Union. One of the strategies that has been designed to try to improve access is also how to manufacture these kind of products. Nowadays, there is many developers that are trying to do these in-house therapies, so hospitals could treat their own patients and do also the in-house manufacturing of the cells. And this is one of the strategies that they propose to access these products. And it's the one that I will tell you today about, because in our hospital in Spain, we are starting to create a network of public hospitals that are capable of administering different CAR T cell products to make sure that the product is closer to the patient. So we have very geographically distributed hospitals around our country to make sure that they can produce and also administer these products. And so far, these are the 2 academic products that are more advanced in the development. RE1, which is a CAR T cell for replace or refractory B-cell acute leukemia that nowadays has the hospital exemption authorization, which really facilitate the access to patients. And then it's currently been going to the EMA for a centralized authorization. but also RE2, which is also another CAR T-cell product for multiple myeloma that also received the hospital exemption clause. Last slide, but not least, we have treated in our hospital and indeed in this network that I show you in the slide, more than 500 patients with these two products, not only in our hospital, but in other Spanish hospitals, and with different kind of disease, from cancer, hematological cancer diseases, but we have a portfolio of investigation for rare diseases also in the hospital, and much more indications that are currently not covered by any product, and that we want to try to facilitate it in collaboration with other hospitals. Just my final comment is thanks to everyone, but especially to make this possible in this academic role, that they can play a really important role to making sure that access to therapies is for everyone and for any time. Thank you for your attention.
Great work. Thank you very much. Thank you. Can you develop a little bit more for those of us that are not necessarily familiar? What are the main challenges for academics or academicians to develop advanced therapies like this, so that people are conscious of the complexity of the issues we are discussing?
Yeah, thanks for the question. Complexity and challenges are at the front line of our days. I would say that one of the challenges is especially the funding, because as you can imagine, academics do not have the funding capacity as other institutions, and because our aim is always to have a best treatment for patients, and not like a pharma that they do the products. But in this case, one of the challenges also is the regulatory framework where we can fit our products, let's say. It's true that in Europe we have the hospital exemption, which is a clause that it's designed for hospitals, that they can they can produce this access and they can do these kind of treatments. And one challenge would be to maintain this hospital exemption as it is, because it really helps academics to develop this treatment. We had developed many treatments. You can see 500 patients that receive it, and that would not have received any other options because it was not possible. So the challenge would be to really keep in mind academia when we are thinking about future and when we are thinking in regulation. Yeah.
And on the same line, in that extent, what you expect from the regulatory agencies as facilitating the whole process? I mean, we saw the table with the red colors, which is already an example, not necessarily only at the European level, but also at the national level, because we are coming back to the issue of both national versus European Union. But I suppose you expect things also from the regulatory agencies to facilitate these procedures and to give access to the patients finally.
Yeah, I have to say that the regulatory agents really realize that academia could play a role, because they are setting different measures to get closer. And they, for example, the EMA has launched a pilot academic platform, so interaction could be more fluid, because you have to think that academic doesn't have the mind of developing products, has the mind to treating patients. But now we realize that we have the patients and we have the cells of the patients, and we could try to treat them also in-house products. So I think regulators have noticed that too, and we're starting to speak fluently and to learn the regulator language, which sometimes is different than the academic or scientific language. And this is a thing very, very important to achieve. Yeah.
Thank you very much. Thank you very much again. Okay. So we come to the last but not least. That was the phrase, Enrique, this morning, no? And it's my pleasure to invite Katarzyna Piotrowska, Director of the Department of Drug Policy and Pharmacy from the Ministry of Health in Poland, to talk about orphan drugs in Poland this time, access, new development, and key issues. So please take the floor. Thank you.
Thank you very much, Alexis. I know that everyone has a problem with my name.
I know it too.
Yes. So thank you. Welcome. Thank you for having me. I would like to also thank Kaya for this touchy and beautiful introduction. And I just wanted to say that normally lately actually, I'm used to talking about pharma legislation because we as a Polish presidency were in the middle of negotiation. This legislation, which is really important not only for industry, but as Kaya mentioned, and also in our opinion as a Polish presidency, mainly for European patients. So thank you once again. But today I will want to maybe not dive, but just say a few words about the Polish reimbursement system and the orphan products in it. Sorry. The green one, thank you very much. I'm not really a technical person. So, reimbursement system in Poland is based on application system. So the responsible entity, so the drug manufacturer, its representative or importer, must submit an appropriate application for reimbursement and for establishing net prices of its technology in order to determine it for reimbursement. And decision to grant or refuse reimbursement is issued by Ministry of Health together with the opinion of advisory bodies such as Agency for Health Technology Assessment and Tariff System and Economic Commission. The institution responsible for the technical parameters of the budget is the National Health Fund. So you have the beautiful graph of the Polish reimbursement system. Decision process. Detailed issues related to reimbursement are regulated by the Act of the reimbursement. Currently, the reimbursement system does not differentiate between medicines used in the rare diseases and other population medicines. Medicines used in rare diseases must meet the same requirement as any other new therapy applying for the funding in Poland. The main requirements that the medicine must meet to enter the system, a reimbursement system, is admitted to circulation or is in circulation, is available on the market, has getting a number compliant with the GC1 system. And according to the provision of Reimbursement Act, the reimbursement of medical products is made by way of an administrative decision issued by Minister of Health based on an application submitted by the responsible entity. And the application submitted to the Ministry of Health must contain all the elements specified in the Act. An application for the reimbursement of a new active substance or a new indication for a given active substance is subject to assessment by the Agency for Health Technology Assessment and Tariff System. In the next stage of the procedure, all documentation is submitted to the Economic Commission, which conducts negotiation with the applicant on determining the official sales price, the level of payment, and the indication of the level of reimbursement for the product. The Ministry of Health, taking into account the achievement of the greatest possible health effects within the available public funds, issues an administrative decision on the inclusion in the reimbursement and setting the official sales price, taking into account criteria named in the regulation, such as the position on the Economic Commission, the recommendation of the President of the HTA Commission, safety of use, clinical, practical effectiveness, and etc. Importantly, from the perspective of the orphan drugs, the cost effectiveness threshold does not differ from other therapies, and it is 3 times the GDP, which is currently approximately €52,000. In Polish law provides additional reimbursement paths in order to reimbursement system. Path for therapies with high clinical value finance under the medical fund requires the submission of HTA analysis and completion of the full reimbursement process of 180 days. And only drugs selected in the one-time list of drugs with high clinical value from 2021 can apply for the reimbursement in this mode. Then a path for highly innovative therapies financed under the medical fund without the need to submit HTA analysis, dedicated to oncological therapies and orphan drugs, and with an extraordinary processing time of 60 days. And only drugs selected in the special list of highly innovative drugs published by the Ministry of Health every year from 2021 are eligible to apply for reimbursement in this mode. The path for determining the official net selling price for technology, that is an element of the total cost of the existing guarantee service. Also the path for drug technologies that were previously on the reimbursement list and received a positive recommendation from the president of the agency does not require the submission of HTA analysis by the responsible entity. A path for drug technologies with established clinical efficiency that have lost market exclusivity and have been on the public market for many years does not require the submission of HTA analysis by the responsible entity. Path for drug technologies and used for off-label indications. Orphan or not, and this is important to remember and to distinguish between orphan drugs used in rare diseases, so used in diseases that occur in no more than 5 to 10,000 people, and those who with orphan designation, so assigned an orphan drug designation by the EMA. Due to the innovative nature of drugs with orphan designation, it is planned to adapt national legislation in the near future to the special challenges associated with introducing them to reimbursement system. What kind of challenges we have in our Polish system with orphan drugs? Small patient populations, which is associated with a small number of and low quality of clinical data and the same HTA requirements as for other drugs. Therefore, cost effectiveness is not achieved in the case of orphan drugs. No or poor quality epidemiological data, no patient registers, uncertain population data when making reimbursement decisions, time-consuming procedures and reluctance of entities to submit reimbursement applications, high cost of the research and development process, which translates into high unit cost of therapy, difficulties in determining well-defined outcomes for a given disease entity, which makes it difficult to maintain the relationship of paying for a clinical effect for effective therapy. So there were challenges, now we have solutions. So the one of the solution that I was mentioned earlier is amendment to the Reimbursement Act, which we are proceeding. And in this amendment, we plan to introducing of the definition of an orphan drug, introducing of MCDA, so multi-criteria analysis, assessment of orphan drugs, introducing of the possibility of requesting the responsible entity to submit a reimbursement application on preferential terms, a policy of motivation and rewards, so we choose carrots, not a stick. No sanctions and no consequences, so lower fees, shorter processing time, making the process of mandatory reduction minus 25% for innovation drugs more flexible upon expiry of market exclusivity, concluding risk-sharing instrument based on clinical results, so paying for the for effective therapy, especially in the case of questionable effectiveness. In addition, we have a plan for rare diseases, so this is also very important part of the solution process. And in the end, I will just to give some statistics. So recent years have been really breakthrough in the number of new therapies covered by reimbursement. The Ministry of Health is constantly developing the list of reimbursed drugs, and each announcement, each list brings good news for patients waiting for reimbursement of products for the condition they suffer from. So despite the challenges associated with including new drugs in rare diseases, an increasing number of new oncological, non-oncological coverages for rare indication has been observed since 2019. Of particular note is 2022, when 150 new therapies were reimbursed, 37 of which were rare diseases. In 2023 it's one of the history year, 145 innovative therapies, including 43 indications for rare disease. And in 2024, the Ministry of Health made available to patients another 135 new molecular indications, 36 of which concern rare disease. Thank you very much.
Thank you very much. Leave the last slide on. My initial question was the previous one. It was my initial question was a little bit your view on how to overcome the barriers, the difficulties for access to drugs in Poland, as an example, between other European countries. But you covered part of it. You can say a word in addition to this, but I would also like to see if at a national level you see any role of the ERNs in those procedures we are talking about, of validation, definition of rare diseases. You talked about epidemiological data and so on. So if you can develop a little bit those 2 points.
Yes, well, I think that our main problem is with the application, because we have money for reimbursed these medical products. The time of the procedure, of the reimbursement procedure, I think it's really good and it's improving. But so I can give an example that a whole administrative procedure takes 240 days, contra 2.5 years of waiting for an application. So see, this is, I think, the main obstacle here, we are talking about. So when the company will, give an application, then the procedure is moving quite quickly, and we are really keen on reimbursed these innovative medical products. So we decline only 4% of reimbursement applications. So I think that the numbers are quite obvious. And to incentive companies, we in this, as I said before, in our draft of our amendment, we try to give some carrots and ask companies to come to the Polish market, and to give our Polish patient the chance to get the drug, because this is the end, all about the patient. So I think that our procedure is efficient, is quite quick, and now we are more thinking about, as I said, create some regulatory incentives, but also I think, like on European level, we can also think, and this is also from the Commission, European Commission proposal in the CMA, Critical Medical Act, about joint procurements for such medical products. Because I know that, for example, Poland, okay, we wait 2.5 years, but at the end, often companies came to our market, but on the smaller markets, patients has no chance to get the medical products because these markets are, you know, too small for companies. So I think that this is also a discussion, but on European level, how to, you know, how to tackle with this challenge.
Just a question from my side, because it's my ignorance, particularly for the drugs. Is there any procedure similar to the one you mentioned about orphan generic drugs, meaning that the moment that a drug is presented at the European level, the procedures of validation also start at national level without waiting the necessary validation from the EMEA, or this is not legally or technically possible? In gaining time, because of course, if the EMEA takes 2 years, plus 200 days, plus 100 more, plus the pricing, then we're already in 2 years for a drug. So is there any strategy of that kind possible, or it's unconceivable?
I know, this is...
Yeah,
it works. Okay, so it is a very valid point, and it is also one of the main objectives of the pharmaceutical reform. Because this is what we have seen, that we have a central authorization, we have a positive opinion from the European Medicines Agency, we adopt an authorization decision, and then nothing happens. 1, 2, 3 member states get the medicine, and then the others are waiting for years. So that's why, you know, we cannot push, we cannot oblige the companies, we cannot do that in a legislative act. But what we have introduced is this additional incentive for a longer data protection period, in case of orphans, for a longer market exclusivity, if they engage with member states. You know, they have 2 years after the authorization, central authorization, to engage with member states for national authorization and to supply. So with that, if this is done, with all member states have to be asked, and this dialogue needs to happen in each of the member states. And if that happens, they will be rewarded. So hopefully this will help. And what I also explained about these generics and biosimilars, what is important, this was already introduced by this called Bolar exemption, that all these even if originator, innovative product is still protected by the protection, the generics, biosimilars, they cannot enter the market, but all these assessments, they can already be ongoing. And this is really key for orphan medicine.
Thank you very much. Okay, before your gold points, any burning question from the public? You have Ruth, okay.
The microphone's coming, it's behind you.
Oh, here it is. Excellent. I have a very burning plea as an ERN coordinator and vice chair of the ERNs regarding the hospital exemption and the pharmaceutical legislation, because we are addressing with the advanced therapies a high medical need in the community throughout. And I know in the time of negotiation, there was opposition by industry to limit the hospital exemption. And I think it's absolutely crucial to maintain it. And why, I tell you in a very short story. We heard examples of CAR T-cell therapies. And there's another CAR T-cell therapy, for example, in neuroblastoma, my very specialty field. In Rome, developed, Germany and Austrian patients can go to Rome. They are reimbursed. A Belgian patient, same patient, high-risk neuroblastoma, cannot go because it's not reimbursed. So we are having here 2 issues addressed under the current legislation. And what is important, keep the exemption for these academic innovative treatments, because the field is accelerating extremely fast and helps patients with innovation. The second part is we still have the constraints of reimbursement under our current cross-border healthcare and S2 legislation. So if these cell products can go back to the home hospital, the costs are largely improved and access to innovation is improved. Yeah? So it's a twofold benefit that we can gain to improve the mechanisms in a patient-centric way. Thank you for these 2 minutes. I was not too long.
Thank you. Okay, so 1 minute each, because I am controlled, that's why. Please, Kasia, start. Yeah, well, whoever.
Yes. Well, I think that I could just sum up from my point of view as a regulator and like a Ministry of Health that what we need, this is cooperation between member states. Sorry, it's too much pharma legislation between ministry and pharma industry. And I really you know, urge companies to submit these applications for countries for the products, because we, as a Ministry of Health, really try to do our best to provide these medicines for our patients.
Thank you. I was quite long in my presentation, so I'll be very short now. So I really wish for a swift adoption of the pharmaceutical package and smooth implementation through different angles, a great collaboration between all the stakeholders, that we can really create a system and have as soon as possible a system which is future-proof, agile, and deliver innovative medicines that address unmet needs of patients and that reach the patients. Thank you.
Okay, so I think that what I would like to underline is that for me, still too often we separate care from research, and this is something. And we were talking here about the access to drugs. So when I think about research and care, that also encompasses all those, let's say, regulatory aspects and inclusion. So what I just wanted to say is that for me, in a way, well, care and research, and also the collaboration with the European reference networks. And we were talking a lot also in the previous sessions about Erdera, about Jardin, about the inclusion of in the system. It's like, you know, kind of homozygous twins, where the DNA are the European reference networks and the research aspects and care aspects. So I just wanted to say that let's not forget about the fact that this is one thing. When we are talking about the holistic approaches, we are talking about encompassing all of that. And I think it would be important that when we talk about also at the policy level, about research and care about rare disease plans, it is being encompassed and as one thing, as one ecosystem.
Thank you, Daria.
And last comment, and thanks everyone for listening, and especially at this time before lunch, which everyone I expect is hungry. But just a final message saying that we are lucky to live in Europe, that the innovation is every day in every hospital in all the members that we are part of Europe. And let's have in mind that hospitals, academic institutions can play a really important role in developing new medicines, because they have science and they have patients, and we can try to help them to have access, and access means developing new drugs for patients and for rare diseases that usually no one investigates on them, and for other kind of innovative scenarios that are really important for developing new medicines. So thanks for that, and we're looking forward for the new legislation, as you mentioned. Thanks.
Thank you, Lalia. So just a minute. I need my gold point also. And I will make the same plea I made at the Czech Republic when we had the similar meeting. Use the ERNs for what they can provide to the health policies. You have a European structure with the best experts in all areas of rare diseases. We are entering a period that we will have gene therapies, precision medicines, accredited hospitals that can provide those that cost millions, and everybody is conscious about this. You have a panel of experts who have no conflict of interest. This contrary to what happens if I defend something in my Ministry of Health, it is because I want to privilege my department or my hospital. The guys that are working at the ERN level are experts across Europe. They are not defending their own department. They are not defending their own country. They defend the patients that they treat, and they know what they need. So we can create, the same way we did for Ukraine, panels that can validate the conditions, for example, to accredit centers that tomorrow will give gene therapy. Panels that will validate procedures about new innovative drugs. Are they good or not? Having the clinical experience of this. So just use them because they are already there. You just need to contact 24 people and ask them to provide 3 experts each to do the work. And that is my message. Thank you.
Thank you very much.
Thank you, speakers.
Thank you very much. That was session 3, led by Alexis Arzimanoglu, Professor Coordinator of the European Reference Network for Rare and Complex Epilepsies. Thank you very much. And this is time for lunch, as it was announced just a minute before. This is time for lunch. We break for an hour and a half, so we meet at 3 o'clock. We have plenty of time to talk, mingle, and exchange views. I have one important piece of information for you. This is a message from Eileen. Near the reception, there's a table with all sorts of leaflets and booklets, and this is a booklet from Eileen. It concerns patient journey, patient with HSP, hereditary spastic paraplegia. A very interesting gathering of information for your attention. Here we go. So we meet at 3 o'clock here in the lecture hall. Ladies and gentlemen, welcome back. I hope that the lunch was very tasty and good, and it was warm, unlike the weather outside. We don't really get too often snow in April. This is some sort of an anomaly, but it was quite picturesque, you must admit. Whatever, we are just about to begin another session, session 4, Solidarity and Cooperation on Rare Diseases with Ukraine. And this session will be moderated by Minister Ursula Demkov. I pass the floor over to you.
Thank you very much for the invitation. I have to put all the papers. You know, we are here discussing about the rare diseases plans and actions to improve the life of our patient. But behind the Polish eastern border, the situation is much worse because there is a military conflict in Ukraine, and then those patients are in a very poor condition, and if possible, we have to support them and to share our resources with the country who is in the trouble with the patients. And then this 24th of February 2004, it was the day when the first bomb fell on Kiev, and the military contract began. And then the Polish government, a few days later, decided to open the borders for all immigrants from Ukraine. And then we see the flood of the people entering our country. In the few days, the population of Warsaw doubled because we are basically 2 million population, and then we had 4 million. And all of them, they were war refugees from Ukraine. And then we have to cope with this situation, and then they got immediately access to Polish healthcare system. And then we hosted them in our home, in our houses. We had no refugee camps, no people, homeless people sleeping on the street. So this was the biggest human conflict and the biggest human catastrophe I ever seen. But as you know, the conflict still persists, and then as a medical doctor, as a professor of medicine, I was involved in the therapy of few children from Ukraine. And then, in fact, the situation for the patient with very complicated medical problems requiring specific diagnosis and specialistic care, they are totally abandoned in the Ukraine. Therefore, I think that we have to move our hearts, and we have to also look at those patients, at children there, and just to make a brainstorm how we could help them. And before we will maybe discuss this problem, I would like to invite Dr. Tatiana Wilczyńska. She is from Kiev, and then we've met when she brought me a child from Ukraine who needed very urgent medical help, and it was a child with rare disease. And then Dr. Wilczyńska, please join me. Tatiana is supporting many children from Ukraine, and she used to work in that hospital who was completely destroyed by bombs falling during the war. So I would like her to tell you how the situation looks like in her country and how the children and adults also with rare disease, what they require, what they need, how we could help them. Please, Tatiana, the floor is yours. I will take.
First slide. Szanowna działa? Nie działa. To tak działa.
Madam Minister, ladies and gentlemen, on behalf of my team, I would like to thank the host very much.
I want to cordially thank to organizers for possibility to present today state of play with rare diseases in Ukraine and state experience of our patients evacuated to Poland. If we look at the definition both of European Health Committee and of World Health Organization, we will see that the care of patients with rare disease embraces 5 key components. It's surveillance, it's diagnostics, it's therapy, including curative therapy where it exists, it's rehabilitation, it's palliative care. And Ukraine was striving, even before the war, to provide care for patients in all those 5 components. In 2003, the first Center of Metabolic Diseases was created, and further in 2015, it was transformed in National Center of Orphan Diseases based on the clinical base of National Children Ahmedid Hospital, which you see in the photo. By that time already, we knew that 5% of population, or around 2 million people, were living with rare diseases. And center was making significant progress. By the time when the war started, we had cooperations with leading institutions of UK, of Europe. In Poland, it was Institute of Mother and Child. The center provided more than 1,000 infusions for lysosomal storage diseases, of enzyme therapy, of chaperone therapy. And the specialists of the center have had experience in 500 rare diseases. Given that we have 6,000 approximately nosological forms, it's a big share. But demand, of course, was exceeding the capacities. As you can see, only 16 state-funded programs were provided, and only 4,000 patients were treated, while there was already 500,000 of registered cases of patients with rare diseases. Again, it was only registered. It was estimated that real quantity is 10-20 times more. Of course, we had limited possibilities because for neonatal screening, we had only 4 diseases for which the state was screening for, and for actually nosological forms entitling the patient for access to state-funded programs, we had only 23 diseases in the list. And of course, we had very limited number of palliative care units, not those which just had contract with National Health Care Service, but those which were providing. Despite the war, Ukraine continued to struggle. And you can see that in year 2022, there were already 25 reference clinical centers in 17 hospitals of Ukraine. The neonatal screening was expanding up to 21 nosological forms, and the rare diseases list entitling the patient to receive care under state-funded programs also increased up to 302. And the last but not least, Ukraine started very important project of implementation of Orphanet as national classifier of rare diseases, despite the war. However, all next slides, this is, you see, the model reference center, one of those which was created for children with severe immunodeficiencies on the basis of regional state children's hospital number 1. Unfortunately, all other pictures will show you the state before and after, because under continuous Russian attacks on the infrastructure, of course, all 5 components I speak about were severely affected. And please pay attention, the number of patients was increasing and increasing with the war. 320% increase, almost 2 million of cases officially registered. Here you see hospital of Ohmedit, the center of orphan diseases, after barbaric Russian attack on July 8, 2024. This attack, of course, costed a lot because 2 medical staff were dead, 35 injured, including 9 children. And for 94 children, it meant relocation inside and outside Ukraine. It meant that almost €1 million restoration costs had to be found somewhere. And of course, for surveillance component, it meant delays in work over the unified state registry over this classifier. The same situation was for other components because, of course, destruction of medical facilities, including those which included those reference centers. You see 114 medical facilities fully destroyed, almost 2,000 damaged, influenced the access of patients to diagnosis and treatment as per EU protocols. Here I give only selected nosologists, like severe combined immunodeficiency. When the attack on Ahmadid happened, it meant for those patients 6 weeks delays in bone marrow transplantation. Currently, this is restored, but they have no possibility to do the tests inside Ukraine. The tests are sent to Germany with very, very large waiting period. For cystic fibrosis, situation led to the fact that pilot project intended for several Ukrainian centers was wrapped up to 1 center. The age limit was cut, the number of patients was cut. And the same is the situation with many other rare diseases. Of course, the access to orphan drugs also became limited. You see a Kyiv state budget for year 2025 allocated almost €1 million for patients with spinal muscular atrophy, and these patients currently cannot receive it, cannot receive risdiplam. For other diseases, the same. I gave as example patients with paroxysmal night hemoglobinuria. They were receiving the drug crovalimab in frame of clinical trial, which is now put on hold, and this is the only registered drug for this disease in Ukraine. With many other orphan drugs, situation is similar. On next photo, you see one of the units which was providing palliative care in south of Ukraine before and after Russian attack. Needless to say that this component is also affected. And of course, we have severe constraints with medical staff providing the care. In this photo, you see my team
providing consilium for the patient with rare disease before the war, and in second, it's very famous photo, solitary medical professional after attack on Ahmadid. Of course, our possibilities now very, very limited, and it created difficulties in planning care for the patients. Therefore, in March, straight after the war started, many patients, in fact, self-organized evacuation to Poland. Some palliative care units were providing it, Ahmadid also organized it, but normally it was very, very severe circumstances, and thanks God, patients received quick access to health care in Poland at all layers, from embassies, transport carriers, patient organizations, medical community, from society. As you see from Euroordis report of the same year, actually Poland was meeting our children in border and providing all aspects of aid, from registering these patients to providing medical access, social support, and volunteers. And I want to illustrate just on the example of our unit and patients which we received from colleagues who went to military or by some reasons could not care of patients, from patients which we evacuated to Poland. From the very first moment, we started to cooperate with Warsaw Medical University and, of course, with Polish children hospices. The latter, after the conference in March, started to provide care and supportive care for our children regarding all social, financial rehabilitation needs at the places of temporary residence, and Warsaw Medical University immediately ensured access to specialized institutions. Why? Because you can see that most of our patients came undiagnosed or poorly diagnosed. If you look at the structure, you will see that many diseases which were diagnosed, sometimes a few cases in the world, like Januar syndrome, or some mutations, de novo, like rare epilepsies, or some congenital abnormalities, also very rare tumors, very rare endocrine diseases. And this list is not extensive. I just give examples. All the children were receiving actually immediate referral to diagnostics. If you look at the structure by nosological forms, you will see that actually 80% of patients came either not diagnosed at all or not completely diagnosed, predominantly chromosomal abnormalities and neurological diseases. This is a structure by nosological forms, but very interesting slide is this one. If we try to classify those patients by ICPCN group of life-limiting conditions, you will see that most of the patients either belong to the group where curative therapy exists and it can prolong life and ensure quality of life if started immediately, or even for the group 4, where such therapy does not exist, any delay can cause the progression of the disease or severe complications. And that illustrates how important was this timely help of Warsaw Medical University. Patients were immediately sent for specialized institutions where they were diagnosed, and after diagnosis, if therapy was possible, they were receiving this therapy, including orphan drugs under state-funded programs. Of course, if it was not possible, or if care possibilities were limited, they were referred to other European Union institutions if it was better for patients. And of course, continuous monitoring was ensured to avoid complications. Actually, all our children who were evacuated from Ukraine were immediately supplied by these diagnostics, by access to care, and as you see, by supportive care, by Polish children hospices, from translation of documentation to support of volunteers to directing to financial support that embraced all aspects of care. And here I want to introduce to you one patient case. Please meet our Sonia, a little girl which was evacuated in February 2022. That was not patient of my unit. It was exactly, she was transferred to us by colleagues from Odessa after some of unfavorable events where she was unable to receive care there. And we received her in the age of 2 years, knowing that up to 1 year and 6 months, she was just observed with a diagnosis of myotonic syndrome. At this age, she was diagnosed, but clinical and laboratory data were very incomplete. We just saw that it SMA without knowledge about copies of the genes, without what type of SMA it is. And we were seeing that her condition was continuously progressing. We saw muscle weaknesses. We saw that the girl could not crawl. She could not stand. She said, you see, with difficulty with the support. So immediately we coordinated with Warsaw Medical University. She was referred to diagnostics. And you see, diagnosis was confirmed. It was spinal muscular atrophy, type 2. Immediately after confirmation, in May, she was already receiving risdiplam therapy, of course, under state-funded program in Children's Hospital in Krakow. And at the same time, she was receiving supportive care in Krakow Children's Hospice. At this photo, you see Sonia already in June of 2022, already with progressively improving muscle tone. You see the change, and in a year, the girl, on information that in Germany she can receive the therapy without age limit, the girl was relocated by her parents to Germany. In August 2023, she received Zolgensma. Of course, there were some moderate, let's say, side effects, which we dealt with in 2 or 3 months. And after normalizations of all the biochemical and blood parameters, second examination was made, and you see Sonia in this photo. You see already unaided seat, absolutely improved motor function in upper extremities. And you see, it's not seen from this photo, but she's striving to stand, and she's currently standing and even walking with support. And this is really a case of one victory, which shows how much timely access to treatment can make. Of course, Poland in March 2022 was trying to provide this access to treatment as soon as to the extent the state could. Now, currently, the possibilities seem to be wiser because there is a law on the assistance to citizens of Ukraine, which ensures the equal access to treatment together with Polish citizens. There is a united database, the organized evacuation can be assured, and there is a support both specific and general. However, Poland continues to face challenges because access to care is still long-waited, because of almost double quantity of the patients, because of overloaded healthcare system, limited opportunities in such overloading of funding, of equipment, of rehabilitation, and limited number of volunteers because of burnout syndrome. However, these children continue to need help, and I recall in this respect to the mentioned Euroordis report, which asked EU to demonstrate generosity towards Poland, and to World Health Organization report of this year, which asks us to ensure to those patients timely access to treatment, which is crucial in management of the rare diseases. What can EU do for Ukraine? What Ukraine needs? Of course, for the patients which currently reside in Poland and other European countries, it's access to specific programs, EU-funded programs where they can receive complex support, treatment, rehabilitation, medical equipment for everyday use. Of course, it's access to trials for specific diseases, especially for emerging treatments. Of course, it's patient advocacy and multifaceted approach, because I'm deeply convinced that only case managers approach may work in this case. For patients residing in Ukraine, of course, EU may provide access to the treatment, identifying structure of those patients by nosological forms and mapping them to existing EU programs. Of course, it's help in restoration of specialized centers destroyed by the war, and of course, also help to the clinical facilities dealing with the management of rare diseases. Finally, my key message is that the support of Ukrainian patients with rare diseases, wherever they are located, in equal access to health care, to social services, and to education, should remain one of the core priorities of European Union
rare disease plan. And only then those patients, like our patients in the photo, will be able to see life is going on and smile. However, I want to say that though it's evident that access to treatment can ensure patient clinical path and improvement of course of disease, there is one much more important thing. It can also change life path of the patient, ensuring the child life with human rights and human dignity, both of which remain core priorities of European Union and core values. Saying this, I want to cordially thank the head of Orphan Disease Center of National City Hospital Ohmedit Natalia Samonenko, personally to Minister Urszula Demkov, Undersecretary of Ministry of Health and Warsaw Medical University, and to colleagues from Warsaw Children's Hospice and other Polish children's hospices who were helping and have been helping all this time to our patients. Thank you for your attention. Slava Ukraini.
Thank you, Tatiana. We really could not close our eyes when this terrible conflict started and these children and adults also started to come to our country. The biggest challenge at the beginning was the translation to medical documentation. You could not understand. So we urgently needed some interpreters to come to our hospital and to support us. But of course, little by little, we were able to help. However, the Poland cannot be left alone with the needs of Ukrainian patients. And then there is, in my opinion, there is a great need for structured, well-organized help from Europe and from other institutions directed to those to those patients in need, because otherwise they could not cope. So I have a question to Tatiana. She already answered somehow, but maybe she could tell more specifically, so we could do for Ukraine what the Europe can do to help your patients.
Thank you for the question. I will try to answer, like in previous sessions, in several directions. First, of course, it's access to care of specific patients, and it means diagnostics, it means treatment, and it means multifaceted aspects of everyday life, because some patients may need specialized nutrition, which is currently lacking in Ukraine. Even Nutri-Drink becomes a problem, not saying about nutrition for children with specific diseases. It can be rehabilitation equipment, and not saying of rehabilitation, even CPAP masks for non-invasive ventilations, children's size. They were absent at the beginning of war, but it was possible to find. Now they're absent. And these are only some small examples, because for each patient, as I said, it should be a case management, and these needs should be covered. The patients can be mapped against existing EU programs, and funding, of course, for such patients can be provided, like it was done in Poland. Second, I would say it's methodological support, because as I mentioned, 500 diseases, our experts had experience, but there are a lot of diseases, even which we discovered in process of diagnostics, to which we have no answer, and Europe might have experience. And of course, this is support of hospitals destroyed by the war. That's how I would say of the priorities. And thank you for the question.
Thank you. Please have a seat. You know, when you have some emotion, the time is running so fast, and I didn't notice that the session is only scheduled for half an hour. So we have to now run faster, and I would like to invite, Tatiana Bakarewicz, also Tatiana. She is representing WHO. Tatiana would tell us how WHO is supporting Ukraine, and then we will have some example of directed help.
Dzień dobry Państwu.
Good afternoon, ladies and gentlemen. I can just speak to this microphone. It doesn't really matter. First of all, on behalf of Dr. Mina Birzuli, the head of the regional WHO office in Poland, I would like to thank you for inviting us to take part in this meeting. And by permission of Madam Minister, I will be speaking Polish, but if there are any questions in English, please do ask them in English. It's not a problem. So much has already been said by Tatiana before me, so my presentation will be shortened because of that. Yes, we are saying that in Ukraine, before the war, there were approximately 2 million people with rare diseases. How many of them are now in Poland or in the EU? It's hard to say. But if we consider that in Poland, almost 2 million people from Ukraine applied for temporary protection and national protection mechanism, we think that from 93,000 to 106,000 of people with rare diseases can be now residing in Poland, which is quite a large number. The most important accomplishment, and we really have to thank Poland for that and keep thanking Poland for that, is that Poland instantly opened its borders and opened its healthcare system to the Ukrainians, as well as the social support system to all Ukrainians, including those with rare diseases. People who have a Ukrainian PESEL number have equal access to healthcare benefits and social benefits equal to that of Polish nationals. Also, considering the data from various NGOs delivering support to people with rare diseases in Ukraine, we know that in Poland, such patients with rare diseases enjoy better access to medications than they used to in Ukraine, especially, well, depending on the disease entity. But talking about access, I mean that medications are available and that they are reimbursed, so the patient does not have to pay out of pocket. We also talked about it today that in Poland there is a relatively high number of centers, referential centers, belonging to ERNs, and that elevates the level of diagnostics and care that can be potentially offered to patients. I also have to say that the needs of refugees are evolving. They have been evolving over the last 3 years as the war was developing. Tatiana also mentioned the EEES report, so the European Rare Disease Association report. She reminded of some activities that were taken by NGOs in Poland, but as of 2022, there were also certain needs, for instance, access to safe residence for people with disabilities, or help of family assistance. So these were the needs back then. What was also needed was psychological support for patients, but also for their families and people who were supporting them. There were also deficiencies of certain medications and certain medicinal products, mainly because at first there was a high influx of patients, so the system was not as flexible as was needed and couldn't adapt quickly enough. Let me also quote data from the Avalon Foundation. Right from the very beginning of the war, the foundation supported people with disabilities arriving from Ukraine, and over the last 3 years, support was delivered to approximately 15,000 refugees. The needs that were typically reported by the refugees are information support in the Ukrainian language. This is still a major problem, and over time, that problem exacerbated. Because at the very beginning, it seems that there were more resources for specific disease entities that were translated into Ukrainian or even English. Now, unfortunately, that information in Ukrainian or English is more limited. So people who arrive right now or who arrived recently, they might have a problem with getting to know about the system and obtaining appropriate information. The second most common question from Ukrainian refugees or their families is access to rehabilitation, especially in smaller rural areas, smaller townships. Not all rehabilitation procedures are reimbursed by the National Health Fund. They are not all available everywhere, or the lines are very long. Also, availability of specialized equipment, because it's not always that families can pay for this equipment, so sometimes they do need help to obtain a financial allowance.
And the acquisition from the National Health Fund budget can be done once in some specific period. As far as children are concerned, it may not be sufficient because children tend to grow up, obviously, and they require different type of equipment or bigger equipment, and then the family will have to solve it in a different way. What are the problems the refugees with rare diseases and their families are facing now? There is a group of very specific problems that are typical for refugees. Those who have been in Poland since the beginning of the war face very similar problems to the Polish patients with rare diseases. What I mentioned earlier is the language barrier, which is still a problem. Healthcare and welfare systems are varied, and the people who have to go through the system need to be supported. The situation is even more dire due to the fact that, as we know, the recent decisions of the US administration reduced public financing of different humanitarian measures, including for the refugees from Ukraine, especially in Poland. The NGOs that traditionally focused on helping out refugees are reporting that they have to close down or reduce different aid programs for the refugees because they simply are short of money. Since half of 2024, the Ukrainian refugees cannot apply for additional allowances at the time when they are waiting for the disability certificate. Patient organizations notify it as a big problem for them. There are also cases, which are not very frequent, but they still happen, when the commission that confirms the disability of a specific patient, well, that person in Ukraine was certified as a person with disability, but it is not confirmed in Poland. And it also happens in case of people with rare diseases. Different Polish issues are very well described in the report of the National Forum for the Treatment of Rare Diseases, ORPHAN. This organization every year organizes audit on patients with rare diseases in terms of access to medical technologies. Yes, I am already finishing. So as far as this report is concerned, you can get acquainted with that on their internet site. And I think that's it. Thank you very much for your attention.
The moderator is... So I would like to invite the last speaker, Mrs. Ruth Ladenstein from EERN PET-CAN, Vice Chair of the EERN's Coordination Group.
Hello, I'm here.
Ah, yes, you're here.
Please. Thank you very much. So I will try to be brief for the sake of time. And the slide I can advance myself. So this is a summary slide on the situation, how we perceived it. So in September 2024, we had a summary of these interactions between the Pediatric Society for Pediatric Cancer, SIOP Europe, EERN PET-CAN, and particularly CCI Europe. It's the Childhood Cancer International Europe branch of patient advocates and families. And at that point, more than 1,600 Ukrainian pediatric cancer patients were supported through the Safer Ukraine program, which was launched by St. Jude. And that was extremely helpful with helping on the ground. So the numbers we have oversight in 2024, I have give my full appreciation and admiration to all the colleagues in Poland who really had the first wave, taking care of the patient, being active as a triage center, extremely supportive, and enabling then a great number of patients to advance to other countries to be taken care of. So in Germany, over 250, Italy, over 200, Netherlands, over 100. So you see the other ones listed. 724 were actually evacuated out through a special Safer Ukraine referral pathway, and I come back to this. But we know the real numbers are actually much higher because many patients arrived by own means in the dramatic situation. And we estimate, but have no clear oversight, that there are certainly over 2,000 pediatric cancer patients that left the country being on treatment and in urgent need. Even in the second wave, with the Okmatit tragedy, there were another 13 patients evacuated immediately out of the country because they were in difficult treatment situations and needed help right away. So if we overlook a little bit just to talk about emergency and crisis management, I think it's worthwhile to learn a little bit how these interactions actually work. These supporting actions for emergency response was launched in February 2022 and was completely devoted to help Ukrainian children with cancer and blood disorders to receive high-quality medical care, either in the Ukraine and abroad. And I think this interactive referral network was really manageable through St. Jude coordination and a lot of corresponding colleagues on the ground supporting and managing the whole very complex situation. So extraordinary interaction really devoted to patients. So overall, more than 1,700 assisted patients, more than 600 evacuated in convents, more than 200 organizations involved, more than 15 accepting countries. So I think it's a very, very brilliant way also to show that we are able to respond to crisis and to help when it's so urgently needed. If we look on the ongoing efforts, the request dynamics are in change. So the number of evacuations are going down, but still persist. So the need is not gone. But clinical consultations are coming up. And this is, I think, where the ERNs again come into the role with the program that was initiated for Ukraine, trying really to support capacity building in many ways. We know that what you need actually was, I think, the immediate actions to have a standardized evacuation guidelines. A lot was about translation, as previously mentioned, really to enable medical teams to understand what was the current need and which country could be receiving certain patients. Then I think strong support by the Tabladochi Association, and we had then another big initiative on the strategy to develop sustainable care and a consultation pathway. And having said this, I've just mentioned this in Austria, we had 63 patients from Ukraine, and in my hospital, 30 of them. This is comparatively small numbers, but they really needed intensive treatments overall. My credit really, I wish to give to Dr. Alexandra Müller. She is located in Freiburg, and through these initiatives became medical director also of the Safer Ukraine coordinating investigator together, and managing all these case by cases in terms as an emergency request, where to go and to advise, and interacting with the receiving hospitals throughout. So here comes the opportunity, I think, with CPMS 2.0 that we have currently upscaled. We have a system provided by the Commission for free to communicate and give advice. And this will be routed centrally through the Augmented Children's Hospital. So we are ready to go and to fly. I don't go through this circle. But I think this is really a big invitation to use this. We are working with our colleagues on the grounds because everybody is there ready to give advice, to buy in, and help also to in the future interactions wherever help is needed, and be it for an evacuation if this is the case, in very special interventions, but particularly in day-by-day care through the system. So I'm brief here for the sake of time, but I think this is a great opportunity how European reference networks also can help in crisis management, and we can help each other out in difficult situations. Thank you.
Thank you, Ruth, for providing fantastic help. And then I see you. But if there are maybe one short comment or question from the audience. Yes, there is.
I would just wanted to share with you very briefly the experience from the ERN Epicare, which is a bit different as a disease because many people have seizures. The good thing that we did from the very beginning is that we established a crisis center with the International League Against Epilepsy, the scientific society, which means it included at an international level, not only Europe, European Union, not only even European region, but even the US. And with this, we have regular monthly calls with our colleagues in Ukraine that are epileptologists to discuss with them what they need. They organized transfer of drugs because there was shortage of some anti-seizure medications. The ERN produced a document how you can substitute a treatment with an equivalent anti-epileptic treatment not to have a burst of epileptic seizures if you don't have the drug. So this was quite helpful, we think, for our colleagues over there. And at the level of the ERN, of course, we had at least 2 webinars that to inform the community. And now we are establishing a list of colleagues that receive all the information and can participate at the case discussions, at the working groups, of course, remotely, but to include them in the process of this. The main message being that collaboration with the scientific societies also helps a lot for those situations as a crisis center, similarly to what Ruth was presenting. Thank you.
Thank you very much. I think that there is no more time for further discussion. However, we just started the topic, and then we will continue to think about how to support Ukraine. And I will finish the session with the motto of today: no one should be left behind. Thank you.
Thank you very much. Ursula Demkow, I'm the Secretary of State, Polish Ministry of Health. Thank you very much, and let's go to session 5, towards reducing the time of an early and accurate diagnosis for patients with rare diseases. This session will be moderated by Virginie Bros-Feiser, CEO of Eurordis.
Thank you. Welcome to this session. So I wanted to, before we get into the topic as well, and I think we heard it this morning, but I just wanted to mention that the patient journey, we had a full session almost on this this morning, actually sometimes starts, or often even, years before they have a name for their suffering, so years before we know the name of the diseases. So today we will be exploring innovative approaches to addressing diagnostic delays, a challenge that affects countless families across Europe. Actually, countless. We do have some numbers as well. So I know that Aileen Tracy did mention those this morning, but I wanted to remind them again. So based on our latest Rare Barometer survey, which was published last year in 2024, that revealed an average time to diagnosis of 5 years in Europe. Importantly, that extend to 10 years for adolescents and teenagers. And over 70% of respondents have faced initial misdiagnosis or their concern had been dismissed. And 40% were not referred to specialized center. So ERNs are extremely important, but it's also even more important to direct patients to ERNs so they can have the care that the ERNs have the expertise to provide. So together we will examine how advancements in science and technology, but also innovative approaches can improve equity, shorten diagnostic delays, and enhance patient outcome across Europe. So we have 4 expert panelists which will bring unique perspectives to those issues. So to get us started, I would like to invite Maurizio Scarpa to join me on stage. Maurizio is the coordinator of the European Reference Network for Metabolic Diseases. He will talk us through the evolution of newborn screening as a public health program and highlight the promises and challenges of genomic newborn screening. Over to you, Maurizio.
So thank you very much, Virginie, for this nice introduction. And in particular, thank you very much to all of you for having thought to a session like this, because I think that it is extremely important to keep the continuum with all the previous European presidencies, starting with the Czech Republic, to speak about newborn screening, which is, I think, one of the revolution in public health that we had in the past 60 years. And as a matter of fact, we have a lot to celebrate, because last year there was indeed the 60th year of the celebration for newborn screening. Since 1960, when Bob Guthrie was diagnosed from one blood drop phenylketonuria, over 750 million children have been screened so far. More than 60,000 children have been saved just because they can receive a diet which will correct the defect of phenylalanine. And this has been indeed a revolution, because if you see here, you see on the right a child diagnosed and receiving the diet with no neurological symptoms, and on the left the child that did not receive, unfortunately, the newborn screening. At the moment, today, almost 70,000 babies are identified and treated each year in the world. And so we have one every 8-minute child who is saved with, due to the newborn screening. So I think that this is really a very important revolution, and it is one of the major public health advances of the 20th century. But what is now the situation in Europe? Actually, the situation in Europe is not uniform, as you see here. Probably you will see some numbers that recently have changed, but the trend is this one. You see that there are countries like Italy that are pioneering in newborn screening, and countries that still have to enter in the newborn screening situation. And not to make a newborn screening means really to decide for the life or the death of children. And one important thing is that very recently, on April 5, even in the US, there has been the termination of the Advisory Committee on Heritable Disorder and Newborn Screening in Children, which is actually the committee advising the RASP in which diseases we need to make screening. So this is really a danger to go back and to decide for life of children. In Europe, we have different situations, not only in terms of number of diseases, but also in terms of expertise of physicians, and also in the differences in day of sampling rather than analysis. So we really need to work together with all the ERNs, together with the International Society of Newborn Screening, together with the patient organization, to correct this, because it is really unreasonable to have in Europe technology, expertise, but having this kind of differences in our member states. Now we are also facing another revolution, which is a change regarding newborn screening. So far, the newborn screening is done to identify some metabolites, so some compounds which are toxic in our blood. Now, with the omics, we can really go to detect the single point mutation in the DNA, and we can actually make a number of diagnoses which is really incredibly high. Now, I wrote here from 200, from 900 conditions, but actually we know that we have more than 25,000 genes in our genome, so we can be really in the possibility of diagnosis all of them. The effect of having an early diagnosis is, of course, extremely valuable in terms of public health. If you detect a child before symptoms, you can treat with the protein who is missing or with the gene therapy, and there are now different ways of correcting the genes, introducing a new copy of a normal gene, or even going to correct the single mutation. You can even understand a little bit what is the condition itself. Now there are a lot of studies going to connect genotype, phenotype, in order that from the genetic disease, the genetic cause, you can predict the phenotype and how the disease will progress, if possibly. Then you can, with metabolomic, understand also the differences between the disorder of the same condition, and you can also make a prognosis in the family. Of course, there are several now programs to detect, to study the potency of this approach, and already from the one that I've listed here, there have been quite a lot of progress in developing therapies, and God knows only how much need we have of therapies for our children, because 95% of our patients do not have any therapy so far. Of course, there are opportunities and challenges presented by genomic newborn screening. We see here that the opportunity is to broaden the condition, but the challenge is also facilitating the informed consent. I mean, the newborn screening is not a technique, it is a system. The couple having a child need to be informed properly, and not only at the moment of delivery, and especially on the pros and cons of the newborn screening itself. The new condition and the new test can detect not only the disease you are looking for, but you can detect also mutation that you don't know how to understand, and so there is a challenge in calling back the family and the child in order to understand better the diagnosis. And then there is, of course, quite a lot of other opportunity, which is to go with the newborn screening to a greater precision of treatment. But of course, you need also to increase the multidisciplinarity of your team. And then with the other opportunities, you generate quite a lot of data that are extremely important in understanding more about the history of the disorders, more about the history of the disease inside the family. But all these data need to be stored, and for this, actually, as ERNs, we are preparing ourselves to newborn screening, and this is the module of the registry that we have inside the MetaERN, and as you see, we have introduced a specific module for newborn screening, which is the first in the world collecting data out of newborn screening children. The newborn screening is a system, is not just a test. You see here all the pathway that we think are important. As I said, it is something that is coupling to the pregnancy, coupling to the delivery, coupling to the first weeks after birth, and need to be comprised and understood pretty well by the family. So, I mean, it is really something that is involving a team, and it is not just involving a laboratory. So where do we begin? First of all, we need to have a debate regarding how we can really correct, if possible, the situation in Europe, how to support the policymakers in making this kind of decision, which is really a life important. But in particular, what we have to do based on the ERN is to establish a newborn screening expert group. As it has been said in this today, in the ERNs there are all the expertise to understand how to handle, how to decide, how to judge, and how to make a treatment of the DNA, of the newborn screening. And then, of course, we need to have interoperability of registries in order to gather results and gather data, and also to start working all together in order to understand better genotype, phenotype, and natural histories in order that the therapies can be developed and applied as soon as possible. So I think that fortunately we have the ERNs. We have a program already of ERNs working together on newborn screening together with patient organization, the Screen for Rare, and now we are launching some pilot studies and a newborn screening ERN-based expert group for this. Thank you very much.
Thank you. Can you hear me? Is that working? Yeah. Thank you very much, Mauricio. I think it was really important to remind ourselves as well how much successful newborn screening is as a public health program, that we need to nurture and foster this as well, but also that the process is quite complicated and fragile in respecting those different steps. If I may, I wanted to ask you a quick question. I think from the patient perspective, one of the things that is really striking is the disparity, inequities in terms of the number of and the type of diseases that are part of the different lists in newborn screening programs across Europe. So how, in your perspective, how can that disparity be addressed to ensure that all the newborns, regardless of their location, like I think it was Adam Yarouba this morning that talked about the geographical lottery. So regardless of where you're born or your socioeconomic status as well, how can they all benefit from an early diagnosis?
Well, of course, I mean, if you have such a geographic map, it is not because someone is sloppy or whatever. There are for sure a lot of reasons, economical reasons, cultural reasons, resources reasons that are causing this kind of disparities, unfortunately, inequality in Europe. So one thing that we can do is actually to start approaching the different member states in order to produce to them all the evidences of the need in expanding the diseases, because it is a matter of life or death. I mean, we have now, together with the ERNs and the different members in the different member states, all the expertise to expand even the expertise in countries where they are not prepared. So I think that we have all the instruments really to start discussing with the governments and understanding how we can help. And for example, we did this a couple of years ago with Romania. We visited the Romanian government, the Ministry of Health. We discussed with them, together with a representative of Eurordis. The discussion is ongoing, and there is a progress decision of expanding from 2 or 3 diseases to 32. Of course, this requires expertise and teaching and knowledge by the physicians, but I think that the ERNs and all the other laboratories and physicians expert in this can assist and really shortcut the time that is needed in order to expand the newborn screening. And we have the CPMS, where we can discuss cases that are described, are defined, and we can help with the sharing of the data.
Okay, thank you. Thank you very much. So now I would like to ask our second panelist, Felipe Gomez-Martin from the Spanish Ministry of Health, who will share the Spanish experience, including the development of a national genetic and genomic test catalogue. Thank you, Felipe.
Thank you very much, Virginie. Thank you very much for the organizer for inviting me to participate with you all. I'm going to share with you some of the initiatives that we are carrying out from the Spanish Ministry of Health. So we all know, as Virginie said, also the erratic journey of a patient with a rare disease, 70% with more than 1 year to get a confirmed diagnosis, with an average of 5 years. So how can we make this journey shorter, easier, and safer? Well, thinking about 3 facts that affect directly on the diagnosis of rare diseases, we can improve some initiatives to improve the diagnosis process of the rare diseases. 2 of them are directly related with rare diseases. 70% begins in early childhood. So from the Spanish Ministry of Health, we have enlarged the newborn screening program. 80% of rare diseases are of genetic origin, so we have compiled the common catalog of genetics and genomic tests. This one depends on our country, Spain. We have a very decentralized health system with 17 regional health agencies with full competencies, and also a very heterogeneous distribution of population. So we have performed the center service units of reference to give cohesion and coordination to the system. Regarding the newborn screening program, we have, since 2007, a legal procedure to updating the newborn screening, the health benefits, the new technologies, that involves the health technology assessment agencies and a screening panel that have to assess these new screenings and to propose them to the Public Health Commission and the Funding Committee. If they approve both of them, then the Interterritorial Council is going to propose to the whole country. But what happened? Since 2014, we had only 7 endocrine metabolic diseases as mandatory for the whole country and the neonatal hearing screening. That was an equity situation because we had 5 regions that performed only the mandatory screening, with the remaining 12 screening for larger numbers. So in the past 2 years, we have enlarged the screening program. We have accelerated the procedure in order to get equity to all the babies, independently, regardless where are they born. So last year, we introduced 4 new endocrine metabolic diseases. We introduced, as a second step, the prenatal screening for chromosomal abnormalities with cell-free fetal DNA. This year, we introduced another endocrine metabolic diseases and the screening for congenital heart disease by pulsioxiometry. It's approved now and is going to be implemented at the end of the year, another 6 endocrine metabolic diseases and 2 congenital disorders. The common catalog of genetic and genomic tests started in 2021. It has involved more than 100 specialists, 33 scientific societies, and the 17 regional health agencies. It's a tool made by the Ministry of Health to ensure equitable and homogeneous access to the genetic tests within the public health system. Now we have listed 904 tests classified in 18 areas, but it's not only a test, it's a process because it's needing informed consent and, most importantly, information and genetic counseling to the patient and their families before and after the test. The main objectives of the catalog are to assure equity and access. It's not meant that all the labs have the tests, but all the patients have the right to them. It allows the diagnosis, rare diseases or oncological diseases. It allows personalized and monitored treatments and also reproductive decision making. And of course, increased knowledge for research and treatment. The catalog must be adaptive. It must be able to adapt the new advances in genetics. It must be dynamic to update and not become obsolete. And of course, based on scientific evidence and personalized medicines. We have 7 types of genetic or genomic analysis. The catalog is open online for the public, and for each test we can find in the catalog which area or group of pathology it depends, what are the disease with its ICD-10 code and ORFA code, what are the clinical criteria to prescribe the test, what type of analysis it is, what's the clinical utility, what are the affected genes or regions, what type of genetic disorder we are going to find, what's a sample we need, what are the techniques that we can employ, and if there is any drug or treatment related. The whole procedure was established in last year, so we appointed a working group with specialists, scientific society, regional authorities, also the health technology assessment agencies, and representative of the Ministry of Health. The working group was divided into groups for each area, and they were in charge of the content and the structure of the catalog. Its decisions were passed to the funding committee, and once approved by the Interterritorial Council to its implementation in the whole country. I said that we have 18 areas. By now we have completed 13 of them, and we have started the updating of 2 of them. The advisory board on genetics is going to be launched on May. It's going to replace the working group for the catalog update, for assure quality of the new tests and identify needs, and also for counseling. Right now we are developing an information system, CNS, not only for search data, but also to create a library of genetic variations in the Spanish population. And last December, we approved the specialists of medical genetics and clinical laboratory genetics. Finally, the reference center service and units is a model project that started in 2006 and pretends to concentrate expertise ensuring quality, safety, and efficient healthcare to improve the care of low prevalence and rare diseases. It has also a very tough procedure if you want to become a reference center, and every reference center every year has a monitoring of activity and quality. Right now, we have 358 reference centers in 52 hospitals for 77 pathologists or technologists, and a lot of them participate in the ERNs. Until now, it has the patient that must be referral to the hospital, but we are implementing now a digital platform very similar to the CPMS to consultate the patient and avoid unnecessary travel, to connect different professionals and to connect the professionals with the patient. So our main objective, our main goal is to make these 3 initiatives as a whole, putting the families, the patients, and the society in the center. So thank you very much for your attention.
Thank you, Felipe. You can stay here if you want. I think it is very impressive and very interesting. So thank you for sharing what's been happening in Spain. I wanted to ask you, because I would assume that with this increased offering, you have an increased demand as well, obviously, from the population and the community. So how does that impact the workforce, in hospital and in the healthcare systems? And how did you manage that increased demand and offering while managing the current workforce, or were you able to already 10 years ago foresee that and you have more trained healthcare professional to deal with it?
Well, I think it has been necessary organization and also funding. Organization, as you have seen, we reunite a lot of all the stakeholders to align their interests, their efforts to plan the work, and also funding. For example, for the common catalog, in the first moment we assigned 40 million euros, and in the second phase another 46 million euros to hire staff, to acquire equipment, modernize facilities, to the information systems. For example, for the reference centers, every year we dedicate a special budget that varies on their activity. So, for example, last year they received 41 million euros. So I think that know what we want to do and to have the resources are essential.
Okay, thank you.
Thank you.
Makes sense. Thank you very much. So our third panelist today is Bruno Rodriguez from the Ministry of Research and Higher Education in Luxembourg. Is he here? He's online. Okay, sorry. I didn't get. Hi, hello. Hi. So you will present the European 1+ Million Genome Initiative, and also focusing on the latest project to tell us a bit about their role in fostering cross-border collaboration through genomic data infrastructure. Thank you, Bruno. All yours.
Thank you. Do you see my slides?
We do, yeah.
Oh, great.
Thanks.
Well, thank you for inviting me and giving me the opportunity to talk about the 1 Million Genome Initiative. I'm sorry I cannot be there, but unfortunately I had other commitments, so I'm happy that we can have this hybrid approach. So today I'll talk about the 1 Million Genome Initiative and a bit about all of the projects, but focusing on one specifically, the genomic data infrastructure that this initiative spawned. So this initiative started in 2018. It was first a signed statement by 13 European countries. And the goal or the objectives of this initiative was and is to build and adopt technical infrastructure, but also legal infrastructure to make federated access to genomic data possible. So, and this genomic data would be, of course, and European-wide. By federated here, what is meant is that the data would stay within each country. And so whenever a researcher or a physician would need access to the data, that access would be federated as well. So it would not be centralized somewhere. What is also important is that this is not just about research, even though, of course, researchers would benefit a lot from it, but one of the objectives is really to integrate this into personalized healthcare and healthcare systems of the participating countries. So the goal here is really to not only serve secondary use, but also primary use of genomic data. So this initiative was signed 7 years ago, and the end goal, of course, is to have access to 1 million genomes. And so how does that work concretely? Well, there are several projects that were started within this initiative. There was the Beyond 1 Million Genome, which was focused on finding use cases. There is the European Genomic Data Infrastructure that is coming to an end at the end of 2026. And then there's also the Genome of Europe. And there's even a new project that started very recently in April, beginning of April, the Beyond 1 Million Genome Plus, which is, and I'll talk a little bit more about that in a couple of minutes, but it's focused on setting up the infrastructure to make this sustainable in the future. So the Genomic Data Infrastructure project, which is currently ongoing alongside the Genome of Europe, is really focused on the technical and on the legal infrastructure. And so the way this happens is that each participating country will set up a technical node. So technical meaning with capabilities to host, to save and host genomes, to sequence genomes, but then also to analyze genomes. And the Genome of Europe, I am not directly involved in this project, but some of my colleagues are. This is a project whose goal is to set up and have a European reference genome. And the data of the Genome of Europe would eventually flow into the technical infrastructure of the GDI. So just to give you a little map, the GDI by the end of 2026, these are the countries that are participating. The countries in pink, those have committed to be fully operational from a technical perspective. So meaning that they would have real data with real users. Then you would have countries that would be onboarding. So they would still, be thinking about how to implement nationally the infrastructure. And then you have countries that would be in a deployment level, and those would be still, so would have addressed their national challenges, but then would need to connect, so to speak, to the European infrastructure. And so this is the GDI project, but then what happens at the end of 2026? Well, by the end of 2026, and we are actually already in the process of setting that up, we will have a new entity, a new legal entity called the Genome EDIC. So the Genome EDIC will be a new infrastructure, and that will be hosted in Luxembourg. And this infrastructure will essentially take over the legal and technical infrastructure that is being built within the GDI, and will continue to drive it. So this EDIC, that is a new instrument that was made by the Commission to set up multi-country projects. And so this is the instrument that was chosen for this new infrastructure. The way this is going to work, we hope, is that the genome EDIC will be able to, not only coordinate the different countries, the different members, but also be legally responsible for data disclosure to the users. So there are several ways that we are thinking about that. Probably the first option that we are going to go for is to use consent. So we would, ask for the subjects, for the data subjects, if they are okay with their data being shared within this infrastructure. But ideally, we would like to move towards an option that would be legal, so a new legal regulation from the Commission that would essentially give the EDIC the legal mandate to provide data disclosure. And finally, the other option that we are also studying from a legal perspective is instead to go for a new model which would essentially be service provision directly to the data subject. So in that model, what we think could be feasible is that instead of having the traditional model of having data holders and then these data holders would disclose the data to the researchers and to the physicians, what we would do instead is we would directly have a contract with data subject, with individual data subjects that would say we are okay with our data being used for research and for policy-making purposes and for healthcare purposes. And so the data subject would instead give the EDIC directly the mandate to disclose their data for healthcare and research purposes. So this is an option that we are exploring with our legal teams. And we think it could be a potentially very interesting option, especially in cases of rare diseases, where we think users would be actually very happy to share their data and to be able to contribute their data to make research and healthcare provision better. So this is all I had to say about the EDIC. But of course, if there are any questions, don't hesitate.
Thank you. Thank you very much, Bruno. So I'm a bit torn because I have a couple of questions, but I can only ask a very quick one, I think. But maybe to follow up on what you just said right now about the genome EDIC as a legal instrument, how do you think it's going to shape the future of genomic research and clinical applications in Europe? What are your hopes and dreams, maybe, for this latest instrument?
Yeah, so if we are able to set up the EDIC as we envision it, we really believe that we could have a huge impact, because we want to have essentially we want to serve several use cases. There's, let's say, the traditional, research use case where, of course, a research team would apply for data access and then they would get, access to the data and they would do research. But we really want to also have a huge impact in primary healthcare. So what we envision is that a physician could, for example, log in, right? They would be authorized to log in and they would be authorized to query data and aggregate statistics quickly. So for example, if they have, let's say we have a newborn screening program in that country, they could immediately, check for variants, check for, is this what I see in this newborn genome sequence? Is that a real anomaly? Is that a false positive? So they could query, aggregate statistics directly without having to go through a very lengthy process of data access. And this could be possible if we are able to set it up as we want, meaning in a federated way, where the query essentially that the physician would then be sent out to each individual country where they would need to get the data. And this is especially important for rare diseases, because rare diseases by definition only have very few patients, of course, and so we really need to pull European data together in a harmonized way to make such queries interesting and to provide insights. So we really hope that we can make a big impact there.
Thank you. Thank you very much, Bruno. That answered my question. Indeed, there's a huge need. So I also hope that it's going to work for the best and for the purpose and the goals that you mentioned. Thank you very much. We have one last speaker. I just checked to see there's no, yes, great, she's here. So our final panelist is Lene Cividanes, I'm sorry if I don't pronounce it correctly, Head of Research and International Relations at the Danish National Genome Center. So you will tell us about the pioneering work, I think, that you've been doing at the center using genomic data for diagnosis and personalized medicine.
Yes, thank you. Well, thank you. First of all, thank you for the kind invitation, and thank you to the presidency. I think it's a very important theme you're putting spotlight on here, and I'm looking very much forward to continue this in the Danish presidency coming up after you. So let's see. No? Aha, here you go. Okay, well, I will try to give you a kind of a snapshot on how we have been working with the transition from one-size-fits-all to personalized medicine in Denmark, obviously with a focus on genomics and rare diseases for better or faster diagnostics for the patients. And I tried to put my entire presentation in one slide. I didn't really manage, but it's a kind of busy, I know that. I'm sorry for that. Yes, okay. So in Denmark, we have this very long tradition from putting everything into registries, everything, all kind of data generated in healthcare settings in Denmark are put into registries, and all samples are put into biobanks. And building on this, we had a strong community, both researchers, patient organizations, clinicians, saying, we need to look into precision medicine. We need to kind of do the transition of the entire healthcare system, and lobbying strongly for that. They succeeded convincing the politicians in Denmark around 2017 in making a strategy for implementation of personalized medicine in Denmark. And that led to the politicians passing on a law in 2018 on establishing a national genome center, giving the center a very strong mandate directly in the law, saying that all comprehensive genetic tests in healthcare settings in Denmark have to be submitted to the National Genome Center, to this genome database. And then the center was established in 2019, and parallel with this, we had let's call them negotiations ongoing with the Danish Novo Nordisk Foundation, and they actually decided to allocate 130 million euros to this project. So the money was meant to build up the entire infrastructure, meaning the physical infrastructure, the supercomputer, the genome database, everything, and also for the implementation of 60,000 whole genome sequencing into the Danish healthcare system. And then at the same time, the region said, okay, this is wonderful. The regions are in charge of healthcare in Denmark, sorry. And the region said, okay, this is wonderful. We want to back up this initiative. So they allocated almost the same amount of money as in kind to kind of, get this going in healthcare settings. So the clinicians, they allocated their time, they started implementing in different kind of specialties the genetic tests here. And then, yes, the money was paid out, and we started building the physical infrastructure. And also, we said, okay, who should actually benefit from whole genome sequencing? Who are the patients out there? So we had this huge democratic process in Denmark where all clinicians, medical societies, researchers, they suggested, these are the patients that should benefit from this. And a lot of suggestions came in. They were all kind of grouped. They were sent out for review. We had experts from all over Denmark sitting together doing the analysis, and we ended up with 17 different patients groups that should benefit from this, paid by this huge grant from the Novo Nordisk Foundation. And then we had specialists from all the 5 regions we have in Denmark, from almost all the hospitals in Denmark, sitting in 17 different specialist groups, deciding on inclusion, exclusion criteria, etc., to make sure that the offer was exactly the same all over Denmark, because we tend to implement, on one, research-heavy hospital, but we wanted to make sure that this could, benefit all the Danes, everyone suffering from rare diseases and genetic-caused cancer. And also, parallel with this, we also built up this huge governance because we wanted to make sure that this, even though it came from the political side, it was very much a top-down initiative. We wanted to make sure that we had all the regions, all the clinicians with us. So the governance around this is big. We have patient societies in the advisory boards. We have an international advisory board. We have a research advisory board, and we have a lot of working groups around this. And then we started implementing. So we started with all 5 regions coming on board with these 17 groups. The first group came on board in 2022, and then we slowly onboarded all of them, and we had everyone on board in 2024. And we also started collecting the data into the genome database, because the smart thing here is when you are a patient, it's by law mandatory that the data has to go into the genome database. So you consent to have your data put into the genome database, and you can actually not say no to that in Denmark. And you also consent to having your data used for research. And most patients are really happy about this. But some patients think that, I want to keep my data private, and then they have to opt out. So the data stays in the genome database, but it cannot be used for research. And we actually consider this implemented now. So now it's a standard offer to 17 different patient groups across Denmark. Everyone suffering from the same disease get the same. So we have actually faster and more accurate diagnostics now. And we think that around 30% of the patients getting a whole genome sequencing done actually get a diagnosis faster, and they even get a diagnosis, because a lot of patients don't get a diagnosis yet, of course. And these are the 17 patients group that we're working with. As you can see, most of them are within the area of rare diseases, and we also have some cancer groups. So how did this actually change the setup in Denmark? Well, now we have a consistent and systematic offer nationally, meaning that we offer the same to all the patients. It's faster and it's more accurate diagnosis. And the patients actually find this extremely meaningful, because they often get a better treatment, but they also get, a way of talking about this rare disease that they're suffering from, because often it's really hard, as we've talked about many times already today, spending 5-10 years not knowing what is going on and not being able to put words on this also when you talk to other people. So patients have also expressed, the value of just getting words for this. And also, of course, increased knowledge of genetics in several medical specialties. It's a lot of specialties haven't had the tradition of working with genetics, and this has really increased the knowledge level. And also collaboration across the country. Clinicians that didn't work together before, they work together across the country. They reach out to each other, and they can share the access to the data in the genome database. And then, of course, having all this data in the genome database makes research possible. So we have the data in the National Genome Database, and now, today, we can connect it manually with other registries in Denmark. And now, the 1st of April, we started a new project where we are trying to connect all kind of research, clinical data, and socioeconomic data in Denmark. And then, of course, linking back to the presentation from Bruno, we want to connect all this data with all the different databases within Europe, with the genomic data infrastructure, and of course, the European health data space. Done.
Thank you. Thank you very much. Thank you. No, I think you made some quite a compelling argument in terms of the benefit for patients to get to have access to whole genome sequencing. So I also wanted to ask you a quick question. So I know there were a lot to mention and you couldn't cover everything, but just in terms of balancing ethical framework or safeguards, how do you implement those to make sure that you can balance the use of genomic data for personalized medicine with potential concern? You mentioned a little bit maybe about privacy and also equitable access.
Yes, thank you. So yes, I couldn't cover everything. As you said, we've put up this committee on patients, citizens and ethics, where we discuss these issues. And then we also made like a huge setup, you could say, to get access to data. You need approval from ethical committee system, etc. And then also you cannot take data out of the infrastructure. Data stays in the infrastructure forever. But you can take out the analysis results, of course. And then, if you access, for example, variants, or you only have one, or rare diseases, etc., then you cannot take this out. Then you need to go back to the patient, even though they already consented. You need to reconsent for these specific cases where you have less than 5 of the same.
Thank you. So you do have those safeguards in place. I don't know if it works, does it? Yeah.
Yes.
Great. Can they still, I know they don't have a full golden minutes left, but can they have 30 golden seconds maybe to do a quick sum up of the key message that you want people to leave with from this session? So maybe we could start with Maurizio.
Well, newborn screening has been a revolution. It can be even more now that we have therapies, we have diagnosis. Of course, we need to study in order to understand better even the evolution of the disease. But it is something that you cannot renounce and you cannot go back now that we have so many good results and a good future in front.
Thank you. Felipe?
Well, I think that all this technology is amazing, but we had to fit it all in our healthcare system, especially in the centers with more expertise, a clinical tool.
And is Bruno still with us online?
Yes,
Great.
I'm here, yeah, here. Yeah, so I just want to say that I think we have the opportunity to do something great if we really, work together. And we've been working together with a lot of our European colleagues, with our Danish colleagues as well, very closely actually. So we're very grateful for that, and we hope that countries will join us in funding the EDIC and in making their data for secondary and primary use available for the greater good.
Thank you, Bruno. And Lene?
I think I can only echo that. I think data sharing, data sharing, data sharing. I think this is definitely key. We need to make sure that we share across borders, and this is the only way we can make this better for the patients, especially within rare diseases. So we need to make sure that this is possible.
Great. I think we heard. Thank you very much again to our 4 speakers, and thank you to the audience. Thank you.
Thank you very much. And session 5 was moderated by Virginie Brosfet. Thank you very much. We don't break for coffee in the afternoon sessions, so if someone is desperate for a few sips of fresh coffee, just please go to the lobby and suit yourself. We are going to session 6 now. This is about patient data as fundamental element in addressing the needs of patients with rare diseases. And this session is going to be moderated by Hélène Leborgne, Policy Officer, Unit Health Innovations and Ecosystems, Directorate General for Research and Innovation, European Commission. Floor is yours.
Yes. Thank you very much. Does it work? Yes, it does. Thank you very much for the kind invitation. I come with my speakers, so if Holm wants to join us, please, so that we don't lose time later on. So indeed, it's my pleasure to be with you today. And thanks to the previous panel for having warmed up the whole audience about data sharing. Of course, data is important everywhere. In rare disease, it's important for care, it's important for diagnostics, it's important already at the start, so newborn screening. It's important to develop new treatments, and a tool to do this are, for example, registries. So we have registries from the European reference networks. We have heard about national registries. There are many other registries from the professional societies, scientific societies, the learning societies at international level, at local level, regional level, all levels. So we understand the whole challenges around rare disease data. We have opportunities as well. So we wanted with this panel to try to build upon these opportunities while keeping in mind all the challenges around data. So I will introduce my speakers one by one, and I will check as well if our colleague working at the parliament, member of the parliament, Tomislav Sokol, is connected online. Yes, he is, thank you. So we'll try in this panel to have a debate afterwards. So I gave the tough mandate to my speakers to speak 6 minutes each, and then we'll have questions. So I will start with Tomislav, since you are connected, and then we'll continue with Holm and colleagues. Thank you. Tomislav, the floor is yours.
Thank you very much. Thank you for inviting me to this conference. I think it's very timely because you know that recently, finally, EHDS regulation was adopted, even though the political agreement was made a year ago. I was the main negotiator on the part of the European Parliament, so I know that it really took some time. It wasn't easy, but what we wanted to do was really to finish the negotiations before the elections, because we knew that if we postpone this, if we delay this, that probably we will have to wait for several additional years. And the complexity of the whole thing is proven by the fact that it took almost a year after the political agreement was adopted to actually finally adopt the final text. So as you know, EHDS has two dimensions. One is primary use of data, the other is secondary use of data. Primary use of data obviously relates to use of data by healthcare professionals to treat patients. So digitalization and creation of electronic health records, common European health record, which obviously means for the patients that when they go abroad or when they go to another hospital, another city, even within their own state, the doctor will be able to access their health data much faster, see the whole medical history, see whether they have certain allergies, that taking certain medications, etc., with the idea of providing much more efficient and faster healthcare without any duplication, without overlaps, without repeating certain diagnostics tests, etc. But I think secondary use of data is probably more in focus, and that has definitely been more controversial when I speak about the whole topic. So secondary use of data, obviously, as was already said in the previous panel, means use of data by other persons than healthcare professionals for other purposes than the actual treatment of the patient. So this can be for research, this can be for policy making, this can be for various different reasons. So for us, what was important first was to make sure that the concerns that existed among the public, many stakeholders, etc., that this data could be misused, that this data for secondary use could be taken, for instance, by big tech companies to use it for social media profiling, etc., are misplaced. And to do that, first we define in a very narrow and concrete and specific terms the purposes for which data can be used. So the idea was to make sure that this can only be used for public interest and not for these kinds of other purposes that like big tech companies use, etc., etc. So this was the idea, to really make sure that this can only be used for public interest purposes, public health research, etc. Of course, the second important question was how to build the trust in the system and how to protect patients' data and their right to choose. And obviously, what is important here is that we have that when we speak about data to be used for secondary purposes, we are speaking about anonymized or pseudonymized data. So we are speaking about data which should not be used to identify individual patients. And this is explicitly stated in the regulation itself, that that it is not allowed for secondary use of data to lead to identification of individual patients. So the whole idea is that somebody who wants that this data will be cataloged, systematized. All the data sets that are lying around in hospitals, research institutes, etc., will be cataloged, systematized. These catalogs will be made publicly known. And anybody who wants to, for instance, do research on this, for instance, if you are a researcher in Finland who wants to do research on pancreatic cancer and sees that there is a useful data set in Rome in Italy, they will be able to make a request to Health Data Access Body in Italy, the public body, right? And this, if this body determines that this researcher fulfills the requirements, they will be able to access data in a secure environment. So it's a secured environment. They can only do research for the specific purpose for which the request was made, and this data cannot be downloaded and taken outside of the system. So again, the idea is to have all of the safety instruments to protect patients, to protect their data, and also to make sure that data cannot be misused. What is also important here was for us that we also give the patients right to decide. This was not in the original proposal, so essentially there were only references to the GDPR in terms of consent, etc. But this definitely made the whole thing unclear and uncertain, because you know that in different member states you have different interpretations of the GDPR, so definitely we consider this to be a problem. So this is why it was very important for us to have a harmonized so-called opt-out, so that we have an opt-out that patients can decide can get to decide that the data will not be used for secondary purpose. But it was important for us that it was an opt-out instead of an opt-in or a consent-based system, because we know we have the studies which show us that with an opt-in or especially consent-based system, where you will have to give consent every single time if somebody wants to use a data set with your data, that in these kinds of cases we don't get data which is useful, we don't get data which is representative, we get data which is biased. So with an opt-out we try to balance on one side the need for patients to decide and to have clear rules, but on the other that you also get data which is useful and representative. What was the big challenge there is that member states, the council, started with a position that they wanted to have essentially the freedom, the autonomy to decide in their own individual legislation about whether to have an opt-out or not, and when they can bypass the opt-out. Of course, this was unacceptable for us in the European Parliament, because we insisted that we need to have a common European system. And if we allow individual member states to have a discretion to decide when an opt-out can be bypassed or not, then essentially it would mean that we would have patients with the different rights depending on the member states where they live in. So for us, this was unacceptable. So we insisted to have a harmonized system, the common mandatory system across the European Union, and we were able to succeed in the end. But now, if in case of some emergency, public health crisis, pandemic, etc., member states could bypass this opt-out limitation, but they have to justify it. So they don't have a discretion, but they can only do it in specific circumstances where they need to protect public interest, public health. This justification is subject to judicial review, so National Court, the European Court of Justice, in the end, etc. So by doing this, we made sure that we have a harmonized system, but then in exceptional circumstances, this can be bypassed, but then this needs to be justified.
Thank you. Sorry to interrupt. I think
if I can just 20 seconds. So this was our main approach. We were able to succeed in this. Now the crucial question is implementation. So we have to prepare the system, healthcare professionals, patients, and the whole public. So we need to build trust in the system. We need to build infrastructure so that all member states have the same playing field. We know that now that is not the case. There are big differences, and I think this preparation in the coming years for the implementation of the HDS will be crucial, so that we get the trust in the system, that the system is up and running when the final stage of implementation expires.
Thank you very much for the snapshot into the sorry. Indeed, thank you very much for the snapshot into the preparation of the European Health Data Space Regulation and also the challenges ahead. And actually, we'll have also the national view from a Finnish colleague to tell us more. If I can just call now Holm Kressner, who is coordinator of a European Reference Network on rare neurological disease, but also involved in the Jardin joint action, you heard about it, but also in the diagnostic workstream of ERDERA, because we all know in rare disease, care and research are closely interrelated, and that's very important to keep the continuum going there. So, Holm, the floor is yours. Please tell us about the challenges you see in patients' registries.
Yeah, thanks a lot. So is it working? Yes. Yeah, it does. Okay. So it's a bit of a break, and we get back to the European Reference Networks, which have been mentioned quite a bit already during this conference. And I wanted to thank you for the invitation, and also for the organizers. Thank you very much. So the title of these slides I have is Patient Registries and Data Sharing in the ERN Environment. And I would like to start with the last bit, so with the ERN environment. So what is actually the ERN modus operandus? So it all starts with patients, of course, and then we would like to address and understand care inequalities which are in place in Europe. And that relates to information, to diagnostics, to care management and therapy. And I wanted to give you one example. And the example is that we're just doing a cross-ERN mapping on the availability, on access, clinical decision-making, and diagnostic screening regarding genetic therapies. So then, we would like to design intervention to actually improve, to change the situation. And we have the ERN toolbox at hand, and Donata Maroni presented the ERN toolbox already. So we have cross-border healthcare, CPMS, we have training education, we have ERN registries, we have guideline and clinical decision support tools, care standards, and we have dissemination and communication. By using this toolbox, we want to achieve improved care equality in Europe for the respective patients. And of course, we also want to measure the effect of the intervention we introduce, and if necessary, adapt to the interventions we have introduced. And it comes to no surprise that one of the two things we have in the toolbox are ERN registries. So Donata also mentioned that we have set up ERN registries, and we have ERN registries for all of the ERNs. So we have, and that's the number stemming from October last year, 81,000 patients in the registries. There are more now, so there are close to 90,000 now, and they have been collected by all of the European reference networks. So the good thing is that all of the registries use one common data set. And one data element which is being collected by all of the registries is genetic diagnosis. And I get back to the example I introduced on my first slide. So now we can actually use the registries and ask care quality questions like, is a patient eligible? Does the patient actually have access to respective genetic therapy? And we can also ask research questions like, how many patients with a certain genotype and a certain clinical characteristics are there for trial planning? So feasibility questions. So I stay with research and switch a bit, but it's also based on data sharing being established by the European reference networks. And the use case I would like to go into detail is the systematic diagnostic research analysis, which we have been doing in SolveID. That has been a EU-funded research project and will be continuing scaling up in Adera, which we heard about already a bit and we'll be hearing much more about tomorrow. And in this use case in SolveID, we started to do a respective systematic reanalysis. And it was, well, at least starting with a quite large data sharing on which this research reanalysis was based on. And we did it successfully. We just submitted and got accepted a publication in Nature Medicine. And we could increase the diagnostic yield by 15%. So we're now scaling up. We're now increasing also the technologies, and we're increasing the number of disease codes being covered in Adera. And we will see how much we can actually increase again the diagnostic yield. But what I wanted to finish with is really the emphasis on data sharing. And my colleague from Denmark said that as well. So it's all based on data sharing. On this, actually, this bit is being based on data sharing by means of the European Reference Network. Thank you.
Thank you very much, Holm, from this, again, snapshot, but into the real ERN environment. Now let's move from to another angle and perspective. We heard about the promises of the European health data space. We are also aware that implementation at national level might not be straightforward, so we'll ask our colleague now, Joni Kamulainen from Finland, to tell us a bit more on how the things are prepared and look like in the future and from your Finnish perspective. Thank you.
Okay, thank you very much, and thank you very much for this opportunity to come here to talk about ESDS and our implementation stages and, of course, rare diseases in Finland as well. Thank you for the Polish presidency for arranging this and all the other organizations. We heard from Mr. Sokol the essential content from the ESDS, and is everything clear to you? if it's clear, I would be happy that everything is clear, because it's not clear even to me, who took part in negotiations in the Council Working Party, of course, along with, for example, Enrique. So we have done a lot of work, and finally we have the regulation, and we can start to implement that. Possibly why I'm here is because we have had similar legislation in Finland for a long time regarding primary use and secondary use. So it's like almost a spitting image of the Finnish regulation. Here's some details regarding rare diseases in Finland. I would imagine it's small print, but many of the things in that slide, and I won't go into details here now because we have limited time to use, and I will be more concentrating on the ESDS and implementation, especially if there's a special need for a special approach regarding rare diseases. And I would imagine the answer would be, people would be nodding, yes, there is. But I would get to that. But similar problems probably in all of the member states. So those are the statistics regarding Finland, and I would imagine we have the same challenges in each and every country. And the cooperation is the key, and data is a goal for treating and researching rare diseases. And of course, we have to advertise that we have an active role in many different initiatives that have been mentioned today. Regarding the ESDS, of course, in TERAS 2 joint action, which is sort of secondary use part of the ESDS regulation. And of course, the Bruno mentioned 1+ million genomes initiatives, and I've been working on legal challenges regarding that as well. And we certainly agree that patient data is a fundamental element in addressing the needs of patients with rare diseases. What we have done, actually, I don't know if other member states did the same thing. We did a bold thing that when we were actually doing a negotiation in the Council Working Party, we included in our pre-rep meetings experts regarding rare diseases. And we got some valuable information. And some of the negative comments that we have raised in the meetings as well, thanks to the rare disease researchers and physicians who are treating people with rare diseases. So we took them aboard, and that was a key thing as well. Regarding the implementation in Finland, we have a steering board, and we established already in March of 2023. I'm the chair of the steering board, and we have taken on board the agencies and well-being researchers and other stakeholders, of course, including rare disease experts, and it took them on board in the implementation process of the ESDS in the different working groups that we have. We have one working group for primary use and one for the secondary use, and we have actually architecture work, and we have 2 project managers as well regarding primary and secondary use. And I'm leading the whole thing as well, apart from actually writing complementary legislation. So the obvious answer, yes, there's a need for a particular approach for the implementation of the ESDS. And my key message would be positive discrimination is actually needed in the case of rare diseases. So based on our implementation of a pretty similar model as the ESD is going to be, we have learned that it won't be a walk in the park to implement the ESDS. But you can certainly learn from the grown-up pains that we have had in the implementation project. And because of our experiences, we feel that we are quite ready to implement the ESDS. Some of the things we already have in place, so we don't need to do anything. Some things just need to be fine-tuned. Of course, ESDS, and of course the use of AI will bring huge potential for researchers, developing of effective treatments, and of course optimizing healthcare planning for rare diseases. But I think the challenge regarding ESD is that one size doesn't fit all. We have excellent legal packages coming already in place from the European Commission. And we have lots of different initiatives, but we have lots of different regulations with different kinds of processes. So that's the challenge. How do they interact? How do they work together? How do we actually share data between different models that are in different regulations? Challenges regarding rare diseases in anonymization is very difficult. Especially anonymization of genetic data is very challenging. And of course, the AI adds another risk layer for re-identification. I'm the chair of an expert group tackling with this sort of problems regarding anonymization, pseudonymization, and re-identification. Trust is the must. We need to have safe and secure environments that are in the ESDS regulations, that they actually work, that are the safe and secure environments that where we can do rare disease research. Of course, not just regarding rare diseases, cost will be a challenge. There needs to be incentives to support the research and treatment of rare diseases. Maybe a complete cost exemption for ultra-rare and novel rare diseases. And just one point more. I would say it is vital to include rare disease researchers and patient organizations in the implementation of the ESDS. Thank you.
Thank you very much, Johnny, for sharing frankly your national experience. And indeed, it will not be a walk in the park, but it's better to be aware that it will not be. Now I will call my last speaker, who is a colleague from the European Commission. So we also wanted to emphasize that actually you see here DG Santé, DG Research and Innovation, DG Connect, which meant communications network, content and technology. We work together hand in hand. We have different services, working on different focuses, but we work together for the rare disease community. And it should be clear to you as it is to us. So I'm very glad to have Simon with us. So you will tell us about the opportunities of data technologies in rare disease. And of course, I'm sure you will also tackle artificial intelligence, which is a buzzword at the moment. And we also found a lot of actually research projects in the field of rare disease, including AI elements, which we hope one day will materialize also in healthcare systems. We might not be yet there, but okay, I leave you the word now. I'm just a moderator, not the speaker. Thank you, Simon, for joining.
Dzień dobry, witam.
Good afternoon. I would like to welcome everyone who's been persistent enough to stay with us.
I am privileged to be the last speaker in the last panel. So thank you very much to all those who are patient and persistent to stay in the room until now. And indeed, I represent DG Connect, which is the technology department of the European Commission. And thank you, Hélène, for this introduction that exactly corresponds to the way we see the collaboration between the different departments in the Commission contributing to the same goal. And this first slide, it's a pure coincidence that Hélène introduced me in this way, shows why. Because we understand a certain logic that you need to pull the data, to leverage the data, to read and use the data and the expertise around the data to enable research advances and to then eventually benefit the patient in the healthcare implementation in any domain, of course, rare diseases as well. And this slide has been with me over the many years that I have been following the 1/million genome initiative. And I always show the same slide without any change because it really shows the logic and how we work together. And with the three blocks, DG Connect, DG RTD, and DG Santé, we work hand in hand. I will not talk about EJPRD and I will not talk about ERDERA. I have these slides to show that using the data in the rare disease community has been simply something obvious, that this is really a community that has been data savvy, that has always promoted and was aware of the potential that lies in the use of data to benefit the patients. So we have, the Commission has been supporting these initiatives, ERDERA, EJPRD, There have been platforms developed that help rare disease patients. From the side of DG Connect, we also support some other data infrastructures that also contribute to these goals. 1+ million genomes, you have heard already from Bruno Rodriguez. Cancer imaging is maybe not directly relevant for some types of cancer, certainly, but maybe less so. Virtual human twins initiative, you might not have heard about it. It would have been a topic for another intervention, maybe. It is, in very simple terms, about computer modeling of a human body, and to model and present visually and in terms of numbers how the body would have developed if you trigger a certain process in the body. It's about mirroring physiology with a numerical representation. That's something that has a great potential also for rare diseases, where you can model, simulate the behavior, the physiology of a patient, for example, by giving him, her a certain medicine. And the European health data space, of course, with its technical infrastructure aspect. All of these initiatives and all of the previously mentioned ones will contribute to the data pool, to the data capital of the European Union, and will be a basis for the future advances of future technological approaches like artificial intelligence, digital twins, and modeling. It is a very fresh news of yesterday that the European Commission published a new document, a very, very high level and far-reaching strategy about use of artificial intelligence. I will not talk about the content here, about the details. This is a policy document, but it is really to invest in data is one of the priorities of this strategy, and that's why I'm today talking and promoting the idea of investing in data generation, in data use. I found this graphical representation within the AI continent communication of yesterday, and I noticed, and that was not triggered by us, that healthcare is included as one of the key sectors, strategic sectors in the public sector, in this house of those sectors and areas where artificial intelligence has the most evident potential. I would say that we could also put under industrial sectors the pharma sector, which directly collaborates and serves healthcare, and under science, obviously life science. In all of these aspects, artificial intelligence represents and presents wonderful opportunities and potential. Just to maybe for you to remember from this graphic also that the European Union will invest huge amounts in establishment of AI infrastructure across Europe. And the AI factories, there are now 13 of them selected. To be noted, out of the 13, 11 mentioned that health and biomedical research would be on their plate as one of the priorities. So really huge infrastructures, huge computing potential will be within the reach of research for life sciences. A lot has been already done in the previous research programs under Horizon mainly. These are just a few examples of many projects that are exploring the potential of data in rare diseases. These are potentially, so these are new projects. All of them are still ongoing. And they represent some specific applications of artificial intelligence and simulation to rare diseases. I don't think I have now the time to comment on all of them, but importantly, of course, as in every application, there's always opportunities and challenges side of it. So opportunities is really that artificial intelligence can help patients, can make a diagnosis more accurate and quicker, more personalized. artificial intelligence can support the development of new drugs, and it can also help in the interaction between the patient and the healthcare professional. But there are, of course, also challenges, and they are not tiny, they are really important. I would start with the data access. Here it is also about data availability, especially in rare diseases. The issue is, of course, the data scarcity, because there are not many similar patients, especially within one country. That's why we support so much European collaboration here. And then also the legal aspects of the data access that we are also trying to solve. European Health Data Space also gives a contribution to it. Then the issue of ethics and trust. Ethics, of course, not as an obstacle, but ethics as a real requirement and fundamental right. That we have to pay attention to the sensitivity of the data, to the rights of the people, to the information that we give to the people, and only then we can really enable this data sharing. And also a very important challenge is always how to go from research to healthcare implementation, how to translate all these very good projects with very promising results into application, into real benefits to patients. Thank you very much.
Thanks a lot, Timon, for this also snapshot. Again, you couldn't say everything, but into opportunities for data in the rare disease space. It's true that we are living exciting times, not only because of the international context. I think at European level, with the new Commission, we also have impetus for new stuff. We have in preparation a Biotech Act, a planned European Life Science Strategy, to which, by the way, you can contribute by having your say until next week. Go ahead. So we thought it's very important to put these elements of what is ongoing now, also in the bigger context. Let me now, unless there is a burning question from the audience, but I would understand, yeah, Ruth, okay, then maybe. So sorry, but I think a bit of life in our debate could be nice. So I'm sure Ruth will entertain us. Go ahead.
Sorry, I have an important plea, because all our ambitions fly very high for the future and we want to accelerate. Completely supportive of this, but there's one little gap. I think there's not enough attention, because I'm not sure if everybody knows that currently, if you open a registry, you have to go for ethical approval in each and every single institution. This is a catastrophe. It's work intensive. That means, for example, just in pediatric cancer, I have all the European registry built up with European support, but need to go to more than 400 individual institutions to have a chance that anybody registers into this very smart built registry. Please find a way that we can go in registries with a single national vote if we have to go to an ethical committee at all. But help us to get away this institutional registry solution. This is a major slowdown process, and if we don't have more patients in registry, it's for these very reasons. Thank you very much. Please guide us and help us.
Thank you, Ruth, for the point. Of course, it's something we know well, and that's also why we have developed a consent form within, for example, the ERICA project, which was coordinated for the 24 ERNs. But I see there are other reactions. I don't know if we want maybe to gather all the questions and then have the panelists helping to answer. You wanted to ask also. So yeah, we want to help you, but there are things we cannot change. So it's something where we need your help to help you, actually. So maybe we can ask also our MEP and colleagues at different levels to support. So please.
Good afternoon. My name is Agnes Chair. I represent European Economic and Social Committee. I have only a very short question. What about the intellectual property right using the data? It's a very sensitive issue as well, not only the ethical side. Thank you so much.
Shall we gather one more question, or no? Okay, the hand is not more raised anymore. Who wants to support? I mean, I had also a question for my speakers that includes the challenge you have to overcome, also in the consent form. So the hurdles, how can, for example, the European Health Data Space maybe in the future support, or what can, is our MEP also still online? How do you think our European Parliament can support also these efforts? Do we see solution there? Light is coming. Mr. MEP, you want to help answering some of the questions?
Yeah, on the ethics part. So this is definitely a major issue. I'm not certain to what extent we can harmonize this on European level, unfortunately, because this is something that many would say that belongs to national competence. So ethical questions, things like that. I mean, we have similar situation when we speak about clinical trials, but I'm definitely in favor of finding some kind of harmonized solution to have one-stop shop instead of many. But definitely this is something that we also need to see what will be the obstacles from the point of view of the member states because of the division of competence. So I'm not sure whether we will be able to do something in terms of regulation on the European level.
Thank you for trying to answer still. Before passing the word to Yoni on this point as well, I would like to propose also something. You heard that within ERDERA, or you will hear again tomorrow, that we have national mirror groups which are supposed to support national efforts. And I think if you have burning issues in the rare disease space, including on research aspects, and registries are basically also in research, you might raise this point there, because this might be a tool to support you to have the national concern form endorsed there. So this would be a proposal from my side, because we cannot deliver you all the solutions. Well, there is a solution there. For example, the consent form agreed across different hospitals thanks to ERICA project. Maybe if you manage to have it endorsed with the health and research ministries embedded in the process, it could help. I see also Anne-Sophie nodding, so I hope France, for example, could give the example. Ruth, you want to answer?
Just very quickly. I think it already would be helpful if we get a national vote on the registry and not individual institutional votes, yeah? Because this we had in the clinical trials before, yeah? So I'm not trying to overrule ethics at all. It would respect the national level of ethics, but just one national-wide vote, yeah, per trial.
Looking
to that solutions. Already would help enormously.
Yeah. How do you see it for Finland, for example, Joni?
Thank you for the question, and you have raised a very valid question. And like Mr. Sokol said, that there's a challenge of how to address it on a European level. On a Finnish level, we mostly don't. If it's registry-based research, we don't actually need in Finland ethical committees. So that's the Finnish approach. But I can understand, the dilemma. I don't have a clear answer for that. I could have a clear answer regarding the IP rights and trade secrets. There's actually in the EESC, in the regulation, you have to respect the IP rights and trade secrets, and it's actually a collaboration between the health data holders who have the data sets and who have the IP rights and trade secrets, and the health data access body, who has to take into account the IP rights and trade secrets, so that the IP rights and trade secrets would not be revealed to whoever's the health data user research or whatever. So ESDS tackles that. But I can understand the problem regarding ethical committees for sure. But I don't have a clear answer on a European level. I could have an answer on a Finnish level because I'm the legislator in Finland.
Just a very quick answer. We had a survey out, very recent, asking to all the institutions, also on the national level, do you need an ethical vote here, for example, our ESCP registry? 90% said, yes, we need to go for the ethical vote. Yeah, so I think I'm not even asking for going without an ethical vote, just simplifying the process to get rid of the institutional obligation that each and every participating institution has to run the ethical process. And you get an array of ideas what you should change, yeah? And you're losing time endlessly. Thank you.
Yeah, maybe I can underline that. It's an experience we collected in the EN R&D. So we have actually data sharing agreements in place with 50 institutions, and it took years, so more than 5 years actually to get those into place. And I think you all know that what we do in the ERNs is based on collaboration, collaboration, and collaboration, and it should be supported by and enabled by data infrastructure, and data regulation. But at the moment, we also face the situation that it's actually blocked and being hindered by data regulations. So please change that so that what we do in the ERNs, and I think we saw that we actually can provide really added value to patients, is being supported and enabled and not being blocked.
There was another question, so I think anyway we have time, the official time, but let's go ahead with questions. Yes.
Good afternoon, Robert Rogowski, Keynote. Great discussion, and there is also a lot of hope toward the EHDS and possibility to use the data. But I think that many people will share the opinion that once we get this data, there is very, very common problem with the quality of data, also including the data that we have in registers. So tomorrow we have the session about this. Feel invited to join, but I have a question regarding especially the Finnish experience. That of course we understand the necessity to collect high quality data, especially the data from clinical practice. But on the other hand, if we ask doctors or medical staff to curate the data, to spend more time on data, they will have to dedicate more time to these tasks. So what's your secret sauce how to get high quality data? Because we know that you managed to do that, but in the same time not to put additional burden on medical professionals. Maybe you have some good practices here.
Thank you. That's a good question. I've been back actually thinking about it quite a long time. My general answer would have been, okay, we have been doing this since the 1950s, and that's why we have high quality data. And it takes a lot of effort from the doctors and so on to register the data. Yes, it does. In order to have structured data, you need to do the basic work. And unfortunately, it means a lot of effort from the doctors. That is away from treating the patients. But actually at the moment, what we're doing in Finland, we're using AI to help with the registering of the data. So they're doing the structured data, and the doctor's job is just to check if it has been done correctly. So we're using, in the registering part, AI, and we're using actually AI when the data has been gathered for secondary use purposes as well, to even enrich it. And in the ESDS, there's actually a possibility for the enriched data as well. So we're even thinking of using the enriched data and delivering back to the health data controllers and using AI for that as well. So, but you need to do basic things. You know, you can't have high quality data if you don't do the job that needs to be done in the primary use situations, unfortunately. But use the AI. We have good experiences using that.
In addition, I mean, data collected is often collected for one purpose. Can be clinical trial, can be something else to learn about the epidemiology of the disease. And then sometimes or often it has been the case that you didn't think about regulatory purposes, about having the drug approved, and the data is not regulatory fit. So what we try to do is also, at least in EU-funded project, to push for having more data, let's say, already checked, discussed, and structured along the regulatory needs. So discussing with the European Medicines Agency, so that the work doesn't need to be redone and so on. So Holm, yes, please go ahead. I'm sure you have experience there as well.
Yeah, so I think the bright future is really the European health data space, but the present is informed consent. And all what we do as regards research in particular is based on informed consent. And then I think it really depends on what you actually cover by this informed consent. So I think also there a quality standard might help to make sure that all the points which needs to be covered are being covered. So we experience that if you have to go back and reconsent patients, that takes an incredible amount of time and resources. So I think there also might be an opportunity actually to improve on data sharing. And of course, it's being based on information. So patients should have the respective information and should decide based on the information. But then actually, based on that, the informed patient consent template the form they use should be as optimal as possible.
Thank you. I do not see any big burning hands being raised, so I think I would, instead of asking questions to my panelists, because we went into different aspects and we would have never finished to discuss data, and we will continue tomorrow to discuss data. So I will give you your 1 golden minute to tell us your take-home message on data opportunities and challenges. Please, shall we start maybe with MEP Sokol, who certainly is still online?
Yeah. Thank you very much. I think EHDS is a groundbreaking concept. It's one of those few occasions where we actually create something new on European level. I think it will be especially beneficial for patients suffering from rare diseases, because only 5% of them have a treatment. So this will create enormous possibilities for and enormous amounts of data that have not been utilized before for research, for innovation, for finding new medicines, new diagnostics, new treatments. So I think that we have an enormous opportunity. Now, the crucial thing is for the Commission to adopt all the implementing and delegated acts, so that all technical things and all things which are still unclear are resolved, that we have a strong enough funding from European level to support member states in building infrastructure, in providing information to all the stakeholders, to patients, healthcare professionals, etc., to prepare the system, and most importantly, to build the trust in the system. So currently, I think a very small number of people, even within the healthcare system, is aware of the HDS and everything that it entails. So we have to avoid a situation that in 5 or 6 years, when all of the important provisions are fully implemented, that we have people who don't understand what it is and how it will work. So we need to prepare, we need to build trust, and I think if we all work together, we can really do a lot. And I think for rare disease patients, this can really be a major breakthrough, and they are the ones who will benefit the most out of it, and this is why we need to get it right.
Thank you. Johnny?
I have actually a simple message. You know, we have all these different wonderful initiatives, including the ESDS. And now it's time to start implementing them. And how it will happen, the clock is ticking now, and soon we'll have to implement the ESDS and other initiatives. How to happen is to do cooperation. The lesson learned from Finland is the cooperation between, of course, health data users, doctors, patient organizations, health data holders who have the health data sets, and of course, HDAPs. And my message is as well, we need positive discrimination for rare diseases. They need special discrimination. Thank you.
Thank you. Holm?
Yeah, I think it comes as no surprise. So my main message is to strengthen the ERNs as an asset, as a European asset, and use them also with regard to data and with regard to primary data use, but also secondary data use.
Thank you. And Simon, last but not least.
Yes, so the new technologies need good quality data or high quality data. That is a very important message, but then it is also a task and a plea. Let's promote data sharing and data generation together. These are separate tasks. The RD community is very much supportive of data sharing. Also, patients are the most supportive among all groups of patients. And we need to really spread this message and the culture of data sharing to other groups of citizens to share this understanding. And also a plea to the policymakers. We need to invest in data generation, in genome sequencing, and in the omics technologies.
Thank you very much to all my panelists and for the audience for staying until so long. I think we still have a closing session, so we run away and leave you the floor.
Thank you very much. Hélène Leborgne was moderating this before last session, because indeed we have one more session, a closing session ahead of us. Ladies and gentlemen, please welcome Ursula Demkow, Under Secretary of State, Ministry of Health, Poland. Give her a warm hand. And Agnes Chair from European Economic and Social Committee. Please welcome.
So, is this working?
Yes, it is.
Can you hear me? We have good tradition with Agnes because we just two of us, we just were closing the conference in Budapest a few months ago, and now we are again closing a conference on rare diseases. And then we did like this in Budapest, so again like this in Warsaw. Okay, if anybody from Denmark is here, please join, please come, because we have to pass the baton to you.
I would like to involve Enrique Terol.
And Enrique, we love you. Come here. Then we are complete. So before I will close the session, during this conference, I was making notes just to underline, to draw some conclusion by the end of the conference, because we are still on the way since 2004, let's say, till 2025, but still many decades in front of us, so we have to just conclude where we are now. And if you allow me, just I will read what I just noticed, what you have said, and what is the main, the most important messages for our conference. First of all, rare disease, orphan disease, are very challenging area of medicine. Every country needs an action plan for the rare diseases specific for local patients' needs and available resources. But we also need a common European plan to strengthen the effort of every country to assure that every patient, regardless of the rarity of their disease and regardless of the country of origin, should have easy access to fast, innovative and reliable diagnostics and the best possible medical care. We consider that it is important to adopt a Europe-wide policy framework on rare diseases. The European plan should pay attention to diagnosis, care, treatment, but also to education, research, social support, mental care, and inclusion. Expansion of ERNs plus new financial plan is also necessary. Training of workforce with particular emphasis on primary care of doctors is very crucial. To raising the awareness of rare diseases and recognition of rare disease among the society at large is also important. We should improve patient pathways and referral mechanisms. Then pointing to the last session, databases, registries, and their integration within European health data space are very crucial, and responding to comments from Ruth, I would say the data is very valuable as gold or oil, but not the share on the market now. And then therefore we should really care for the data because they are a source of very important information that could transform the healthcare policy. We have to share innovation and we have to support the research. Very crucial is implementation of ERDERA.
Very important is also to creation innovation hubs. And I especially like the virtual twins which can mimic the real organism. We should support the underrepresented country, especially those which have no action plan for rare diseases, because then they should join us. Public-private cooperation should be accelerated. Moreover, we have to create incentives for pharma and biotech to encourage them to invest in rare diseases. It would be great if you could create a joint purchase mechanism by a group of countries with a single manufacturer, joint negotiation and purchase of the drug, and joint assessment and monitoring of the effect of the implemented therapies. We should also discuss the period of market exclusivity and incentives to eventually shorten them. We have to facilitate patient access to drugs before they are reimbursed and facilitate clinical studies. We have to also to ensure ethical sharing of the data among different stakeholders and implement EHDS. We need also regulatory framework on every level. And we are just about to finish the high-level conference, but we need some lower-level conference and meeting in smaller groups to extend our work and to deeper the discussion. And then the title of the conference is, the motto is toward an EU action plan on rare diseases. So we should forward to our EU disease action plan, which will make Europe a leader in rare diseases. And by the end, I would like to thank you, those who helped to organize this conference, especially to Patrice and Ekes, to Małgosia Bogusz, to Jarosław, who was great monitoring, to my people from the Ministry of Health, to Dominika Janiszewska-Kajka, to Ania Leśniewska, she is just show yourself, to Małgosia Probosz, to Paulina, my secretary, who was making 9,000 copies of certain paper just last night. And then we have a decades of work in front of us. And the good news is that we start just tomorrow. We move to the building the next door, and those who do not have plans today, just please come tomorrow and we will continue. Thank you very much.
Good afternoon. First of all, rare disease patients, because we are here for them and for their family members. And I would like to invite Virginie, and I will stand up, and please come with me, because Donata, without the commission, we cannot make anything for the patients. Please sit down. Please sit down. Virginie, representative of Aerodis. Without Aerodis, we cannot make any step forward. Please sit down. Please, yes, please sit down. And many, many thanks, all of you, to be here. And first of all, the Polish presidency. And let me thank the European Economic and Social Committee, and special thanks to Enrique Terol, who is the behind engine. Thanks Bajba Miltovica, the 10th section president, Beatrice Porres, head of unit, Agota Bajic, and Daniel Makai, sorry, for our side, for our Economic and Social Committee side, and our colleagues who are here from the different 27 member states, because without European Economic and Social Committee, we cannot be here. And thank you so much, the Danish presidency. There will be the next one. coming back to the Polish presidency, it's a great success in our life. And let me thank Commissioner Barhey, because he told at the 4th EU Health Summit, I try to cite him, together we can reshape the future of health in Europe. We are here for this together. And let me tell you something. Sorry, I try to find my minutes. Yeah, thanks. Information is power. Data is information. So that's the reason are really very important issues, the ethic and the intellectual property rights, when we work with data for our patients. And I would like to ask you to protect our proposal to make the 2026 year for the rare disease patients. I spoke about this in the European Parliament on the Day of the Rare Disease Patients on March 5th. So, may I ask this plenum to work together for this, to achieve our common goal, the EU Action Plan for the Rare Disease Patients. And you know, I don't want to go into any details. Why? Because today we have to learn that we have a treasury box. Which type of treasury box? First of all, full with goodwill, lot of knowledge, information, a lot of excellent persons, academics, health and social workers, NGOs, and we have institutions, but they work for us. So, how can we go ahead? Hands in hand, and we will make at national level and EU level together the really very, very good action plan for everybody. And let me tell something. We always speak about the 30 or 36 million rare disease patients. Please stop it. We should speak about 100 million European or any other citizens. Why? Because today we had to realize that rare disease patients cannot live alone without help. So that's the reason we should protect together not only the rare disease patients, but their family as well. In our opinions, you can find a lot of proposals, and I don't want to repeat it today, because that's the reason we are here, to change our knowledge, our experience for all. And many thanks again, and may I ask you to raise again our hands together for us. Thank you so much.
Thank you very much, ladies and gentlemen. As it was mentioned by Minister Demkov, we have another conference tomorrow which starts in the neighboring building in the Children's Hospital. It starts tomorrow at 8:30 in the morning. There will be many patients present, and there will be presentations made by them. As I said, it's in the Children's Hospital, level -1. You are most welcome to join us at that conference. Thank you for today, and have a great evening in Warsaw. Thank you.